ಕೊಟ್ಟು ಮತ್ತೆ ಬರಕ್ಕೆ ಬಿಟ್ಬಿಡಿ ಟ್ಯಾಬ್ಗೆ. ಓಕೆನಾ? ಎಂಡ್ ಸ್ಟ್ರೀಮ್ ಕೊಟ್ಟರೆ ಹೊರಟೋಗುತ್ತೆ. ಸೊ ಏನೇ ಇದ್ರು ಜೂಮಲ್ಲೇ ಇರಲಿ.
ಹಲೋ
ಅನಿಶ್, ಏನೇ ಇದ್ರು ಜೂಮಲ್ಲೇ ಇರಲಿ.
ಹಲೋ
ನೋಡಿಲ್ಲ ಎಂಡ್ ಸ್ಟ್ರೀಮ್ ಅಂತ ಕೊಟ್ಟರೆ ಹೊರಟೋಗುತ್ತೆ.
ಅಲ್ಲಿಗೇನು ಬರೋದು?
ಆ ಟ್ಯಾಬ್ಗೆ ಏನು ಬರ್ಬೇಡಿ. ನಾನು ಮೆಸೇಜ್ ಹಾಕ್ಬೇಕು. ಟೈಪ್ ಮಾಡು. ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಆಲ್. Welcome to Neuro-Oncology. Type ಮಾಡಂಗೆ ಸ್ಪೇಸ್ ಕೊಟ್ಟು. We shall start shortly.
We'll be live on.
ಅಲ್ಲ ಲೈವ್ ಇದೆ. So the program will start shortly.
Zoom ಹೋಗಿಲ್ಲ.
ಬರಾಯ್ತಾ?
ಚಾರ್ಜರ್ಗಳು ಹಾಕಿದೆ ತಂದಿದೆ
ಹಲೋ ಓಕೆ.
ಸಿವಿ ಬಂದವ ಬರ್ತಾ ಇದೆ ಲ್ಯಾಪ್ಟಾಪ್ ಬರ್ತಾ ಇದೆ
ಬರ್ತಾಯಿಲ್ಲ ಹೋಯ್ತು.
ಒಂದು ಸರ್ದು ಕೊಡಿ ಮೀಡಿಯಂ ಲ್ಯಾಪ್ಟಾಪ್ ಬರ್ತಾ ಇದೆ.
ಡೂಪ್ಲಿಕೇಟ್ ಬಯಸ್ ಬಂದಿದೆ.
ಎತ್ತಾಕಿ ಸರ್ ಅದು. ಹಾ ಬಂತು ಬಂದಾಯ್ತು. ಸ್ಲೀಪ್ ಮೋಡ್ ಆಗ್ಬಿಡು ಸರ್. ಅಷ್ಟೇ ಹಾ
ನವೀನ್
ಮೈಕ್
Good morning, everyone. Good morning, everyone. I welcome everyone to the Narayana Neuro-Oncology Symposium 2022. And to start the event, I would like to invite Senior Consultant Neurosurgeon, Department of Neurosurgery of Narayana, to come and start our event with his first talk. Dr. Komal Prasad.
Good morning, everyone, and welcome for this Narayana Neuro-Oncology Symposium. Thank you for coming and joining. We'll be shortly starting.
ಚೇಂಜ್ ಮಾಡಿದ್ರೆ ಏನಕ್ಕೆ ಬೈತಾರೆ ಬಂದು ನೋಡೋಣ ಬ್ರೇಕ್ ಟೈಮ್ ಅಲ್ಲಿ ನೋಡೋಣ ಮಾಡಕ್ ಹೋಗ್ರೆ ಏನಾದ್ರು ಒಂದು ಸ್ಟಾರ್ಟಿಂಗ್ ಟೈಮಲ್ಲಿ ಅವ್ರಿಗೂ ಟೆನ್ಷನ್ ಇರುತ್ತಲ್ಲ ಅದಕ್ಕೋಸ್ಕರ ಬ್ರೇಕ್ ಟೈಮಲ್ಲಿ ಅದೇ
ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಆಡಿಯೋ ಬರ್ತಿದೆ ಇಲ್ಲಿ ಮಾತಾಡ್ತಿರೋದು ಮ್ಯೂಟ್ ಮಾಡಕ್ಕಾಗಲ್ಲ
ಇಲ್ಲಿ ಮಾತಾಡೋದಂದ್ರೆ ನೀವು ಮೈಕಲ್ಲಿ ಕಟ್ ಮಾಡ್ಬೇಕು ಅದೇ ಹೆಂಗ್ ಬರುತ್ತೆ ಮೈಕಿನ
ನೀವ್ ಮಾತಾಡ್ತಿರೋದೇನೋ ಬಂತಿಲ್ಲ ಅದನ್ನ
ಇಲ್ಲ ಅದಲ್ಲ ಅದು ಬರಲ್ಲ ಅಷ್ಟು ನಾನು ಮಾತಾಡಿದ್ರೆ ಇಲ್ಲಿ ಚೇಂಜ್ ಮಾಡ್ಬೇಕು ಸರ್ ಇಂಟರ್ನಲ್ ಮೈಕ್
ಮಾಡಿದ್ವಲ್ಲ
ಮಾಡಿಲ್ಲ ಮಾಡಿದ್ರೆ ಬರಲ್ಲ ಇಲ್ಲ ಅದು ಯಾವ್ದು ಮೈಕ್ ಇದೇ ಇದ್ರದ್ದು ಹೋಗ್ತಾ ಇದೆಲ್ಲ ಓಕೆ ನೋಡಿ ನಮ್ಗೆ ಚೆಕ್ ಕಟ್ ಮಾಡ್ಬೇಕು ಮೈಕಲ್ಲಿ
ಅಲ್ಲ ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಬರ್ತಿದೆ
ಹಾ
ಝೂಮ್ ಅಲ್ಲೂ ಹಂಗೆ ಬರ್ತಾ ಇರುತ್ತೆ
ಹಾ
ಝೂಮ್ ಅಲ್ಲಿ
ಅದೇ ನಿಮಗೆ ಒಂದು 2-3 ಸೆಕೆಂಡ್ಸ್ ಡಿಲೇ ಆಗ್ತಾರೆ
ಅಲ್ಲ
ಅದು ಇಂಟರ್ನಲ್ ಮೈಕ್ ಬರ್ತಾ ಇರುತ್ತೆ
ಇದರಲ್ಲಿ
ಕ್ಯಾಪ್ಚರ್ ಕಾರ್ಡ್ ಎಲ್ಲಿದೆ
ಆಡಿಯೋ ಕ್ಯಾಪ್ಚರ್ ಗೊತ್ತಿಲ್ಲ
ಹೌದಾ
ಆಡಿಯೋ
ಹೇಗೆ ಗೊತ್ತಾ ಯಾವ ಆಡಿಯೋ ಬರ್ತಿದೆ ಅಂತ ಹೇಳ್ತೀನಿ
ಚೆಕ್ ಚೆಕ್ ಆಗಿದೆ ಚೆಕ್ ಚೇಂಜ್ ಮಾಡು ಡಿಜಿಟಲ್ ಆಡಿಯೋ
Check. Hello. Test. Check. Check 1 2. Hello.
ಹೋಗ್ಬೇಡಿ. Good morning again. Welcome to Narayana Neuro-Oncology Multi-Disciplinary Symposium on Management of Brain Tumors and NVSS Oration 2022, which will happen tomorrow. Thanks for joining us for this unique multidisciplinary meet where various different specialties who are working in neuro-oncology are getting together to explore what has happened, what is the update. Last 2 years were difficult times for most of us all over the world because of this COVID pandemic. In between this pandemic, we had a new edition from WHO about the classification of CNS tumors, which happened in 2021. And there was an urgent need for all of us, which was felt for many years. This new revised edition was pending, and it actually finally happened last year. So one reason why we got together was to update ourselves about how best we can reclassify this CNS tumors, gliomas in particular. And so much of advances have happened quite very recently in a rapid pace. And we will be working in our own specialties, neurosurgery, in their own silos. And we need platforms in which, like this, we come together to share what we know, because our ultimate purpose is the benefit of the patient. So with this objective, so we from Narayana Health, where we have a comprehensive department which has all specialties, subspecialties which are required for a comprehensive care of neuro-oncology is existent, and we are doing this for quite some time now. And we also have, not many places can boast of having a basic research laboratory within a multi-specialty hospital. That's an additional advantage what we have. We are blessed with a basic research team. So cutting edge research as well as state-of-the-art medicine, surgical, and radiotherapy facilities are available. And we thought we should take this initiative to get people together so that we'll update ourselves at this juncture. So I will initiate this proceedings by going through some of the challenges. We know, like, as I said, we all see with our own, it's like an elephant being described by a blind man, 5 blind men. So we will be seeing with our own senses, like what we have is the surgical tools. And what we see is the tumor and the brain live. We are fortunate. And we decided much ahead in our career that the way forward is to physically, we were of that nature that we wanted to go see physically, take it out and explore and make the people better. So that is neurosurgical aspect. Whereas underlying, we have all this recent classification, the astrocytoma, glioblastoma, the new classification, grade 4, ependymomas. So that thing we will not be, when we are dealing with the tumor, we will be more dealing with consistency. That's the key word in neurosurgery is consistency. Not many in other specialties will be hearing or noticing that word, but what matters in neurosurgery is like how the tumor is feeling and how we can suck it out or use QSAR to take it out to give a maximal resection. So as I said, like we will be seeing in our own vision, with our own goggles, how we are trained. And this objective of this kind of session is to see how everybody else is seeing and make a mental imagery of what exactly it is. I will come to that, how mind works. So basically, at the outset, we have to remember we are all healers. So we are here to make a person, a fellow human being better. And what are the levels of intervention we have? So this gives some clarity about where we are heading to and what work we are doing in this sphere, whatever we have chosen. So first is health promotion. So that is like the universal, what the government schemes will do for the general well-being of the person, be it meditation, be it exercise. So it's like basic underlying rule that we promote health with health promotion. Anything related to neuro-oncology here, we have no clue about it because we don't know what is the cause of most of the tumors, where we can, in general, promote health in general. Specific protection in neuro-oncology will be about specifically how we can avoid or postpone, or only if we know the cause, we can do that. Only thing we know is about ionizing radiation. We have to avoid Third World War. That's the only way we can specifically protect at this time. And other thing is about mobile phones, which we are quite clear now that we are not sure. There is some correlation, some studies show some correlation, that mobile phones can increase a bit incidence, but there's no causation. We are not in a stage in which even you can implicate, suggest. So we are hands tied, and here also we can't do much in specific protection. All of our efforts in various different specialties are concentrated on this third step, early diagnosis and treatment. So with MRI being available, we are recognizing GBMs in asymptomatic patients with one seizure and small lesions, small recurrence, and early treatment. So this is the third stage. Fourth is disability limitation. How we do that with surgical excision, resection, sometimes benign tumors, and avoiding seizures by taking out a meningioma, all that comes under disability limitation. Also, here we can consider molecular markers or any surrogate markers of tumor progression where we can detect tumor progression or recurrence early and then intervene early. That will also be a disability limitation in a way. And rehabilitation is an indispensable part, because like not everything has a cure, particularly when it is with brain, when it is middle with brain. So rehabilitation is an indispensable part of this whole spectrum. So we have chosen all these specialties who are, and this is the spectrum what we can see. So many, because it's in one slide, we should not assume any one of it is bigger or smaller. Each has its role. Oh, where is neurosurgery? Okay, neurosurgery is there. Even endocrinology, cellular tumors. Tomorrow we have a session on endocrinology. Neurology, about anti-epileptics. We have a talk on what's the optimal usage of anti-epileptics, seizure prophylaxis for tumors. Psychiatry, there are various aspects in which mind comes into play, both for the healer as well for the patient. Even we will be facing psychological issues when dealing with this information asymmetry. The patient wife is sitting in front of you, you see the scan, you know the fate, but they don't know. They are looking, staring at your eyes, and you are in a position, you have to, your work is to explain and diffuse slowly that information. So we have session on how to break this bad news. Neuroradiology, very indispensable. Lot of advances have happened. up to identifying IDH mutations using sequences of MRI, using artificial intelligence to read the scans. So that's the advances in radiology. Neuropathology is a huge topic which Dr. Vani Santosh will be talking just now. Medical oncology, pediatric oncology, which we were hearing earlier that we can use stem cells as an adjuvant after medulloblastoma. It's a reality now. Like we were thinking like it's quite far and sort of experimental, but it has become a norm nowadays. Radiation oncology, stereotactic radiosurgery, and our association with other specialties at the cusp where head and neck and skull base join, we deal with them together. We have a panel discussion on how we deal with these difficult tumors together because they have their own ways and the medicine grows at the cusp of two specialties. So be it head and neck, ENT, with skull base, with particularly the skull base region. So these are the other specialties which we work with. Even thoracic people we work with, like with their VATS, video assisted, this thing, the spinal tumors which come out of the foramen. So if they are there standby, we will be always comfortable. Most of the times we'll be able to take out, and sometimes mediastinal tumors they take out, but we'll be there as standby in case there is necessary. This is the multidisciplinary approach. Neuroanesthesiology, awake craniotomy gives us confidence that our disability limitation is satisfied and patient will be satisfied, and patients themselves asks and he sees in the monitor and says, why don't you take out that yellow part by the side? So this is how we have reached, and it has become a norm, and he's seeing his own tumor and he is guiding us, and I have to explain him, okay, that's looking normal for me. Neurocritical care is another thing which we have, which has a lot of advances, which has happened when we are like most of the systems, even for liver, there's a sort of dialysis in which we can tide over. We have ventilation for respiratory system. For brain, what do we have till the brain comes back to its normal recovery phase? This is where the critical care people will keep it like a baby, like a neonate like a fetus in the womb. They will keep in the ICU and tide over till the brain recovers back to taking care of its own. Physical medicine and rehabilitation, that's we all accept that it is indispensable, but we won't give that sufficient importance to that. So how it is relevant in neuro-oncology, we'll deal with. Endocrinology is, we have a session on that, both in cellular tumors, pituitary tumors, as well as in pediatric age group, at growing age, how best we can manage craniopharyngiomas, children, the stunted growth, when you give growth hormone, testosterone. So that's another session we have about how best we can manage. Dr. Purna Kurkure will be talking about this tomorrow, endocrine management of CNS tumors. Nuclear medicine, how best we can utilize this PET scan. It's not just to see the metastasis, multifocality, but they also guide us. Sometimes tuberculosis, we get confused in the spine, whether it's tumor or tuberculosis. So these are areas where nuclear medicine helps us. Molecular biology, I'm very happy to see people participate with the clinicians. And this is what is the objective, is to get together to see, not to, because it's a long journey, particularly when you see the tumors through molecules. And some days we'll feel like, are we doing a change? Are we doing impact on the eventual bedside? So these are the ones which will give you a satisfaction that we are here to reassure you that we are looking out for every other specialty, because we are dealing with deadly tumors with most of the times nothing else left in our hands to offer to the patient. Neurochemistry is another, which is now there is a blur between the specialties what we deal with. Pathology, histopathology, immunohistochemistry, PCR, molecular biology, neurochemistry. What's the borderline between these things? There is no border, so everything is merged. The sole purpose is this kind of intervention to make our lives of our patients better. So I will give some anecdotal examples as thought-provoking examples or concepts. This was Walter Dandy, who was equally annoyed with this relentless progression of gliomas. In 1928, he presented this seminal paper of 5 cases, not many, but 5 cases. And don't ask me what was the classification of glioma those days. That was just glioma. So then he decided, like right-sided tumors, why don't we take out the whole hemisphere? Because they grow, you take out and it grows in the border, in the edge. So he offered this surgery, particularly because he quotes that the patients asked that I don't mind having a paralyzed body, but I want to be alive. So that was the reason why he embarked into this kind of procedure. And he had 5 cases. And he explains what happened to them later. One died with an infection, one died with some other unrelated cause. But there were 2 recurrences. One was within 3 months period. But that particular case, it was going beyond corpus callosum and he could not resect the whole thing. That came back within 3 months. And the other 5th patient survived for 3 years. We don't know what's the grade, but he survived for 3 years, but promptly the tumor came back on the opposite hemisphere. It's not unusual, like it's not a scary surgery, like we do hemispherotomy with excellent results. The patient remains the same, and actually the hemiparetic, this girl with seizures got better and now she can dance now. This is for epilepsy, but the same surgery here, we get a recurrence on the opposite side. We don't have one cure for this deadly tumors. What happened in 1940s is this phenomenon which changed our objective of medicine. That's the discovery of penicillin. We are fooled because of this magic bullet which came and wiped out most of the infectious diseases. That is when humanity started thinking that we need to have, for one disease, one treatment, one magic bullet. That was serendipitous discovery which happens once in a century. But the expectations of humanity changed forever, that we need to find one molecule, one antidote against which we have to work on. So someday I will make out the whole, I will have a whole chart of the pathway of carcinogenesis. And I will focus on one medicine which is anti that, maybe an antibody or maybe a radiation. Or if not anything, hammer, you have scalpel, take out. No, cancer is not amenable for that because we are dealing with an unknown enemy here. We don't know the cause yet. Natural history is unpredictable. So always keep in mind about this Dandy's heroic surgeries, but for a real cause of hemispherectomies for glioblastomas. Our problem is like, we assume whatever we see is just an amalgamation of the cells put together. Like whatever is happening in a cell or a group of cells is something what we see. Like if we see it in a petri dish, if we see it in vivo in a tissue culture, the same thing gets replicated in vivo in humans who are alive and conscious. We expect multiple drops of water put together can be called as an ocean. It's not. Ocean means many more things in that. So this is one interesting article, not now, 1962. Smithers was a radiotherapist. So he had a large series of cases where he had astutely observed and recorded what has happened in that. And I want to read this out, like, the question is, can we really scale up? So these are the numbers. Human brain has 10 to the power of 11 neurons. That is 100 billion neurons, 100 trillion synapses. So what happens in a petri dish? Can we extrapolate to this number? You have to think. So this, Dr. Smithers gave this example about cancer as a whole. Cancer is no more of a disease of cells than a traffic jam is a disease of cars. He says, a lifetime of study of the internal combustion engine would not help anyone to understand our traffic problems. You all have faced the traffic, Bangalore traffic, the two in rains. The causes of congestions can be many. A traffic jam is due to failure of normal relationship between driven cars and their environment. and can occur whether they themselves are running normally or not. As we have many times observed, the traffic gets delayed when there is a policeman there or when there's a traffic signal is there. We try to put traffic signals. We try to put policemen there. Suppose in your wild imagination, you expect that you have a huge JCB machines which are parked there in the traffic lights, which will just take 100 cars and push it out of the way. Will it solve the traffic jam problem? We are aiming to kill those bad cells. Will that eradicate the problem of traffic jam? There is something else. So we come to the what we have. So because we have to consolidate and go together further ahead with new thoughts, new avenues, creatively thinking, keeping the patient in center. And this is where we are now. WHO classification of CNS tumors, 5th edition. And this is taken from the introduction to CNS tumors. In the after forward, this introduction, they very explicitly say that all classifications are imperfect representations, reflecting the state of understanding in a field at a particular time, as well as how that information is interpreted by a handful of experts. It's like our mobile phones, iPhone 12, 13, Samsung 10, 22, it keeps coming. Just imagine for a moment how WHO classification 10th edition would look like. If humanity exists, if there is no third world war, our children are going to see this. And just, we can't even imagine what will be there in that book. As of now, 5th edition is hybrid. The books are limited, it's online. 10th edition, I don't know, maybe it comes directly plugged into your brains. 5th edition central nervous system volume of WHO classification of tumor series like its predecessors should therefore be seen as a work in progress, as a stage in evolution. So this is the hype cycle of Gartner. So we see technology. When the technology triggers, anything new comes, maybe it is artificial intelligence in pathology or reading the scans, or maybe robots which help us in surgery. There will be a technology trigger and there will be a peak of inflated expectations. But it's bound to continue with a trough of disillusionment. And over time, there will be a slope of enlightenment and a plateau of productivity. Today, with the 5th edition, we are here at the Trignot, it's like triggered, and we have inflated expectations for that. Over time, we'll come to go through this phase of disillusionment, and then over time, we'll come to this slope of enlightenment. So then is the productivity which comes. And coming to neuro part of neuro-oncology is much more complicated. It's not like a soft tissue tumor, thyroid or breast or something in the periphery where you can amputate. We're dealing with a person here. I was just in the morning discussing about a patient where I had to break the news about his uncle that he is brain dead. So innocently he asked the question that can you transplant? Can you change the brain? Because you change every other body like a machine part, like a garage. So, but why don't you change the brain? So it was such an innocent question, but that let me think that is he there residing in his brain or is he beyond that brain? Like, because many times, like when we go and philosophically thinking, we think about consciousness as what is inside that, what is driving that, the driving force behind that brain. Brain is the car which we use. The driver is unseen. So our experience is generated by the brain. Fundamentally, brain is structured to generate a reality and function in that reality. And we are delving about why we can't solve this mystery of consciousness. And we go back to our ancient times where our Adi Shankara long ago, he has proclaimed that I am not my senses, I am not my body, I am not my brain. Beyond this, I remain eternally at peace and happy. I am indeed that eternal knowing and bliss, eternal love and pure consciousness. So this sets us thinking into what is underlying the driving force which works and makes things happen through our hardware of brain. To realize that hardware and software both are something which are tangible, which is there today, not there tomorrow. Beyond this hardware and software, there is somebody sitting and operating this. that does not need any transplant because it is eternally there. With this, some thought-provoking points about neuro-oncology, I welcome you again for this update on multidisciplinary management of brain tumors and NVSS Oration of this year. Thank you very much.
Thank you, sir, for the wonderful talk. I would now like to invite the chairpersons for the first session to please come and take their places on the stage. First is Professor Suresh Nair, Dr. Anand Balasubramaniam, and Dr. Parthiban. If you could please grace us with your presence and chair the first session. I would now like to invite Dr. Vani Santosh to give her talk on the 2021 WHO classification of tumors of the central nervous system, the key changes.
Good morning, everyone. Welcome to this lovely program and the first session. We had a very thought-provoking talk by Dr. Komal. And next we are going to hear from the horse's mouth. That is a part of WHO classification, whom she is Dr. Vani Santosh, who needs no introduction to this audience. But needless to say that her work in neuro-oncology over the last 2.5, 3 decades and contribution to the WHO classification itself. And she is member and contributing member in this classification and to this aim of classifying CNS tumors. It will be lovely to listen from her the key changes in the WHO classification. And we are thankful to the organizers for giving her the due time of 1 hour for this talk. And I leave it to Dr. Vani to proceed with the talk.
Thank you, chairpersons. Thank you, Dr. Anand, for that kind introduction. And let me confess that this is the first time that I have been given a 1 hour session in a clinical meeting. I'm certainly truly honored by that. And thank you, first of all, Dr. Hegde, Dr. Komal Prasad, for inviting me here to take part in this Neuro-Oncology Symposium. I've been asked to talk about the WHO 2021 classification of CNS tumors, and let us look at some of the key changes in this classification. Now, we know that accurate classification of CNS tumors becomes very important for clinical management of individual patients, for estimating prognosis, for guiding therapy, for the conduct and the interpretation of clinical trials, as well as experimental studies, even for the evaluation of population-based disease trends, and also the allocation of resources for healthcare support by governments and agencies. However, we should know that all classifications have to be periodically revised, because that would enable the clinicians to have a better understanding of the disease process, so that the patients with specific CNS tumors, they would receive the most optimal therapy. And moreover, that would allow for a more homogeneous population of patients to be enrolled into clinical trials, thereby facilitating the accurate evaluation of any of the novel therapies that are being tried in that clinical trial. Now, if you go back and look at the evolution of CNS tumor classification, as all of us are very familiar with, the earliest classification was put forth by Bailey and Cushing way back in 1926. And this classification was quite a popular classification. It lasted for a very long time until the WHO took over the classification of CNS tumors. And in the first 4 editions of WHO classification between the years 1979 and 2007, the classification was based solely on histomorphology, and later in the later classifications, it was supplemented by immunohistochemistry. But now we know that in post 2007, there has been an explosion of molecular data from which have evolved a growing number of molecular biomarkers with important clinical utility. And several of these were incorporated into the revised 4th edition, that is the 2016 classification that we have been following up till now. And this classification for the very first time combined morphology and genetics into the classification, which was not there in the previous WHO classifications. And that brought about a paradigm shift in classification, resulting in restructuring in the classification of several groups of CNS tumors, particularly the diffuse gliomas as well as the embryonal tumors. Now, post 2016, there has been rapid pace of advancements in molecular pathology with the ongoing discovery of molecular biomarkers of diagnostic, prognostic, and predictive information. And in order to keep in pace with that, the C-Impact now, or the consortium to inform practical approaches to CNS tumor taxonomy, was introduced in the year 2017. And between the years 2018 and 2020, 7 updates have been published. I'm sure many of you have gone through all these updates. It comes in the official journal of International Society of Neuropathology, that is Acta Neuropathologica, as well as Brain Pathology. And the recommendations of all these updates are now incorporated into the 5th edition, that is the 2021 classification, which has been published recently, which all of us are following now, and very popularly referred to as WHO CNS5. This classification advances the role of molecular diagnostics in CNS tumor classification. Nevertheless, it is deeply rooted to the established approaches of tumor characterization, such as histology and immunohistochemistry, and therefore it presents to us a hybrid taxonomy. As Dr. Komal Prasad already told you, any classification is imperfect and it is primed for changes and modifications with advancing knowledge. And the WHO CNS5 is a work in progress, and it represents the current state of the field, but is likely to be an intermediate stage to more accurate and precise future classifications. If you look at some of the major changes in WHO CNS5, it includes revision in CNS tumor taxonomy, in CNS tumor nomenclature, CNS tumor grading, and there is structuring of the tumor group, restructuring of the tumor groups, and introduction of new tumor types, subtypes, and that is seen in almost every new classification. Use of the terminology is not otherwise specified or NOS and not elsewhere classified NEC, that I will discuss a little later. And for the very first time, the classification endorses the use of DNA methylation profiling for the diagnosis of some of the brain tumors, and also lays emphasis on combining histological and molecular parameters to generate what we call as a layered reporting format or an integrated diagnosis that would provide clinical information, diagnostic, prognostic, predictive information useful for the clinicians, and in some instances even suggest a targeted therapy. So the first change that has happened is CNS tumor revisions in the CNS tumor taxonomy. And the reason this is a hybrid taxonomy is because some tumors are grouped according to the genetic changes that enable a complete diagnosis. That is, they're genetically defined tumor types. Some examples include astrocytoma IDH mutant, diffuse midline glioma H3K27M mutant. These are all genetically defined tumor types. You cannot diagnose it without the markers. If you do not have the markers, then you call it a not otherwise specified tumor type. For some tumors, the molecular parameters are not required, but they may support the classification as well as the diagnosis, like the pediatric type low-grade gliomas or the glioneuronal tumors. On a routine basis, we don't require molecular testing for diagnosing these tumors, except in some cases. And in some, the molecular features, they help define new tumor types and subtypes. One of the examples is medulloblastoma. And we know that there are molecular subtypes, SHH activated, Wnt activated. These are of great clinical utility. And some are never or rarely or never diagnosed using molecular markers. And one of the examples is meningioma. And that is the reason this classification is a hybrid classification. And in order to standardize the WHO CNS5 with the other 5th edition Blue Book, certain terminologies have been changed. The term entity is now replaced by type and variant by subtype. So we do not refer to tumors as tumor entities and tumor variants. We call them tumor types and subtypes, and it's only the types that are listed in the classification. Now, the second change is the revision in CNS tumor nomenclature, which has now become more consistent and although we know that it is so specific to the cerebellum. So such anatomic site modifiers like the third ventricle has been removed from a tumor like chordoid glioma. And only the location, age, or genetic modifiers with clinical utility has been retained. For example, with respect to location, extraventricular neurocytoma is still differentiated from central neurocytoma because of clinical differences. And with reference to the genetic modifiers, glioblastoma IDH wild type is retained, but glioblastoma IDH mutant is redundant. It is not used in the classification. We'll discuss this later. Supratentorial ependymoma Rele fusion positive is also retained. Now it is known as Zefta fusion positive. And for the embryonal tumor, that is embryonal tumor with multi-layered rosettes or ETMR, the genetic modifier C19MC alteration has been dropped because now we know that a subset of these tumors harbor other mutations such as Dicer1 alterations. Now, if you look at the changes in CNS tumor grading, Arabic has replaced Roman numerals. That is because we want to make it uniform with the other WHO grading system for other systemic tumors to reduce transcription errors. In general, Roman numerals give rise to transcription errors. And the term CNS WHO grade is now introduced because the grading of some of the CNS tumors, it differs from the general WHO grades. That's why we use the term CNS WHO grade. There is grading within tumor types. For example, astrocytoma IDH mutant is now graded as CNS WHO grades 2, grade 3, and grade 4. And that replaces the previous terminologies, diffuse astrocytoma, anaplastic astrocytoma, and IDH mutant glioblastoma. And ependymoma and PXA are graded as 2 and 3, and the term anaplastic has been removed from such tumors. Now, a combined histological and molecular grading is applied to some tumor types. For example, for astrocytoma IDH mutant, the molecular marker CDKN2AB is now included along with the histological parameters for grading these tumors. And for glioblastoma IDH wild type, we require 3 molecular markers: EGFR amplification, third promoter mutation, gain of chromosome 7, loss of chromosome 10, copy number changes, which are included along with the histological parameter for diagnosis and grading. And we'll look at some of these examples. And WHO does not assign a grade to a tumor type if it confuses the clinical care. I'll give you 2 examples. One is diffuse leptomeningeal glioneuronal tumor. The other is astroblastoma MN1 altered. These have not been assigned a grade because we know that they have variable clinical behavior. The WHO CNS5 encourages us pathologists to use these terminologies NOS and NEC, which can now be used for any tumor type, not really reserved for a specific tumor type as in the 2016 classification. Now, NOS is not otherwise specified. That implies that the necessary diagnostic molecular tests, either they are not available in that lab, they were not performed, or the results are inconclusive. And that would only prompt additional testing at another center. On the other hand, NEC or not elsewhere classified implies that the necessary diagnostic molecular tests are all performed, but the results, they do not allow for a specific WHO diagnosis. And these include cases where there is histological and genetic mismatch. I'll show you an example later. In such a situation, one can consider a layered reporting format or even an integrated diagnosis. So a layered reporting format, it optimally combines morphological and molecular data to generate a layered neuropathological diagnosis. And this is the template for the layered reporting format put forth by David Louis and colleagues from WHO, which has 4 layers. The first is the integrated diagnosis, which is typically a WHO diagnosis. Now, if it is not so, then the pathologist can use an NOS or an NEC terminology. The second is the histopathological classification, which is based on histology and immunohistochemistry. However, mind you, this can be different from the integrated diagnosis. Third is the integrated CNS WHO grade. And the fourth is the list of molecular findings, which are all listed in the 4th layer, along with the testing platform. I'll give you one example. This is a cerebral hemispheric neoplasm, where the integrated diagnosis is supratentorial ependymoma, NOS. And the histopathological classification is ependymoma. The grade, CNS WHO grade is 3. And the molecular information here is that DNA sequencing and or FISH could not be carried out in this particular case. And that is the reason the pathologist has given an NOS diagnosis. And that would only prompt additional testing, probably refer it to another center where it is available, and if the clinician requires that. Now, we also know that in the past couple of decades, the molecular approaches have clearly shown their abilities to contribute not only to CNS tumor diagnosis, but also to the classification, using platforms that are available now in many centers, even in our country, such as FISH or the PCR, DNA, RNA sequencing, apart from immunohistochemistry. And that is nicely evidenced in the changes that we have seen already in the revised 4th edition, and which is incorporated into this 5th edition volume as well. And most importantly, there has been emergence of skillful ways of adapting this histological molecular classification recommendations in many countries. And one of the classic examples is our own ISNO consensus guidelines that we put forth for adult diffuse gliomas post 2016 classification. And I'm very proud to say that this has been referenced in WHO CNS 5. There are newer techniques that are available for diagnosis. We have platforms like NGS or the methylation profiling. Other platforms are all available. The limitations, of course, is the fact that they're not available in all centers, in very few centers. And second is the cost factor. And that is the reason WHO CNS 5 proposes essential and desirable diagnostic criteria for every tumor type. Essential diagnostic criteria is considered as definitive criteria or a must-have feature for a particular tumor, whereas desirable diagnostic criteria are those that can support a diagnosis, but they're really not mandatory for that particular tumor. And we look at some examples as we go along. So this table gives you an overview of how the tumors are classified in WHO CNS 5. They come under these 12 groups, which is almost similar to what we had in the previous classifications. The only difference is that there are new molecular types and subtypes. There is restructuring of the tumor groups. Nomenclatures have changed. So with that, there are changes, but the groups remain almost the same. And what I'm going to be doing is to discuss this first group a little more in detail, particularly the gliomas, because that is what we encounter most often. If you look at the major changes in diffuse gliomas in WHO CNS 5, it includes division of diffuse gliomas into adult type and pediatric type. This is there for the first time. In the earlier classifications, they were not divided into adult type and pediatric type, and now they're divided because we know that they're molecularly distinctly different neoplasms. There is simplification in the classification of adult type diffuse gliomas, including nomenclature and the grading, and division of pediatric type diffuse gliomas into pediatric type high and low grade gliomas. And this table compares the WHO 2021 classification of gliomas with the 2016. In 2016, there were several genetically defined tumor types, almost 15 genetically defined tumor types of different grades. All of them came under one header, that is diffuse astrocytic and oligodendroglial tumors. And the circumscribed astrocytomas came under this group of other astrocytic tumors. But now it is more consistent. We have only 4 groups: adult type diffuse glioma, pediatric type diffuse high-grade gliomas, low-grade gliomas, and circumscribed astrocytic gliomas that I'm going to be discussing. So the first is adult type diffuse gliomas. And mind you, this is a genetically defined tumor group. It includes genetically defined tumor types. And there are only 3 tumors in this. That is astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19q co-deleted, and glioblastoma, that is IDH wild type. Now, the essential diagnostic criteria for astrocytoma IDH mutant as per WHO CNS 5 is that it's a diffusely infiltrating glioma with IDH 1 or 2 mutation and loss of nuclear ATRX expression or ATRX mutation, or exclusion of 1p19q co-deletion. So most tumors will have loss of ATRX expression, IDH mutant astrocytomas. So once there is loss of ATRX expression, there is no need to carry out 1p19q co-deletion by FISH as recommended by the C-impact guidelines. Nevertheless, there are some tumors which show retained ATRX status. And in those cases, diagnosis is based on excluding 1p19q co-deletion. Only then we require this FISH technique. And look at the desirable diagnostic criteria. You can see that astrocytic differentiation by morphology is a desirable criteria. So not all tumors need to have an astrocytic morphology. For example, this is one of our cases. You can see that the tumor has an oligodendrocytic morphology. Beautifully, you can identify these oligodendrocyte-like cells. It is immunopositive for IDH1 R132H, but it does not show ATRX lost status. It shows an ATRX retained status, and there is some amount of p53 immunoreactivity. So we went ahead to perform the FISH, and you can see that by FISH, 1p19q is non-co-deleted. There is no co-deletion of 1p19q. And so the diagnosis here becomes astrocytoma IDH mutant CNS-WHO grade 2. The reason, although the tumor shows an oligodendrocytic morphology and although it shows an ATRX retained status. So it is only in these tumors that 1p19q by FISH becomes very important. And astrocytoma IDH mutant tumors are now graded as CNS-WHO grade 2, grade 3, and grade 4. And that replaces these terminologies: diffuse astrocytoma IDH mutant, anaplastic astrocytoma IDH mutant, and glioblastoma IDH mutant, which is no longer used. And the terminology astrocytoma IDH wild type is eliminated. And let us see why this terminology has been eliminated. We know that IDH mutations are very common in diffuse lower grade gliomas. This is some older data that I'm showing you. And IDH mutations are seen in 100% of oligodendrogliomas. And that is the reason it's a molecularly defining factor for the diagnosis of oligodendroglioma. It is seen in approximately 80% of WHO grade 2, grade 3 astrocytomas, and about 8 to 10% of glioblastomas, which we used to label as IDH mutant glioblastoma or even secondary glioblastomas. And we do know that IDH mutations are associated with a favorable prognosis in these diffuse lower grade gliomas, which has been shown in several studies. And in this very elegant study by Von Demling's group, Hartman and colleagues, they compared the prognostic differences between anaplastic astrocytoma and glioblastoma based on IDH mutational status. And they showed that IDH wild type anaplastic astrocytomas were associated with the worst prognosis when compared to the IDH mutant glioblastomas, thus highlighting the prognostic power of this biomarker. And this is our own previous study on grade 3 tumors on anaplastic gliomas, where we also showed that molecularly defined anaplastic oligodendroglioma was associated with the best prognosis, anaplastic astrocytoma IDH mutant with the intermediate prognosis, and wild type tumors were associated with the worst prognosis. So these astrocytoma IDH wild type tumors are aggressive lower grade gliomas. They look like grade 2, grade 3, but in essence, several behave like glioblastoma. For example, this is one of our cases. Previously diagnosed as anaplastic astrocytoma grade 3, a 40-year-old gentleman. And this was IDH wild type both on IHC as well as on DNA sequencing. And this tumor progressed very rapidly and recurred as glioblastoma within 5 months of the initial diagnosis. In fact, Roos and colleagues from the German group have shown that adult IDH wild type lower grade astrocytomas, they actually resolve into the molecular subgroups of glioblastoma itself. However, that concept changed over a period of time. And later studies showed that not all IDH wild type lower grade astrocytomas are associated with a aggressive behavior. It's only a subset of those tumors which show a poor prognosis. And this subset harbors GBM-like molecular alterations. That it looks like a lower grade astrocytoma, but it would be IDH wild type and harbor these mutations, that is EGFR amplification, gain of chromosome 7, loss of chromosome 10, and third promoter mutations. And these were all associated with a poor prognosis. And in the C-impact now update 3 recommendation, these tumors were designated as IDH wild type diffuse gliomas with molecular features of glioblastoma. But subsequently in the C-impact update 6, all these tumors have been redesignated as glioblastoma itself, IDH wild type, And this has been incorporated in WHO CNS5. Now, there is a grading criteria for astrocytoma IDH mutant, taking into consideration both histological and molecular parameters. And we know that the tumors are graded as CNS WHO grade 2, grade 3, and grade 4, and that replaces the terms diffuse anaplastic astrocytoma and IDH mutant glioblastoma. Don't use those terminologies anymore. And we are aware of the histological parameters that are required for grading, which is already established in the previous classifications. So I won't go through that. And the only new molecular marker that has been included for grading is CDKN2AB homozygous deletion. So what is important for us to know is that astrocytoma IDH mutant tumors grade 2 or grade 3 do not have CDKN2AB homozygous deletion. And astrocytoma IDH mutant CNS WHO grade 4 is defined as a tumor that has microvascular proliferation or necrosis histologically, or CDKN2AB homozygous deletion, or any combination of these features. And any CNS WHO grade 2 or grade 3 tumor, if it harbors CDKN2AB homozygous deletion, then it conforms to WHO grade 4 tumor. And let us see why the CDKN2AB was included into the classification for grading. We know that IDH mutant astrocytomas are associated with a favorable prognosis generally, but recent studies using high throughput genomic epigenomic platforms identified a subset of rapidly progressing IDH mutant astrocytomas also. And these tumors harbored certain genetic alterations such as CDKN2AB homozygous deletion, CDK4 PDGFR amplification, MICN amplification, and had a low global DNA methylation levels, that is a low GSIMP levels. Among all this, it was CDKN2AB deletion that was the most robust marker associated with a poor prognosis. Now, CDKN2AB is cyclin-dependent kinase inhibitor 2A, 2B. These two genes are very closely placed on chromosome 9p21.3 locus, and they encode for 3 tumor suppressor proteins, that is P16, P14, as well as P15. And they inactivate CDK4, CDK3, or they prevent P53 degradation. And CDKN2AB deletion, it results in uncontrolled activation of the genes that are involved in transition from G1 to S phase. That's the reason it brings about increased tumor cell proliferation. And several studies, including this large study from Ari Perry's group, have shown that CDKN2AB loss is associated with a shorter overall survival in IDH mutant lower grade astrocytomas. And taking all this into consideration, Takashi Komori from Japan put forth this schematic diagram for grading IDH mutant astrocytomas, which are graded not only based on their histology, but also on their genetic parameters, most important being CDKN2AB homozygous deletion. That is why it is in larger font and it is in a bold font. And any tumor which is grade 2 or grade 3, if it harbors this, then it conforms to CNS WHO grade 4, associated with a worse clinical outcome, has a lower global DNA methylation level, and higher genomic instability. But mind you, CDKN2AB homozygous deletion frequency in IDH mutant astrocytomas is very low. It ranges, this is some studies which have shown that it ranges between 0 to 12% in grade 2 tumors, 6 to 20% in grade 3 tumors, and 16 to 30% in grade 4 tumors. In our own experience, where we looked at more than 100 cases of IDH mutant astrocytoma grade 3, we found that the frequency was only about 5%. So that is as low as it is. So that is the reason one has to be very careful in identifying this small subset of these IDH mutant astrocytomas. So essentially, the diagnostic criteria for IDH mutant astrocytomas remains the same as in 2016. We start with histology, then we do the IHC for the recommended markers that I'm not going to go through. And in those cases that are IDH1 R132H negative, sequencing will be required for the other IDH mutations. There are other non-canonical IDH1 and IDH2 mutations, and if to determine whether that tumor is IDH mutant or IDH wild type. And the only new molecular marker that is required for grading is CDKN2AB homozygous deletion that can be assessed by the FISH technique that is available in many labs, standardized as well. But the more sensitive technique for identification is the MLPA technique, where you can detect higher levels of the CDKN2AB deletion. The criteria for diagnosis of oligodendroglioma IDH mutant 1p19 co-deleted is also unchanged from 2016 classification, which mandatorily requires us to demonstrate IDH mutation either by IHC or by FISH and or by sequencing, and 1p19q co-deletion by FISH, in the absence of which these tumors are designated as not otherwise specified or NOS. Now, the essential diagnostic criteria for oligodendroglioma IDH mutant 1p19q co-deleted is that it's a diffusely infiltrating glioma with IDH 1 or 2 mutation and 1p19q co-deletion. So all others become a desirable criteria. And these tumors are graded as CNS WHO grades 2 and grades 3. The term anaplastic oligodendroglioma has been removed. So you just call it oligodendroglioma CNS WHO grade 2 or grade 3, based on the histological parameters that we are quite aware of. And the term oligoastrocytoma is now deleted. You don't use that. It's not a WHO term. Nevertheless, pathologists can use it as an NOS terminology if there is no access for molecular testing. Moving on to glioblastoma, we know that in the 2016 classification, these were categorized as IDH wild type, IDH mutant tumors, and defined as a high-grade astrocytic glioma with nuclear atypia, cellular pleomorphism, brisk mitotic activity, and very importantly, microvascular proliferation and or necrosis. So we are well aware of the criteria we were using for glioblastoma. But now glioblastoma is only an IDH wild type tumor. It corresponds to CNS WHO grade 4. And the essential diagnostic criteria is that it's an IDH or a H3 wild type astrocytic glioma with one or more of the following histological or molecular parameters: microvascular proliferation, necrosis, EGFR amplification, TERT promoter mutation, gain of chromosome 7, loss of chromosome 10, copy number changes. So any tumor that has either one or more of these parameters are designated as glioblastoma IDH wild type. And we do know of glioblastoma variants that we were diagnosing earlier. Many of you might have received these diagnoses. Giant cell glioblastoma, tumor that is composed of these numerous bizarre multinucleated tumor giant cells, very strongly positive for P53. And gliosarcoma, a biphasic tumor that has glial and sarcomatous elements, as well as epithelioid glioblastoma, a tumor that occurs in the younger individuals, characterized by cells that have this epithelioid morphology and is BRAF V600E positive. Now, all these are retained in the classification, but we don't call them as variants, but they're referred to as subtypes of glioblastoma IDH wild type and discussed in the chapter under histopathology. So this is only a summary of what changes have happened in adult type diffuse gliomas. Maybe you can remember this. For astrocytoma IDH mutant tumors, they're graded as CNS WHO grades 2, 3, and 4. The terms diffuse astrocytoma and anaplastic astrocytoma IDH mutant glioblastoma is no longer used. Grading is within the tumor type. A combined histological and molecular grading is introduced, taking into consideration CDKN2AB homozygous deletion status. And the term astrocytoma IDH wild type has been eliminated. Now, the second is oligodendroglioma IDH mutant 1p19q co-deleted, graded as CNS WHO grades 2 or 3. Grading criteria is unchanged from 2016, but the term anaplastic is no longer used, and oligoastrocytoma terminology is deleted, but can be used as an NOS terminology. And glioblastoma IDH wild type is a CNS WHO grade 4 tumor. The term glioblastoma IDH mutant is eliminated, so don't use that term. And a combined histological molecular grading has been introduced, taking into consideration the 3 markers that I've already mentioned. So routinely for us as pathologists, the key markers we require in the assessment of adult type diffuse gliomas, if the histology is astrocytoma, oligodendroglioma, oligoastrocytoma, and the grade is 2 or 3, are IDH 1 and 2, ATRX, P53. I like using MIB because it's an adjunct. It's not really a criteria, an adjunct that helps us to grade the tumor. 1p19q, and the only new marker is CDKN2AB. And we are very familiar with the technical platforms, IHC, as well as DNA sequencing for the non-canonical IDH mutations, and FISH for 1p19q, as well as for CDKN2AB. So I'm just going to show you a few algorithms that we can follow, a simplistic algorithms. CNS WHO grade 2 or grade 3. We start with immunohistochemistry. That is the most important.
If the tumor is IDH1 R132H positive, and then it shows ATRX loss, it is P53 positive, then the diagnosis is astrocytomate mutant. We follow that up with CDKN280 homozygous deletion. If there is deletion, it upgrades to grade 4. If not, remains as grade 2 and grade 3. Now, if the tumor is IDH1 R132H positive, ATRX is retained and P53 is negative, then FISH for 1P92 will be required. Because if it is co-deleted, it becomes molecularly defined. If it is non-co-deleted, it still is astrocytomate mutant, and then it follows this. Now, what if the tumor is IDH1 R132H negative on IDC? So it was grade 2, grade 3, but it was negative on IDC. If it shows ATRX loss and P53 positivity, most probably they're astrocytomate mutant tumors itself. But we should call it astrocytomas because we have demonstrated IDH mutation. Follow that up with the sequencing for IDH1 and 2. And if this is mutated, then it becomes astrocytomate mutant to follow the same pathway. Now, if it is not muted, it becomes IDH wild type astrocytoma. How to deal with these tumors? In older individuals, the 3 molecular markers for glioblastoma has to be carried out, and any one is present, then it one or more, it's glioblastoma IDH wild type. If not, it is astrocytoma NC, not elsewhere classified, because we've done all the molecular testing, but we're not able to fit it into a particular diagnosis. And in the younger individuals, we look for histone mutations that I come to later when I talk about the pediatric tumors. Now, if it is IDH1 R132H negative and ATRX is not lost, it is retained P53 either positive or negative, I would prefer to do IDH1 because I've seen that the large majority of them are negative for IDH mutations and they go into IDH wild type because most of them. Nevertheless, if it is muted, then FISH for 1P92 will be required, and then it becomes oligo. If it is not co-deleted, it is still selected to delete. Now you look at a tumor, and the pathologist says it has features of glioblastoma with a microvascular partition.
Selection.
Then what do we do as pathologists? The one stain that we require is IDH1 R1. Only one stain will be required. If the patient is equal to or above the age of 55 years, then I can see if IDH1 R1 is negative, then it is sufficient to be able to but if the patient is below the age of 55 years, and IHC is negative, particularly in the setting of pediatric loss and P53 positivity, then sequencing will be required to determine whether it is mutant or wild. And if the tumor is in the midline, it's IDH wild type, regardless of the age of the patient or even the grade. It need not be glioblastoma, it can be grade 2 or grade 3. We require to do this histone markers that I'm going to discuss subsequently. And we know that enzyme promoter methylation testing is very useful. It's prognostic and predictive biomarker. May not be useful in routine clinical setting for all the patients, but certainly useful in recurrent settings.
Included in the WHO-CNSY classification, but one marker that we need always. Now, moving on to the pediatric CNS tumors, in WHO-CNS5, there has been a rapid transition from a morphological to molecularly driven classification, taking into account all the new discoveries that have happened in pediatric tumor genomics. And this is how the pediatric CNS tumors are classified in WHO-CNS5. They come under these groups. Gliomas, glioneuronal and neuronal tumors are one group. Then we have the choroid plexus tumors, embryonal, pineal region, germ cell and other tumors. So what I'm going to do is to concentrate on the glial group of neoplasms because that is the one that has a lot of molecularly defined tumor types. And if you look at pediatric gliomas, particularly the diffuse gliomas, they can occur in the adults and vice versa. That is the reason we call them as pediatric type and adult type gliomas because they're not specific to the pediatric age group or the adult age group. And these tumors are now grouped as pediatric type diffuse high-grade gliomas, pediatric type diffuse low-grade gliomas, and circumscribed astrocytic gliomas. I'll begin with pediatric type diffuse high-grade gliomas. These are uncommon tumors. They're de novo tumors. They never progress from a lower grade glioma as in the adults. Molecularly, they're distinctly different from high-grade gliomas that we see in adults. And interestingly, there are site-specific differences in their molecular alteration. For example, a tumor that is, the molecular alterations in a tumor that is in the cerebral hemisphere will be distinctly different from a tumor that is located in the midline. Now, pediatric type high-grade gliomas can be either in the midline or they are hemispheric. And midline tumors are now designated as H3K27 altered. Now, this is a revised nomenclature that replaces the older terminology H3K27M mutant, and it includes 3 tumor types. The first is diffuse midline glioma, H3K27 mutant itself. Second is the diffuse midline glioma, that is H3 wild type with EZHIP overexpression. And the third is diffuse midline glioma, EGFR mutant. I'll discuss these in very briefly. Among hemispheric gliomas, we have diffuse hemispheric glioma, H3G34 mutant. It is not K27, it is G34 mutant. These tumors are seen in adolescent and the young adults. Diffuse pediatric type high-grade glioma, H3 IDH wild type, and infant type hemispheric glioma. I'll start with the midline tumors, that is H3K27 altered. And the first is diffuse midline glioma, H3K27M mutant, that all of us are quite familiar with because this was introduced in the 2016 classification itself and defined as a diffusely infiltrating glioma that is seen in the midline structures defined by thalamus or the brainstem and even the spinal cord, harboring the H3K27M mutation, which luckily for us can be identified by IHC itself. There is an IHC surrogate for the mutation. And since this H3K27M brings about a global loss of the trimethylation of H3K27M, we can demonstrate by IHC loss of H3K27Me3. So these two are the 2 IHC markers that are required. And mind you, the tumor can be of grade 2, it can be grade 3, or it can be grade 4. If it harbors these mutations, then it corresponds to CNSWH2 grade 4. Now, the second is diffuse midline glioma, H3 wild type with EZHIP overexpression. Basically, H3K27M mutations, whether they occur in canonical or non-canonical histone variants, they bring about a global loss of H3K27 trimethylation. And it's the inhibitory interaction between H3K27M and another molecule known as EZH2. This is known as enhancer of Z's homolog 2, which is a methyl transferase catalytic subunit of the polycomb repressive complex that drives this negative effect. However, even when there is H3 wild type status, there is another molecule known as EZHIP. It's an inhibitory protein of EZ. And this is an endogenous mimic of H3K27M. This can also inhibit PRC2. So basically, both EZHIP and H3K27M are oncoproteins. They are competitive inhibitors of PRC2. Both of them bring about loss of H3K27Me3, thereby driving oncogenesis. And diffuse midline gliomas that are H3 wild type, that is, they're negative for H3K27M, but show EZHIP overexpression, was first described by the French groups. And initially by DNA methylation profiling, they were shown to cluster distinctly, and later their IHC pattern was also described. Now, this is one of our cases, a diffuse midline glioma in a child. It was in the brainstem. It has features of glioblastoma on histology. As you can see, there is this area of necrosis. But on IHC, it is negative for H3K27M. So there is no H3K27M mutation. We call it H3 wild type. On the other hand, it shows loss of H3K27Me3 expression. Only the endothelial cells are stained. The tumor cells are all negative, and it shows EZHIP overexpression. So this is designated as diffuse midline glioma, H3 wild type, with EZHIP overexpression, and this also corresponds to CNSWH2 grade 4. And the third is diffuse midline glioma, EGFR mutant. These are rather rare tumors. These occur in the pediatric age group. They're bithalamic gliomas. And these tumors are known to harbor EGFR mutations, usually in exon 20 or the exon 7 of the gene, but they lack EGFR amplification, what we see in the adult type of tumors. Histologically, they're either grade 3 or grade 4 astrocytic gliomas. They're negative for H3K27M, so they're H3 wild type. but they also show H3K27 ME3 loss. So these three tumors, that is the H3K27M mutant diffuse midline glioma, the EZHIP overexpressed tumor, and EGFR mutant tumor, all of them bring about loss of H3K27ME3, and that is the reason they have now been grouped under H3K27 altered tumors. And if you look at the hemispheric tumors, the first is diffuse hemispheric glioma, that is H3G34 mutant. Now these tumors are exclusive to cerebral hemispheres. They don't occur in the midline. They occur in the adolescent and the young, They occur in the adolescent and the young adults. And histologically, these have features of grade 3 or grade 4 astrocytic gliomas. Usually they have this gliomatosis like spreading pattern. Some of them can have primitive neuronal features, very primitive, peanut-like, what we used to call as peanuts. So it can have that feature also. It has a distinct IHC pattern. OLIG2, which is a diffuse glioma marker, will be negative here. ATRX will show loss and P53 positive, similar to the IDH mutant tumors, but these are not IDH mutant. And diagnosis can be made by DNA sequencing. And luckily for us, now monoclonal antibodies are available for both H3G34R as well as V, and one can diagnose this. Although this is a CNS WHO grade 4 tumor, it has an intermediate behavior because MGMT promoter methylation is seen in about 65% of these tumors. Now, the second is diffuse pediatric type high-grade glioma H3 IDH wild type. This is a molecularly defined tumor type. There are some subtypes in that, and this would require a high throughput platform like NGS for diagnosis. So I'm not getting into the details of that. And the third is infant type hemispheric glioma. These are also very rare tumors, but these are receptor tyrosine kinase driven tumors. They're RTK driven tumors, and they show molecular alterations in 4 key genes: ALK, NTRK, ROS1, and MET. And usually these are fusions with multiple fusion partners. And the most common alteration is the ALK alterations. And actually in infant type hemispheric gliomas, ALK altered tumors have a better prognosis. ALK alterations can be detected by the FISH technique and more easily even by IHC. For example, this is one of our cases, a diffuse hemispheric glioma, which shows features of glioblastoma on histology, and it is diffusely ALK positive. So even though it is a rare tumor type, why should we know this so much in detail? Because there are now targeted therapies that are available for this group of tumors that can target genes like ALK, ROS, NTRK, and all of these are under the clinical trials. Now, the next group is the pediatric type diffuse low-grade gliomas that include 3 newly recognized tumor types that I'm not going to bore you with. And the term angiocentric glioma, which was enlisted in the group of other gliomas, has been shifted to this group of tumors. I will just briefly mention only one tumor here, a newly recognized tumor type in 2016 in the 2021 classification, which is polymorphous low-grade neuroepithelial tumor of the young, also known as PLENTY. This is a very indolent cerebral hemispheric neoplasm. It occurs in the young individuals. Usually tumors are in the temporal cortex. They have a DNET-like MRI features. There is a strong association with seizures. Histologically, however, it is diffusely infiltrating. And it has histological features like a low-grade oligodendroglioma, but it is in the pediatric age group. Sometimes it's in the adolescents and young adults. And it is negative for all the oligomarkers, but it shows positivity for another marker called a CD34, which shows a nice membrane staining. And it is a very low-grade tumor with low proliferation, no mitosis, corresponds to CNS WHO grade 1. And it harbors 2 classic genetic alterations, FGFR2 or 3 fusion and BRAF V600E mutation. Now, among circumscribed astrocytic gliomas, pilocytic astrocytoma, pleomorphic xanthoastrocytoma, and SEGA continues to be in the classification. The only difference is that for PXA, the term anaplastic is removed. They're graded as 2 or 3. And chordoid glioma and astroblastoma, which were in the group of other gliomas, have been shifted to this group. And as I already mentioned, for chordoid glioma, the location modifier third ventricle is removed. Don't call it chordoid glioma of the third ventricle. And for astroblastoma, the genetic modifier MN1 has been added for specificity because that is a specifically genetically defined tumor. And the only newly recognized tumor type here is high-grade astrocytoma with pyloid features. I'll just tell you a few words about this. It's a very interesting tumor. It's an astrocytoma with a distinct DNA methylation profile. It was first identified by DNA methylation profiling itself. These are tumors that occur mostly in the cerebellum, and they're in the older adults. And when you look at it histologically, they are high-grade gliomas. Sometimes you would have seen high-grade gliomas in the cerebellum, which are not ependymomas. And sometimes they can even look like glioblastoma, but they have other features like eosinophilic granular bodies or occasional Rosenthal fibers, trying to take you towards pilocytic. They have frequent MAP kinase pathway gene alterations, particularly BRAF fusion, but they show loss of nuclear ATRX expression and deletion of CDKN2AB. And unlike all other CNS tumor types where DNA methylation profiling was only a desirable criteria, here it becomes an essential diagnostic criteria. So we cannot give a definitive diagnosis. It should be an NOS diagnosis. And a grade is not assigned to this tumor because it's associated with a variable prognosis. So the question for us is molecular testing really required for all? We know for adult type it's so important, but for pediatric type low-grade gliomas, do we really require that? And in my opinion, it's not required when the histological features are very classic, but we will require in tumors that require post-surgical radiation therapy or for prognostic guidance, or in very small biopsies where histology cannot differentiate a low from a high grade because the biopsy is very small. And in incompletely resected tumors with the potential for targeted therapies like the BRAF therapy. And since the large majority of these pediatric type low-grade gliomas, they harbor BRAF mutations, V600E mutation, or the KIA1549 BRAF fusion, we routinely require very few markers for their diagnosis. The IHC markers include BRAF V600E. I would like to use it for all pediatric type tumors, low-grade, circumscribed glioneuronal. Now, H3K27M should be used along with ME3, even if it is low-grade, but is in the midline structures. And if the patient is adolescent and has a hemispheric tumor, IDH1R132H will be required. And there are several other IHCs that will support our diagnosis because we can make the diagnosis using GFAP, OLIC2, SYNAPTO, CD34. All have to be combined with histological parameters. And very few FISH markers. CDKN2AB is one of the FISH marker you can use that supports the diagnosis of PXA, not really required routinely. But I like using KIA5049 BRAF fusion, particularly in small biopsies with a suspected pilocytic astrocytoma diagnosis where histology is not supportive, to guide adjuvant therapy, and in recurrent tumors and in cases which are BRAF V600E negative. And assessment of all other genetic alterations, whether they belong to MAP kinase, non-MAP kinase pathway, they can all be kept optional in a country like ours because they'll require a platform like an NGS platform. So if you look at ependymomas, the reason there has been a revamping in the classification of ependymoma is because of the identification of the molecular subgroups of ependymomas. And I'm sure all of you are very familiar with this famous paper by Pagler and colleagues who carried out DNA methylation profiling on a large number of ependymomas in different regions of the neuraxis and identified 9 molecular subgroups of ependymoma. And very recently, an aggressive form of spinal ependymoma, which is characterized by dissemination throughout the neuraxis and anaplastic morphology, and MICN amplification has now been identified. Taking all these into consideration, WHO CNS5 classifies ependymoma based on 3 parameters: anatomic site, histopathological features, and genetic alterations, so that it reflects the underlying biology. And we know that the 3 anatomic sites where ependymomas occur are supratentorial, posterior fossa, and the spinal. Each of them have their molecularly defined tumor type and histological defined tumor type. So what is important is that for the molecularly defined type, a specific WHO grade is not assigned. You grade it according to the histology, what you saw. Histologically defined tumor types are graded as 1, 2, or 3, and the term anaplastic is removed. And mind you, myxopapillary ependymoma is now a grade 2 tumor, not a grade 1 tumor. Newly recognized tumor types in WHO CNS5 include supratentorial ependymoma, YAP1 fusion positive, posterior fossa group A and group B ependymoma, and spinal ependymoma, that is MICN amplified. These are the new tumor types that are introduced. And supratentorial ependymoma, which was RELA fusion positive or C11 ORF95 positive, is now renamed as ZEFTA fusion positive because the gene's name has been changed. And if you look at this, table, you can see that among all the molecular subgroups is the posterior fossa group A ependymoma and the spinal ependymoma that are associated with a poor prognosis, as it is indicated in these red dots. And the supratentorial ependymoma rela fusion positive, which is now called zepta fusion positive. We used to think that this is a tumor with a very poor prognosis, but in essence, it is associated with an intermediate prognosis. And it's only a subset of these tumors which once again harbor CDK and 2AB deletion that are associated with a poor prognosis. And you can see how nicely these molecular subgroups, they cluster on DNA methylation profiling. And luckily for us, we do have some IHC surrogates. We use L1CAM and P65 for zepta fusion tumors. And we also use H3K27ME3 for posterior fossa group A tumors. So we do have such IHC surrogates. There's not much change in glioneuronal and neuronal tumors except for the addition of some newly recognized tumor types. And let me tell you that most of the essential diagnostic criteria for the large majority of these are only histology and IHC. Molecular parameters are required for very few tumors, maybe like a diffuse leptomeningeal glioneuronal tumor and a few other tumors. Similarly, in the group of embryonal tumors, the classification hasn't changed a whole lot. The molecular subgroups of medulloblastoma continues to be there. It is genetically defined or histologically defined. 8 molecular subgroups of group 3, group 4 ependymoma have been identified, but not really in the classification. In the text, you can read that. There are molecular subtypes identified in ATRT as well as ETMR that I already discussed, and there are 3 newly recognized tumor types. I'm going to discuss only one which we encounter quite a bit. This is known as CNS tumor with B-core internal tandem duplication. That means this is an embryonal tumor, newly recognized. Histologically, it has a solid growth pattern. It has, sometimes it looks like ependymoma, sometimes it looks like sarcoma, sometimes it looks like astroblastoma, all kinds of histologies. But you will find that it is B-core immunopositive. But this is not specific to the mutation. B-core immunopositivity can come in other tumors also. And diagnosis is based only on DNA sequencing, where we demonstrate the internal tandem duplication in exon 15 of the B-core gene. And this is associated with a poor prognosis. And this is some of the series that we have published from our center. Finally, if you look at meningiomas, I'm not going to go into great details of meningiomas. Dr. Tejpal Gupta is going to discuss in great detail. We know that there are 15 subtypes in grade 1 meningioma. The criteria for grading grade 2, grade 3 can be applied across all subtypes. It need not be just meningothelial or transitional or fibrous. It can be applied across all subtypes. Grading criteria for the grade 2 meningiomas remain the same. It's not changed at all. So I'm not going to get into the details, except one feature, that is specific morphological subtypes. If the tumor is chordoid or clear cell, it doesn't have any of these grading criteria. It is still a grade 2 tumor. But the grading criteria for grade 3 has changed, that is anaplastic. So the criteria includes 20 or more mitosis at 10 hypa fields, or frank anaplasia. It can have a carcinoma-like feature, sarcoma-like, melanoma-like, or whatever. It's very, very anaplastic, or third promoter mutation. If you see that even in grade 2, it conforms to grade 3. And a homozygous deletion of CDK and 2AB is also another feature that is taken into consideration. And mind you, earlier we used to think rhabdoid and papillary phenotypes of meningiomas automatically are grade 3 tumors. No longer they are grade 3 tumors by themselves. They should have one or more of these criteria to call it as a grade 3 or anaplastic meningioma. There are 22 newly recognized tumor types in this WHO CNS5. 14 are under gliomas, glioneuronal tumors, 8 under other groups. And the large majority of these are actually seen in the pediatric age group itself. They're very challenging to diagnose and probably will require NGS platforms or other platforms for diagnosis. So finally, what is the change we are actually seeing in this new classification? Besides the usual changes, the new tumor types, subtypes, restructuring, renomenclature, main changes are the addition of specific genetic alterations that we already know of. And particularly for adult type diffuse gliomas, most of them can be reliably diagnosed by combining morphological and genetic alterations. And that can be assessed by using platforms that are available in many centers. And I would suggest that everybody sticks to the histological molecular classification of adult diffuse gliomas. Very few will require advanced methods for diagnosis, like an NGS platform or a methylome assay. And I have seen that this is particularly useful for pediatric brain tumors because that is very challenging for diagnosis. So finally, to conclude, the WHO 2021 classification has evolved from the knowledge that was acquired by using several advanced molecular technologies. But that doesn't mean that these technologies have to be used for routine diagnosis, except in some instances. And what I would like to emphasize is that histology is pivotal. It is the central point, which would guide the pathologist to carry out the appropriate molecular test. If the histology goes wrong, then all molecular test interpretation also will be wrong. And now there are readily available surrogates, all kinds of IHC markers that can be used for routine diagnostic purposes. Moreover, the WHO CNS5 encourages us to use NOS, NEC terminologies liberally for reporting tumors. And only that would indicate that it has to be referred to another advanced center for further workup. And this is just a table that I want to show you, where there are so many IHC surrogates that are now available for the various mutational status. And I'm sure that these IHC markers are available in most of the pathology labs. They're all commercially available. But the only caveat is that not all are sensitive or specific for the underlying genetic alteration. So we have to keep that in mind before we make a diagnosis. So with that, I'd like to end my lecture and we'll be very happy to take any questions. Thank you very much for your attention.
So wonderful, exhaustive coverage of the topic. You want to say something?
Same thing, sir. Thank you, ma'am, for, as sir said, a very exhaustive coverage. And your talk is probably the cornerstone for the rest of the symposium. I would like to invite Dr. Akhila, HOD and consultant pathologist from Narayana, to join the honorable chairpersons to felicitate ma'am.
Any questions before that? Any comments, please?
Secondary, say IDH mutant astrocytoma, which later turned out to be secondary glioblastoma. That is gone. All you are telling is they are all CDKN2 homozygous deleted. I don't know, our old terminology.
Yeah, the terminology is gone, but these are CNS WHO grade 4 tumors. When it is a grade 4 tumor, it is like glioblastoma itself. Okay, the terminology is changed. You don't have to have CDKN2AB deletion in all of them. If you have seen histologically that they have microvascular proliferation necrosis, even then, if it is IDH mutant, you call it that. But many clinicians ask me, what do we do with the CNS WHO grade 4 tumors? It is a glioblastoma basically, but let me tell you that if we do MGMT promoter methylation, about approximately 90% will be promoter methylated in this group of tumors. Whereas if you look at glioblastoma IDH wild type in adults, only about 35 to 40% will be promoter methylated. So that is one of the things that we should know, that is the reason probably, and these are predominantly frontal lobe tumors. Most often they'll be in the frontal lobe. They're little more better defined when compared to the IDH wild type, which is so diffusely infiltrating, what Dr. Komal was showing, how it infiltrates into the parenchyma. Little more surgically, slightly more amenable to the surgeon when compared to the wild type tumors.
Yeah, ma'am. Sorry. Thank you. Thank you. Just had a small question, and this is regarding the classification, as you said, that for IDH wild type astrocytomas and the algorithm which you presented, and after that you do the molecular, the three things for glioblastoma like signatures, and if they are all negative, then you say that it is astrocytoma NEC. So the question is this a very common phenotype that you see, or do you think there is any further classification required, like MGMT promoter methylation?
Let me tell you that, first of all, they're not able to fit it in. It's already, they've done the markers, it's a lower grade, it's wild type. So basically what happens is a group of those tumors actually will conform to the pediatric type diffuse low-grade tumors. Although, sorry, they will conform to the pediatric type diffuse low-grade tumors. So when we have that NEC kind of diagnosis, it's best to carry out an NGS because in such a situation, we find other alterations. There's something called as pediatric type diffuse low-grade glioma, which will be IDH wild type. It will look like a grade 2 tumor itself, but it will be IDH wild type. It will not harbor GBM-like mutations. So those tumors are very low grade. Actually, they are very low grade. So you require to look at the other molecular markers when you have that NEC.
And MGMT promoter methylation is not any indicator because
it's not in the classification. I mean, there were some pathologists who used to ask me this question, like in the lung tumors and other tumors who have, like alpha, there are groups of tumors. Why don't we have methylated GBM, non-methylated GBM? Why don't we have that? But WHO did not use that for the classification. Nevertheless, it's one of the very important markers in my opinion that has to be carried out, particularly for guiding that.
What an opportunity that we have.
Thanks for that lovely talk, as usual, of course. But this DNA methylation profiling is the cornerstone of all this. So, is it so complicated that it cannot be done everywhere? Or is there some way we can have centers across India which are going to do this? Or what is the difficulty?
very good morning to all you all. Myself, Dr. Shilkan from Narayana Health Sector. So today I'll be discussing about the 2021 classification of adult glioma from the radiology perspective. That was an excellent talk, so entirely covering the pathological side. So 2016 update is the one which really brought all these changes from the radiology perspective also, where the genomics were given more and more importance. It has really changed the role of imaging from the structural point of view to an underlying physiological point of view, the perfusion, all the incorporating all those criteria. Then came the C impact, now the consortium, which have updated some changes, and finally the 2021 classification, which added more and more importance to the genomics, definitely for the right reasons, because of the prognostication and management. So it has brought many changes in nomenclature and our understanding also. And we'll discuss mainly about the adult gliomas now because of the time constraints. So what is the major changes? In the 2016, the fourth edition update, as you can see, you are able to see that the astrocytomas are having both IDH mutant as well as wild type, and the glioblastomas are also having both IDH mutant and the wild type. And the grade 2, grade 3, they were labeled as diffuse and anaplastic. So the major changes that were brought in the adult diffuse gliomas were the IDH wild type astrocytoma has been removed, and even the IDH mutant glioblastoma is also removed. So previously what we are trying to do is, after the 2016 classification, we are trying to predict the IDH mutations based on the imaging. We are trying actually. So during those time also, we had difficulty finding the IDH wild type astrocytomas and the IDH mutant glioblastomas. These two are the classes where we found maximal difficulty or the least predictive value on imaging. Now those two components were removed completely, and the diffuse and anaplastic variants, these two are also removed completely. Now in the 5th edition, they simplified the classification, saying that if you have IDH mutation, it comes into two classes only, whether it is an oligodendroglioma or it is an astrocytoma. And if you don't have IDH mutation, it definitely falls into the IDH wild type. Now, and the grading also. Previously, the grade 4, it was labeled as GBM invariably, but now the astrocytoma also is having grade 4. These cases, previously we used to label as IDH wild type astrocytomas. So now it comes as grade 4 astrocytoma. So these are the major changes that happened. And some new additions were also made, like pediatric type diffuse low grade glioma, pediatric type diffuse high grade glioma. So among all these parameters, what is the role of imaging? Imaging role is mainly threefold actually. It has slightly simplified our role compared to the 2016. Main role is to identify the gliomas on imaging so that we are not missing any other pathology as glioma or those which are mimicking the glioma pathologies. Once you are able to identify it as a glioma, the second step will be, should be able to predict the grade accurately. That is more important than predicting the IDH mutation. And of course, last step will be trying to predict the IDH and other mutations as accurately as possible. Here I'm trying to be overly optimistic because we know that from the imaging we'll not be able to accurately categorize the IDH mutations. So that is the last resort. So these are the three steps that we are trying to achieve. So coming to the gliomas, from the imaging perspective, most of the time expansion of the involved structure, that is a hallmark which is seen in most of the gliomas. As you can see, in majority of the gliomas, you'll see expansion of the involved structure. But there can be some other pathologies which can cause expansion and which can mimic. For example, CVT causing some hemorrhages and subcortical edema leading to expansion of the structure, or in case of subacute infarcts because of the edema, or autoimmune encephalitis. There are some cases where these were inappropriately labeled as low-grade glioma or high-grade gliomas because of the hemorrhagic contents. So we should be able to rule out these pathologies before concluding it as a glioma. Or in the deep gray matter nuclei, if you see, this is a case of deep venous thrombosis leading to edema of bilateral thalami causing expansion. Or in another case of dengue hemorrhagic encephalitis causing expansion with hemorrhages. Or in case of Wilson disease because of expansion. So these are all some of the mimickers or where significant expansion is seen, but before labeling it as a glioma, we should be able to rule out the other pathologies. Now, what are the imaging sequences and what are the findings that we are trying to look for in case of gliomas? So the most commonly used and most important sequences are in this particular order. First will be the T2, because in T2, you will be able to see the expansion of the involved structure in a very clear manner. So on T2, look for the expansion of the structure and then look at the heterogeneity or homogeneity and the ill definition or well definition of the borders. These are the pointers which we are trying to look in the T2 weighted images. When you are looking on the flare again, these points, it will be much more easier to appreciate on the flare imaging, the borders or homogeneity or heterogeneity. Then in the GRE or SWA sequences, we always look for any foci of blooming, whether any calcifications are present or any foci of hemorrhages are present. These are important. Then in the post contrast, is there any enhancement? If there is enhancement, is it heterogeneous or homogeneous, peripheral or central? In the diffusion, any areas of restricted diffusion. These are the pointers that we are trying to look at. And then we look at the perfusion analysis, whether any significantly increased perfusion or mildly increased perfusion compared to the opposite hemisphere. Spectroscopy is useful in definitely some cases where we have doubt regarding the underlying etiology, whether it is infective or neoplastic. In case of neoplastic etiology, we'll be able to see significant elevation of choline while using the spectroscopy. Whereas DTA and fMRI are useful only in select cases where the lesion is close to the eloquent areas where you are operating. Only in those cases we'll use the DTA and fMRI. Apart from that, all these parameters are very, very important. So I'll show you the next step where the IDH mutation prediction. So once you are able to identify a glioma, the next will be looking at the grade of the glioma. So for easier understanding, all these are the parameters that we are trying to look at. Be it on different sequences, we'll be looking for increased heterogeneity, foci of restricted diffusion, surrounding infiltration, that means ill definition of the borders, increased enhancement, and in the perfusion parameters, significantly increased RCBV elevation. So we can look at them as low grade, grade 2 and 3, and grade 4, because grade 2 and 3, they do share majority of the parameters. That's why we'll not be able to separate them in most of the cases. Now, presence of necrotic contents is the hallmark of GBM as per the 2016. Up to that, even from our earlier days also, imaging wise, if you see necrotic contents, we used to label that as GBM on the imaging itself. Now that has changed significantly. Now we'll be able to say it as grade 4 only. We'll not be able to label it as GBM. Even if you see necrotic contents, we'll mention that as high grade glioma. Then the further molecular genomics will reveal whether it is a glioblastoma or diffuse astrocytoma with grade 4 variant. So that is one major change which happened. So in case of low-grade glioma, you will see no mass effect, no foci of restriction, no enhancement, no RCBV elevation. So these are the important pointers that we need to remember. Again, in low-grade glioma, we may not be able to identify these mutations on imaging. These are the new mutations which are added. Whereas in case of grade 2 and grade 3 tumors, we were able to predict the underlying mutations on imaging even during the 2016 also. So once the 2016 update has come, there are many papers which were published, many retrospective studies and prospective studies were conducted to look for the IDH mutations and to be able to predict on the imaging. So they tried to look at multiple parameters and they found some of the parameters to be extremely useful in predicting the underlying IDH mutation status. Out of all these, one finding is particularly T2 flare mismatch. This is one very, very useful sign on imaging which can predict the underlying mutation. So I'll just show you. The first one is the IDH mutant with 1p19q co-deletion, that is the oligodendroglioma. In case of oligodendroglioma, what are the predicting points on imaging? One is frontal location involving the cortical subcortical location, left more than right, and ill-defined borders. If you see on the T2, you're able to see that the margins are completely ill-defined. And then too much of heterogeneity within the lesion. As you can see, the lesion is not at all homogeneous. There are areas of bright signal and some isointense signals are present. And then the most important sign, that is the T2 flare mismatch. If you look at the T2 and flare together, if you see more than 50% of the lesion, if it is suppressed on flare, that is called as positive T2 flare mismatch. In this case, as you can see, there is no suppression of flare signal compared to the T2 signal. That means it is negative for T2 flare mismatch, and this is reasonably having very high predictive value for oligodendrogliomas. So after that, you look at the GRE imaging to look for any foci of calcifications. In any case, if you are able to identify all these findings, as I shown in this case, ill-defined margins, too much of heterogeneity, negative T2 flare mismatch, foci of calcification, then you can confidently label that as oligodendroglioma, and you can predict the underlying mutation easily. That is a IDH mutant with 1p19q co-deletion. In this variant, between the grade 2 and grade 3, the differences are presence of foci of restriction, or presence of contrast enhancement, or increase in the perfusion indices. If you come across these three, then you label that as grade 3 oligodendroglioma. For example, in this case, there is no foci of enhancement, no abnormal increase in the restriction, or no significant increase in the perfusion also. So this was a proven case of grade 2 oligodendroglioma, and which we are able to predict this on the imaging itself. So this is one variant where we are able to predict. Coming to the other variant, that is astrocytoma, where IDH mutation is present with 1p19q intact variant. So this is the grade 2 or 3 astrocytoma. As you can see, it is almost exactly opposite to that of the oligodendroglioma that we have seen. One, you'll have the well-defined margins. If you remember from the previous slide, the margins are ill-defined in the prior one. In this one, the margins are well-defined. And more importantly, it will have homogeneous signals. Throughout the lesion, you will see homogeneity and T2 flare mismatch. If you see here, the more than 50% of the lesion is suppressed on flare imaging. This is called as T2 flare mismatch, and you will not have any foci of blooming or hemorrhages within the lesion. So if you come across a lesion which is fitting into all these criteria, having well-defined margins, completely homogeneous, and there is flare mismatch and no foci of calcification, then you can label that confidently as astrocytoma, which is IDH mutant. Until this, these are the two which are very clearly we are able to appreciate on imaging. Again, in between the grade 2 and grade 3, similar to the previous one, presence of contrast enhancement, presence of foci of restriction, or significant increase in the perfusion, it will make it as a grade 3 astrocytoma. So in this case, again, there are no typical features, so it became a grade 2 astrocytoma. So just to summarize the grade 2 versus grade 3, these are the most important and most with high positive predictive value. Ill-defined margins, no T2 flare mismatch, presence of calcifications, and that becomes a IDH mutant with 1p19q co-deleted. And if you see T2 flare mismatch with well-defined margins and homogeneity, absence of any foci of blooming, that will become an IDH mutant with 1p19q intact. So until this, we are able to achieve with multiple studies and looking at multiple cases. Now looking at the grade 4 lesions. As I have shown you, all these parameters, as they increase, the grading of the tumor will also increase. And previously, we used to think the necrotic contents as the hallmark of GBM, but now it just indicates grade 4 only. So we are not reporting it as GBM nowadays. We'll report just as a high-grade glioma. More importantly, grading is no longer entirely histological also, let alone leave the imaging part. Even from the histological point also, even if you don't see the necrotic or microvascular proliferation, presence of this mutation will make it directly a grade 4 lesion. So imaging role has definitely slightly came down when you are trying to predict the mutations. So you need not predict mutations, but we should be able to grade, predict the grade accurately. So this is completely gone, where the IDH mutant glioblastoma, it is completely removed. Now there is no IDH mutant GBM. So just to show you the high grade features. So on diffusion weighted imaging, you will see that there will be peripheral areas of restricted diffusion with central necrotic contents. That is one feature. On T2, you will see too much of heterogeneity with central necrotic contents. On flare, you will see incomplete suppression. Remember that incomplete suppression means it need not show high signal intensity. You can compare with the adjacent CSF. CSF is the comparison point here. CSF is completely suppressed, whereas the flare, it is not showing any incomplete suppression. So that means it is incomplete suppression of flare contents, that is central necrotic contents. And post contrast, if you see peripheral significant enhancing lesions, that is the hallmark of grade 4 disease. So these are the variants which are labeled as glioblastoma. Now, let's try to see what we are able to predict and the predictive value also. Though the predictive value is not as high as in the grade 2, grade 3 lesions, still, if you're able to see that a lesion showing complete peripheral restricted diffusion with T2 heterogeneous contents and peripheral enhancement, the entire lesion is showing peripheral enhancement, entire lesion is heterogeneous, and the entire lesion, the peripheral restricted diffusion. If you're able to see these three, then from the imaging point of view, we're able to predict it as a GBM in majority of the cases. If you look at the other type of variant where the IDH wild type or grade 4 GBM, similarly, too much of heterogeneity within the lesion and incomplete suppression on the flare sequence, presence of foci of hemorrhages, peripheral restricted diffusion, and heterogeneous enhancement. So these are the features. If you are able to identify, that, that is having a good predictive value for IDH wild type GBM. Let me show you one more case where it is a IDH mutant GBM previously. So for example, if you look at this case, you are able to see that there is a lesion in the left anterior temporal lobe and insular cortex area, but entire lesion is not showing heterogeneity. Only along the posterior aspect, we are able to see heterogeneous contents, whereas the anterior half is completely homogeneous. Even on the imaging point of view also, we are able to see that differential signals within the lesion. So this was previously, it was labeled as IDH mutant grade 4 GBM. Now, as we are not able to see it as GBM, it will become as a IDH mutant grade 4 astrocytoma. So these are some of the predictive points. And when looking at the perfusion data also, we should always make sure to look at the perfusion of the enhancing components. And different components may show differential perfusion, and increased areas of perfusion, those are the areas which will have higher grade. And if you are doing a biopsy, those are the areas which you should be able to track it. And we should target those areas. So just to summarize the 2021, among the major changes from the imaging point of view, these are the major changes. The removal of the IDH wild type GBM, and grade 4 is assigned for astrocytoma also. So we don't label necrotic component lesion as GBM directly, we label it as a grade 4 lesion only. So these are the 3 roles for radiology: to identify gliomas, not to miss any glioma like autoimmune encephalitis or any other pathology, and should predict the grade accurately. And different components of the tumor may have different grades. You should always be able to label the components which are having higher grade on the imaging. That is the area where we should target biopsy and look for the molecular this thing. So these are just summarized. These are the same things. These 2 are the variants which are having excellent predictive value. If you remember these things, if you come across these all the features, then you can confidently label the genomics also on your imaging itself. It's a long journey, so thank you.
Thank you, Dr. Shivakant. It was very nice description of the radiological features. And with the first talk and the second talk, we are able to understand better. Now, thank you. I think we can move on to the next talk. Yeah, please.
Okay. So basically, depending on the ADC values also, they were trying to predict the restriction component. So directly, we may not be able to visualize on the imaging itself. By using some special softwares, we will be able to measure the ADC values within each of the voxels. So if you see different components of the tumors having different ADC values, similar to diffusion weighted imaging, instead of just looking at the visual data, if you are able to quantify the diffusion parameters in different voxels, thereby also we can try to predict. But again, as I mentioned, there are many parameters which were considered, but none of them have the predictive value to incorporate into routine imaging itself. Yeah.
Thank you, madam. Please.
I just want to ask you one question.
Yes, ma'am.
Is it any biological underlying reason for this T2 flare mismatch only in IDH mutant astrocytomas? We are
No,
not
we're
going to
not
see
able
it
to.
in the 1p19q co-deleted. So is there some kind of a biological reason for why we get this T2 flare mismatch, which is so predictive value is so high, as you said?
Yes. Biological reason, I'm not sure. No, sorry.
Cold protoplasmic astrocytoma, not for
Okay.
every astrocytoma. I don't know, you can treat that. To flare mismatch.
Yeah.
Not for protoplasmic variant of astrocytoma, not for all the other types.
Okay. And more often also, oligodendros predominantly they involve the cortical area, the cortical expansion. That is the reason, because we are having both white matter as well as cortical involvement with foci of calcification. That is one reason why it is more heterogeneous. Whereas astrocytomas predominantly they in the subcortical and white matter. So that is one reason why they could be more homogeneous. Yeah. Thank you.
Thank you very much.
Yeah.
Now, actually, for the wild neurosurgeons, those days the classification is like, is it approachable or not approachable? It is accessible or not accessible? And can you do it or you can't do it? Right? From that approach, I think Anand will now tell us more about clinical implications with the new classifications, so that it will enlighten all the neurosurgeons who are sitting over here. Thank you.
And organizers, it's a pleasure to be here to discuss the clinical implications of the new classification. We have heard so wonderfully from the last two speakers, the pathological perspective and the radiological perspective. So it's going to be a lot of repetition because the classification is the same. I'm going to draw in the same classification and just try to make it simpler for the clinicians. So what is it that we need to ask for? What is it that we need to remember? And what is it that we don't need to, we can leave it for the pathologist to discuss and we don't have to get into that. So let me see if it's an oversimplification, I will request the pathologist to apologize. I mean, I apologize to forgive me at the cost of oversimplification. With this, can I move forward? This is not, yeah. So we know this is the overall WHO. There are 6 glioneuronal types. The adult diffuse type is what we are going to look at. I'm not discussing the rest. This is only to the adult type diffuse gliomas. And we know that there are these 3 types, which we have already seen, Madam has discussed. Then the pediatric low grade, pediatric high grade, the circumscribed astrocytic gliomas, where our pilocytics come, pleomorphics come, the glioneuronal tumors and ependymal tumors, I'm not going to discuss. So we are left with adult diffuse type gliomas. And this was the scenario 2007, 2016. Life was much simpler in 2007 when we had to know only diffuse astrocytoma, anaplastic astrocytoma. Then it got a little complicated with the IDH subtypes. Now it has got very simple, only 3 types. So this is the adult diffuse gliomas, is only IDH mutant astro, IDH mutant oligo, 1p19q co-deleted, and the wild type glioblastoma. So this was what we had at the end of 2016. You can see that IDH mutant, IDH wild type was being written for every tumor, but now this has become the overarching classification. So whether it is mutant or wild type, then you have the GBM in between the diffuse astrocytoma, wild type anaplastic astrocytoma are not labeled anymore. And these are the defining mutations. So the ATRXP53 type is for the astrocytoma and the 1p19q is for the IDH mutant oligo. So we just have astro, oligo, GBM, IDH mutant 2 varieties, IDH wild type 1 variety. And this is 3 grades, this is just 2 grades, and this is just 1 grade. So first coming to the IDH mutant astrocytoma. So as I said, there are 3 grades. So the grades are 2, 3, and 4 remains exactly the same, so right from 2007 to 2016 to 2021, based on mitotic activity, microvascular proliferation, and necrosis. There is no change in this. If you already have this as grade 4, no further molecular characterization is required to call it grade 4. So your CDKN2A molecular characterization, which we heard for grade 4, is applicable only when you have a lower grade tumor, which you are planning to manage less aggressively. Say in a young patient having a good resection, looks grade 2 on histomorphology, just not to miss an aggressive tumor, you need to do a CDKN2A. If it is already grade 3 or grade 4 on histomorphology, other than IDH, which requires ATRS and P53, IDH mutant, no further molecular characterization is required. So this is only for grading, whereas these IDH, and ATRXP53 is for the diagnosis. So we have diagnostic and the grading. Grading we need not do if it is already graded by histomorphology. So histomorphology is still pivotal and still crucial and is the guiding factor. We heard about T2 flare mismatch. I'll just go there a little bit. The prognostic factors remains the same. It's just age and extent of resection. So this is your T2 flare mismatch. T2 flare mismatch is identical with IDH mutated astros. This is very important for us to recognize preoperatively for two reasons. The previous speaker stressed on how well defined they are. They lend themselves to good resection. IDH mutated tumors are having a good prognosis post-surgically because the extent of resection in these tumors tend to be better. So to recognize these tumors preoperatively is important so that we get to resect as much as possible. So these are the tumors which you will muster all your armamentarium. You want intraoperative imaging, you want intraop ultrasound, you want to do navigation guided, you want to do intraop neuromonitoring guided because they are well-defined tumors. So this is the data that comes from the TCGA project, where they found almost 100% correlation. If there is a T2 flare mismatch, like in these three examples, it is always IDH mutated astro. Now, what if it is contrary? If there is no T2 flare mismatch, unless, like the previous speaker said, there are other correlative findings like calcification and no enhancement, then it could be oligo, but there is no 100% correlation. When there is no T2 flare mismatch, they look identical. It could be still a IDH mutant astro, it could be IDH mutant oligo, or it could be a IDH wild type GBM variant. So this is a mixed bag. When there is no mismatch, it's a mixed bag. But when you have a mismatch, it's very good for the clinician to recognize it preoperatively because these are totally resectable tumors probably. You can even go for a maximal safe resection. And number three, in oligos, even if you leave behind some tumor, they are excellent response to radiation chemotherapy, not as good in IDH mutant astros. In IDH mutant astros, the response is not as good. We all know from the long-term data for IDH mutant oligo, 15-year survival, 20-year survivals are reported with radiation and temozolomide or PCV. Whereas in IDH mutant astros, like there is a T2 flare mismatch. If you resect well, they will do better. If you don't resect well and you leave behind residue, the response is not as good as oligos. This is a very important point as clinician for us to recognize preoperatively. No point knowing it postoperatively that I could have done a better resection had I known it was IDH mutant. And as such, they lend ourselves to good resection. So our mindset being prepared when we go in for surgery for a total resection is more important rather than going in with a nihilistic attitude or a subtotal resection attitude. So it really prepares you and very important to recognize. I'll just show you one example of this where there is no T2 flare mismatch, but it turned out to be IDH positive tumor. The reason we extensively worked up this was an insular glioma, dominant hemisphere, high performing individual. There was a residue left in the upper opercular deep part of insula because of speech deficits we had during resection. And lo and behold, it turned out to be IDH positive. We had to go in for the residue, whether to operate now again, which was not possible because she was having speech deficit, whether to wait and watch or to treat at the time of progression. So if it is an oligo, you can wait and watch. Whether you do a treatment at progression or immediate, they are going to respond very well. If it is an astro grade 2, you can still wait and watch because radiation at the time of progression versus radiation upfront again give the best result. Whereas if it is grade 4, it looks like grade 2. If it is grade 4, then you would treat now. You will not wait for later. So this is where this type of cases wherein CDKN2A becomes important because you're dealing with a IDH positive but grade 2 lesion with the residue in a good prognostic low age individual. So CDKN2A becomes important here. No point doing it upfront. This is another example. Good T2 flare mismatch. You know it is an IDH, going to be IDH positive astro. So maximum resection is going to be needed here. Unfortunately, as you can see here, it is grade 4. Histologically, it is grade 4. It is ATRS lost. IDH is positive. So this no need to do CDKN2A. Here a pathologist has suggested to do CDKN2A. It's not going to help because it's already grade 4 on histology. So you're dealing with the IDH positive mutant astrocytoma, which is already grade 4. You can't call it GBM because they are better prognosis than a GBM, which is IDH wild type. So you're going to treat upfront, but you need not do CDKN2A here. Whereas the previous case, we did CDKN2A. Now coming to the oligos. So oligos, it's a histological criteria. It looks like an oligo, more likely to behave like an oligo. It's not very true. You need to have 1p19q co-deletion, but it is expensive. If you are going to do routine markers, like IDH is essential, ATRX-P53 is essential, like Madam showed beautifully in her algorithm, these two being mutually exclusive. So if you have an IDH positive tumor and ATRX is retained, then more likely, if it looks like an oligo, it's going to be 1p19q co-deleted. So are you going to ask for a 1p19q co-deletion? Here is a talk you can discuss with the pathologist what they feel and then ask for the 1p19q as a layered second step. The prognostic factors remain the same, age and extent of resection. If you have a IDH negative by histology, by a standard IHC marker, then 1p19q or sequencing, which way do you go, would again depend on ATRX and your discussion with pathologists. So don't blindly ask for 1p19q, which may be very expensive. It may be worthwhile to go for IDH sequencing, make sure it is IDH mutant, and then go by the ATRX, which is mutually exclusive. Now coming to the wild type. So wild type, as going by this classification, IDH wild type, all are going to behave badly provided it's wild type. So you need to really make sure if it comes out on IHC as IDH negative, double confirm and do a sequencing, because this is going to be labeled as bad prognostic tumors. Again, if they are looking histomorphologically grade 4, no further molecular typing is required. So far we have seen only IDH, ATRX and P53. No other molecular markers are required, even in the IDH mutant astros if it is already grade 4, and IDH wild type if it is already grade 4, provided you have confirmed by sequencing this is IDH wild type. In those cases, like in the previous session, there was a question, in those cases which are IDH negative, but looking grade 2 and grade 3 morphologically, low grade. So there, these three markers become essential so that you're picking up the GBM. So once these are, because this has become diagnostic criteria for GBM. If you're not able to do, then you have to report it as NOS, as Madam had said. So here, an example, we had a clinical patient. This is an 81-year-old individual, deep-seated right parietal lesion, operated. This is IDH negative, repeated twice, checked. So correctly, the pathologist has suggested IDH sequencing, which was done, and it was shown to be negative again. The ATRX retained, P53 negative. So what is next to do? Here, 1p19q has been done. I think this is an overkill, need not have been done. And he has suggested to go for TERT and CDKN2A. Both are not required because this is grade 4 and this is IDH wild type. So already it is grade 4, it is IDH wild type. No further characterization needed for you to subclassify either in grading or in histomorphology because sequencing has confirmed its wild type. Now MGMT methylation has been asked. Now this is an important factor which again came up in the question. I'd like to stress here. MGMT does not change your grading. MGMT is not required for calling or labeling the tumor. Your labeling is done by IDH, ATRX, P53. Now, what is MGMT really useful for? Because this patient is a 81-year-old individual. We know that MGMT is an important prognostic marker and not a predictive marker when it comes to all gliomas, except in the elderly. So beautiful study which had come up where they had randomized elderly patients with poor KPS and good KPS with methylated and unmethylated MGMT. So they found that if methylation is present, so if the KPS is very good and it is methylated, you can go for the standard RT and temozolomide. If the patient is compromised, what is the idea? What is the principle? We want to segregate MGMT and non-MGMT patients. We don't want to give them higher dose of RT and put them down on KPS because they are already elderly patients, GBM. So we want them to have a good quality of life. So hypofractionation, only temozolomide or a combination of hypofractionation temozolomide is very good in methylated MGMT cases. In unmethylated, that prognosis is not going to be good. We'll have to go for standard therapy if the KPS is good. If KPS is not good, treatment becomes palliation. You can even consider only giving temozolomide if it is methylated, or only giving hypofractionated RT if it is methylated. So this is the only clinical situation where MGMT is predictive and you need to ask for MGMT. Blindly asking for MGMT in any other clinical scenario does not change your management, and you're going to follow the standard STUPS protocol for all gliomas. So diffuse midline glioma, we have already studied. I'm not going to go in detail, just to show that this is again a separate variety based on the location. So all that we saw diffuse adult gliomas are lobar. For the brainstem, it is H3K27, and for the hemispheric gliomas, the previous term of gliomatosis, it is now H3G34 altered. I'll just show you like this multicentric hemispheric involving the insular, involving the septum pellucidum and in the lobe. So these lesions are like the old gliomatosis cerebri terminology, now called pediatric type diffuse hemispheric glioma. So summarizing, putting it together, IDH is most important. ATRX-P53 takes you down the path for astrocytoma with 3 grades. If it is low grade, you need CDKN. Otherwise, you don't need CDKN if it is already histomorphologically high grade. Oligos are much simpler, 2 and 3 grade. You don't have to do 1P19Q probably if ATRX is mutually detected, and if you're sure it is IDH mutated and looking like oligo. For the IDH wild type glioblastoma, if it is grade 4 and if sequencing is IDH wild type, no further molecular markers are required. But if it is IDH wild type low grade, then you go for the other molecular markers. So in summary, we already have seen that Arabic is, Roman is out and Arabic is in. Subgroups, the grading is in the subgroups. We don't call them anymore low grade, high grade gliomas. We call them IDH mutant astros, then the grade 2, 3, or 4. It's very important to classify and know where they are. If you are in a project, if you are in research, probably you need all the markers for all the cases. Otherwise, if you are clinically wanting to treat the patient, stick to histomorphology. Most of the pathologists may not be familiar, especially people working in large multi-specialty hospitals where you don't have a dedicated neuropathologist. As clinicians, you must be very clear what you're asking for. Rather than asking for a blind glioma panel for all cases, going in a structured way, going by histomorphology first, and then once the IDH and ATRX status are known, if you're not able to label further, then going down to sequencing and molecular genetics for further grading in a low-grade tumor are essential. And MGMT, mind you, no point asking MDMT in all patients. It's relegated for a subset of elderly GBMs, especially if their KPS is compromised, so that you can maintain them in a higher KPS with simple hyperfractionated radiation or just temozolomide. So with this, I'll conclude my talk and I'm open for discussion or questions. Thank you.
Yeah, please.
suppose you showed first case of yours, insular glioma. I think that case at T2 fire mismatch, you knew that it is a astrocytoma because it is only astrocytoma.
No, there is no mismatch here.
That there is no mismatch.
When there is no mismatch, you cannot be sure. When there is a mismatch, it's 100% predictive of IDH mutant astro.
I agree, but
This is no mismatch, but turned out to be IDH mutant astro.
okay. So, and the previous speaker, radiology, also we know that insular temporal lobe, it is unlikely it will be a oligo. So that is also, it's more for frontal parietal like that. Insular temporal lobe more for astro. But my question to you is, you have a IDH mutated mismatch T2 fire astro you have taken out in toto. And grade has come grade 2. Will you still go for CD, KN2A assessment? It has to be done because if it is proven, even that low grade merits upfront radiation. What is your take on that?
That's correct. If histomorphologically it is grade 2, you have done a total resection and you are planning to observe the patient.
No,
there is no other indication for radiation here. You should do CDKN2A to make sure you are on the right path. Suppose this is an elderly patient. You will anyway go for radiation because high risk, in spite of it being grade 2. Or if there is a residue you have left behind which you don't want to radiate now, you will do CDKN2A to make sure that you are not missing a grade 4.
But I think it should be done for everybody, all the cases, because
I'll tell you in which cases you need not do. If it is already looking grade 3, you have done a good resection.
I am telling grade 2, if it is coming on histopathology, I think every case should have, irrespective of total resection.
Provided you are not radiating now. That's what I'm saying, sir. If you are going to radiate immediately, you are already considering it as a high grade. You need to characterize.
How can you radiate telling that at low grade, they will tell why are you
If age is high risk characters, if age is more. Any one of the two high-risk features, age or extent of resection, is not satisfied. Even a low-grade tumor, you will have to treat upfront.
Yeah. I think, is there any question? Yeah, please.
Yeah, I just wish Dr. Anand gives a talk every time we listen to Madam's lecture, because it's like decoding a Da Vinci code for neurosurgeons to make it simple. Continuing Dr. Nayar's question, earlier we have been talking about this high risk, low grades, grade 2.5 and all those things. Now all those have been taken out completely. And will IDH and 1p19q itself, in addition to extent of resection, help us in deciding the adjuvant therapy? Because you said you would watch, I think in the present time, I think Dr. Tejpal is there somewhere, I think almost all grade 2s as well as grade 3 undergo adjuvant therapy, unless it is a low grade, grade 2, complete resection.
Exactly. So that is the point. So if it is grade 3, grade 4, we are all going to give treatment straight away. Grade 3, as per 9805 RTOG trial, whether you radiate upfront or you give later at the time of progression, the outcome is same. So if you have done a resection, there is a very small residue left behind, or there is no residue there. Even in grade 3, you can wait and watch if you are sure it is IDH mutated and you are dealing with only grade 2 or 3 with good prognosis, young patient, and you are going to have close follow-up so that you can treat at the time of progression. Outcome, long-term progression does not change. In grade 2s, with supramaximal resection, no extent of resection, means large tumor resected with even a margin, with good age, low age, less than 35. We have seen series from Dufau, no adjuvant therapy given at all, 15-year survivals with hardly 3 or 4 progressions, which could be re-resected. So we are reaching a stage wherein if you diagnose a low grade, real low grade glioma, probably surgery could be curative. I mean, we are overstepping and saying this when I'm saying this as a sentence, but we should recognize that quality of life is very important. Young performing individual, if you're going to radiate, you're going to land up in trouble when they are going to live for 15 to 20 years. however good our radiation protocols may be. So there, doctors, what Suresh Nair said is very important. Better make sure you're dealing with a CDKN2A negative tumor. As madam said, the number is very small. It will be hardly 5% or even less. But better to make sure your patient does not lie in that 5% because you're going to observe. But for whatever reason, if you're going to give adjuvant therapy, either you're afraid or it is in a non-eloquent area, you can radiate, or age is higher, or you're not very happy with the quality of resection and patient is willing to take radiation, then no further characterization is needed. You directly resect and you keep under close follow-up.
Excellent. And actually, yeah, it's very, very nice.
Thank you.
It's very nice, really very nice. I think we as very aggressive neurosurgeons must be aggressive in this particular gliomas, because gliomas was, those days it was, we took it as very lightly, but now we are doing more aggressive work. As Suresh and was telling about, very particularly one thing, why should we wait? Why can't we do that and find out whether it is going to become aggressive or not? Because sitting as a dormant is not good for the neurosurgeons when there is a suspicion of particularly grade 2, grade 3, where we are going in. Number one is that we all now grown up to a complete, doing for a complete excision of the tumor, because our technology has improved and we have improved ourselves. Number two is now the histopathology has gone up and immunochemistry has gone up and molecular development has gone up. I think it's a good going and a very nice start for the conference. I think I come to the end of this.
I think we'll wind up this session. Congratulations to all the speakers for excellent lectures. What a great learning experience. Congratulations. Yeah.
Everybody of Narayana Neurosurgery to join the honorable chairpersons to felicitate Dr. Anand. Now we'll have a short tea break. Everyone can proceed to the outside area. We'll reconvene in another 10-15 minutes.
Check. Basically, check. Hello, check. Hello, check. Hello. Mic change ಮಾಡಿ ಕಟ್ ಮಾಡಿ
Check. Hello. Check.
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 and start the inauguration.
Keep it like this. No, we don't need. Good morning and welcome for an informal inauguration. We will do it by lighting the lamp. We are having a meeting after a long break because of the pandemic. We never had big meetings and we were used to all virtual meetings. And today, sitting and listening to all the speakers, I realized how important it is to have a real meeting. Because when you are coming here for a real meeting, your attention is here 100% compared to a virtual meeting when you're actually doing something else and paying a limited attention to what is going on. We will begin by lighting the lamp. Dr. Suresh Nair, please. Dr. Suresh Nair, Dr. Parthiban, Dr. Anand, I'll request you to come. Dr. Nitin, please come. Thank you very much for your support for this conference.
We shall now proceed with session 2. I invite the chairpersons on stage, Dr. Shibu Pillai, Consultant and HOD of Department of Neurosurgery, Narayana Health, Dr. Shachi Vadanan, Senior Consultant Neurosurgeon, Command Hospital, and Dr. Shailesh A.V. Rao, Head of Department of Neurosurgery of St. John's Hospital.
Before we start, slight change. I am Dr. Air Commodore Yadav, Krishna Yadav, not Dr. Shashi, so it's okay, no problem. So welcome to the second session, and we have some very interesting talks in the second session as well. we all know about the treatment part. I mean, we know at various levels, and we all have studied about it. But there's something which most of us know very little about, something which is beyond and something which connects us with the patients, and something which will ultimately make or break our reputations. And that is the communication with the patients. Now, one of the important communication is related to breaking the bad news when the patient and the relatives come to know that the person is having morbidity or future mortality, whatever. So we have this wonderful, we'll have this talk on this by Dr. Timappa Hegde, who will guide us and tell us as to how do we go about it. Dr. Timappa Hegde, please.
Dear chairpersons and my dear friends, I'm not here to guide anybody about how to break bad news, because this is not an area that we are specifically trained. We learn from our own mistakes. And although Dr. Komal has given 30 minutes, I don't think I will use a good part of that. More of that I would like to see from each of our own experiences. And what I'm going to present is only about how I have failed in my own communication, how I have suffered in this interaction. And breaking bad news is not an easy thing to do. It is emotionally very draining, because bad news is bad news. There is no way you can make the bad news any better. Once you have news, maybe you can prepare the patient to some extent, but then how or in what way you could make it more appropriate. If you have a counseling room, preferably where there is some amount And I did not know where he was staying. I knew a general idea of his residence, but from the hospital, I had to get
and with that angle it would go into the thalamus. Now looking back, these are into the subthalamic nucleus. We used to do epilateral x-rays. All these were done in the x-ray room. And the moment you find your position, the moment you are there also, you see some amount of tremors stop. And some amount of alcohol was injected. The moment alcohol was injected, the person started breathing deep. And he required his respiration to be supported, shifted into the emergency and so on, into the ICU. And the doctor, my consultant, asked me, see, this man should have a long life. He should live for at least 60. How old is he? I checked his record and said he's 60 years, sir. When you have reached that fuel, when your fuel meter drops, it drops. Now, again, I go back to the Bhagavad Gita to answer this question, is life fair? How do I know? Why do I deserve whatever? So whenever we go through difficulty, this question comes, and it is extremely difficult to answer patient or their families. Why me? Why my child has got a malignant disease? I have no answer for this. Now, in the 8th chapter of the Bhagavad Gita, Shri Krishna says, I am there inside all of you as the one who decides whether your action deserves punya or papa. Now, this is extremely important. It is not the action that decides punya or papa. More than the action, you will know what is it. It is the intention with which you do. I may do a seemingly good act with a bad intention. So there is a person inside me who knows whether my action deserves a punya or a papa. And that's what Shri Krishna says. I'm the one who's there inside you to be able to decide. And if you can understand this law of karma, there are certain advantages. We will see primarily more than to be able to counsel our patients, to be able to counsel in our own life, how I handle my own prarabdha karma. The prarabdha karma decides some of the most important events in our life. It defines our time of birth, our place of birth, which country you are born into, your gender, what kind of body you have, what kind of mind you have, what kind of family you have, what religion you're born to, what nationality. Now, these are very important, but this is what has been decided by our prarabdha karma. The prarabdha karma not only decides these things, it also decides the environment in which I am brought up. The environment programs us. So much of our programming has happened because of influential people in our life. It could be our parents, it could be our teachers, it could be religious leaders. Now, therefore, all of us become programmed. Now, if you look at this law of karma, it will look like we are all, it is all fated. This is completely determined. Is there a choice? The answer is, the glory of a human being is that I have a choice. I have a choice in deciding my own life. Why? I'll just jump to the next one. All right, I have put this one. Karmas can be of two types. One is called prabala. Prabala means strong. When a person is going through this bad news process, at that moment, you are not 100% certain that are we dealing with a very bad result, or it is just, I do not know. I have some amount of information. That is why part of breaking bad news, we should never give an exact timing of how long this person is going to survive, because people will blame you either way. If the person survives much longer than you have said, then they also come very angry and upset with you. On the other hand, families will come and say, you said I'm going to survive only a short period of time. See, I'm still alive. So we can make mistakes. So prarabdha, the karma can be prabala or durbala. If it is strong, then you will see whatever your efforts don't seem to be working. But if it is durbala, that is where the glory that you can work through all treatment options, you can work through all psychological options, you will be able to handle it. And this is a beautiful mantra which helps us to work on such situations, which says, grant me the serenity to accept things that cannot be changed, the courage to change the things that I can, and the wisdom to know the difference. Among the most difficult problems that we face as a doctor is to be the one who's responsible for problems in a patient's life. We are fortunate that so many of our people will say, every morning I wake up, thanks to what you have done, I have a good life. But there will be a few isolated patients, hopefully few of them only, who will wake up in the morning and say, I went to this doctor, he promised me that he will cure me of my illness, but see what I am today. I am paralyzed, I am disabled. And there are a lot of people who will curse you for years, and you find yourself in this position. You find yourself as a person who is responsible for the problem in the life of somebody else. I will use this in our own life to understand all of us or some of us will have difficult people in our life. Difficult people means those people who, by virtue of their proximity, either through relationship or because they are of seniority, their decisions and their presence determine our well-being. We cannot wish them away. Maybe at work because my work is important, maybe in my life because my husband or the family is important. Now, how do I deal with difficult people? Now, there is a nice quote which says, about people who give happiness. There are two kinds of people who give happiness, and I will tell you who are these difficult people. One kind of person is one kind of people is they give happiness wherever they go. A second kind of people they give happiness whenever they go. So I'm looking at those kind of people in our own life. How do we handle them? You must understand these people are the final common pathway who have come to deliver my own karma. If you understand, if I am going through difficulty, why is this difficult person in my life? He is only a messenger. Because of my past karma, I have ordered or I have incurred certain things. And this person is a person who is the one who's the delivery agent for my karma. And this is particularly meaningful when we understand how I have been the delivery agent for somebody else's suffering, when I have done everything in good faith. I'll conclude with a few messages from Tagore, which will help us to handle all situations. Let me not pray to be sheltered from dangers, but to be fearless in facing them. Let me not beg for the stilling of my pain, but for the heart to conquer it. Let me not look for allies in life's battlefield, but to my own strength. Grant that I may not be a coward, feeling your mercy in my successes alone, but let me find the grasp of your hand in my failure. I'll conclude by this very nice message. Dr. Komal also put a nice message from Adi Shankara. This is from Manisha Panchakam. Manisha means each verse ends with Yesha Mama Manisha. Adi Shankara concludes about this. He says, I am Man Isha. I am absolutely certain. And what is this? Sashwan Nashwara Neva Vishwam Akhilam. Akhila Vishwam. The entire world, Sashwan Nashwan. My own world can come crumbling in front of me. Very difficult to accept. What is my own world? My body, my mind, my family, my possessions, my work, my reputation. All these are, remember, perishable commodities. And the first word he says is Sashwan Nashwara Neva Vishwam Akilam Nischitya Vacha Guru. Listen to the words of the teacher. Nityam Brahma Nirantaram Vimrushata. Can you look at what is there in you which is Sashwat, which is always there? Nityam Brahma Nirantaram Vimrushata Nirvaja Shantatmana Bhutam Bhavita Dushkritam Pradahata Samvinmaye Pavake Prarabdaya Samarpitam Swavapur Yesha Manisha Mama. I have a certain amount of prarabdha, a certain amount of karma that I have to go through. How do you handle it? If it is Prabala, it is very strong. I can't do anything about it. I accept it. I accept it gracefully. I'm not going to complain because I know I am the problem. I am the solution. I will leave you with two words, and this came from the former Nobel Prize winner and the Secretary General of the United Nations, a source of inspiration for none other than John F. Kennedy, who says two words which are very important. For whatever I've been through in my life, can I be grateful? Can I be able to say thanks? And for whatever is going to come in future, I have only one word, yes, I accept. Thank you very much.
Thank you, Dr. Timapegde. You have spoken wonderfully about a very sensitive topic, which is rarely discussed and certainly not taught in medical colleges. Thank you very much.
Sir, two small comments. I have been up like you, I have gone through the doctor part and the father part who has seen this situations. It makes you stronger and it makes you more compassionate and I think more mature when you're dealing with this thing. And second thing was, sir, with the younger generations now, they know everything, sir. The knowledge is booming, sir, on the net. So we need to tell them a lot more, sir. Because they ask. We don't want to tell, but they ask. I mean, just as small as my own observations, personal observations.
Okay, we move on to the next talk. It's by Dr. Suresh Nair, Petroclival meningioma, choosing the correct approach.
Outset, I should thank Timmappa, Kiran, my student Komal, and Shibu and all their team for inviting me for this great meeting here. And little bit from our, now we go to hardcore little surgery. I will try to finish it ahead of time allotted to me. But if I overshoot, please tell me 5 minutes time left. So I will talk to you about the petroclival meningioma, which is considered to be one of the difficult tumors in neurosurgery. So what is this petroclival meningioma? This is the fifth nerve here. This is the petroclival line. So tumors which arise medial to the fifth nerve entry point. So these tumors are called petroclival meningioma. Tumors which arise in the clivus, this one, they are called clival meningioma. Tumors which arise posterior to the internal auditory meatus, it is called just post CP angle meningioma. This is CP angle meningioma. Tumors which arise medial to fifth nerve, we call it petroclival meningioma. So there is another group of tumor which arise not medial to fifth, but in front of the seventh, eighth nerve. They are also grouped along with petroclival meningioma, because in a large tumor, it is very difficult to know from where this tumor is arising, because tumor will be attached into the clivus, petroclival line, this premeatal area. So you do not know where exactly the tumor is arising. Only at surgery, you realize this tumor is arising from petroclival area, because if a tumor arises from petroclival area, it pushes the fifth nerve posterior superiorly, as opposed to a tumor arising from the premeatal area. Premeatal area, the fifth nerve is pushed anterior superiorly. So at surgery only you may be able to realize where exactly the origin of tumor. And tumors which arise down in the clivus, we call as foramen magnum meningioma. So this is some of the classification which has come, which is a simple classification which was published by Professor Kawase from Tokyo. So he divided these tumors into upper clivus and divided into cavernous sinus type, tendorium type, and petrous apex type. And this is one article he gifted to me when I was in Kyoto in 1999. And this is the thing, this is the classical petroclival meningioma. Here, this is not coming. No battery here. Eh? Coming here? Here. I am not seeing this one here. This is the classical, this light is not coming, no? Coming, yeah. So this is the classical petroclival meningioma. You see the fifth nerve is pushed posterior superiorly. And this is the cavernous sinus type, where again the fifth nerve is pushed posterior superiorly, but this is extending to the cavernous sinus. This is the tendorial type. where the tumor is pushed the fifth nerve is pushed inferiorly. And this is the petrous apex type, where the fifth nerve is pushed anterior superiorly, as opposed to the other two petroclival. And this again is that important picture we showed. And this is how we classified in our institute. And so this is a tumor which is the classical petroclival meningioma. This is image wise, we are not sure whether it is pre-meatal meningioma or classical petroclival meningioma. This turned out to be a classical petroclival meningioma because the bulk attachment was medial to the fifth nerve. But on image, we are not sure whether it is pre-meatal or post-meatal. And look at the next picture. This turned out to be a pre-meatal meningioma. Here also, it looks more classical for a true petroclival, but this turned out to be a pre-meatal meningioma because the imaging picture will never tell us very clearly. Only at surgery, when we see the fifth nerve, whether it is pushed anterior superiorly, you call it pre-meatal. And when it is pushed posterior medially, we call it posteriorly, and superiorly we call it true petroclival meningioma. And for both these groups, 7th, 8th is pushed posteriorly, and lower cranial nerves are pushed posterior inferiorly. This is a cartoon which I have taken from Al-Mufti. Between these two groups, he has described just 2 layers of arachnoid in true petroclival, while there is 1 layer of arachnoid in this pre-meatal meningioma. This arachnoid duplication is more seen for a true petroclival meningioma. How about the natural history is extremely poor. This was a study which was done long back in 2000. Publication came in 2003. They followed up patients. More 70% of the patients they deteriorated on follow-up observation. And this is yet another study which got published later in 2017. Equally bad. Most of the tumors grew up to 2.38 centimeter cube every year. And they found that if untreated, these tumors gradually progress. So what are the risk factors of growth other than histology? Because, some risk factors are there for this tumor growth. So we know only of histological grading, and we now know that 25% of grade 1 and grade 2 meningiomas, they grow in spite of radical removal. Are there any other predictors of growth? And these are some of the things which people have found. When they have high proliferative indices, there is non-skull-based location, because skull-based location people have found relatively good prognosis. Peritumoral edema, when there is absence of calcification, intratumoral T2 hyperintensity in a young patient, and negative progesterone status. These were considered to be some predictors of risk factors for growth. But we always had this thing only, this grade of Simpson's removal and this grade to predict. Have we got anything at hand now? Now, current methods of identifying aggressive meningiomas focus on genomics. I am sure Tejpal will highlight on that, and we had great lectures in the morning. And now what we do is, we do focus more on genomics, proteomics, and epigenetic to understand meningiomas at these various levels. And now we have a better understanding of the various pathways of meningioma oncogenesis and their genetic landscaping. So this is what we do, is we look at genomic alteration, epigenomic alterations, and proteomic signatures for meningioma to predict their aggressiveness. And these are some specific mutations which we have seen in meningioma, which is broadly classified into NF2 mutations, those harboring NF2 mutations, and those harboring other than NF2 mutations. And we can localize these genomic alterations to specific anatomical levels. And this is, this different anatomical levels, we have found this specific mutation. So this is the era where we are going now. And also we have this proteomic analysis of meningioma, which has revealed clinically distinct molecular patterns, site-based differences, and we found that hypomethylation and focal DNA hypermethylation are both associated with tumorigenesis. So we are going into another era to predict meningioma landscape. And now going to pretroclival real surgical topics. So when you have a meningioma at hand, what do you do? So one is, you can observe, especially in elderly patients, small tumor, you can observe. But most of the time in India, why the time patient come to us, they are reasonably large tumors and they require either some intervention, either a microsurgical resection and radiation therapy. So let me tell, between larger tumors and smaller tumors, larger tumors, there is no other treatment other than surgery. And we cannot observe them, we cannot give them gamma knife, we have to go for surgery. How about small and medium sized tumors? And this is also very important. This, in our institute, it is the easiest time to take out the tumor when it is small. Because especially in an younger age group patient, so it is easy to take out this tumor when the size is small, because the most important determining factor for surgery is the consistency and the size of the tumor. If the size of the tumor is large, it is extremely difficult. But if it is small, say we used to go for surgery that time also. And what is the best approach for this tumor? So this bone, this is a petrous bone, it forms a big obstacle for us to reach this petroclival area. So we can come through the anterior part of the petrous bone, which we call anterior petrosectomy approach, or we can come through the posterior part of the petrous, which we call posterior petrosectomy. We can combine these two approaches also. And I will just show you, and also tumors which show very high extension, supracellular extension to the middle fossa. We do a cranio-orbito-zygomatic approach to look high up to remove that tumor. And for those tumors which extend down, we do retrosigmoid combined with far lateral approaches. So how do we decide? This is the upper clival area, from the floor of the cella to the level of the internal auditory canal, from there to jugular bulb, and from there to the foramen magnum. Upper clival tumor best to be removed through anterior petrosectomy approach. The zone 2 is best to be removed through a posterior petrosectomy approach. This is a rough guideline. So dorsum cella to the upper border of IAC, which we call zone 1, is best approach to the Kawase approach, which is called anterior petrosectomy approach. So zone 2 is the middle one from IAC to the upper border of jugular tubercle. This is a very good approach, posterior petrocell approach. And below that, it is through a lateral suboccipital plus minus run condylar approach. So what is this Kawase's approach, anterior petrosectomy approach? Ideal for upper half of clivus. We can access tumors which go to the paracellular area, including cavernous sinus. And we can access lesions which are also in the anterior part of the middle fossa, and also lesions which are anterior 1/3 of the tendoral incisura. And so what is the important thing is, no neurovascular structures are encountered during extradural bone removal. And then blood supply from the tendoral arteries are tackled very early. So this is just an example of a small petroclival meningioma upper third. We have removed through a Kawase approach, anterior petrosectomy approach. What essentially it is, we do a craniotomy, temporal lobe. This is a zygoma, you can see anterior, posterior. We do a craniotomy like that, and we come epidurally. Epidurally, temporal dura is retracted back, middle meningeal artery is taken out. We expose this greater petrocell nerve in the floor of the middle fossa, and then ultimately come to this area, this quadrilateral area, which we call Kawase's quadrilateral, which is lateral to, it is actually posterior to fifth nerve, this V3, it is posterior to V3, anterior to arcuate eminence, medial to GSPN, and medial to the petrous apex. And the C line is the line of internal auditory canal. So this bone, which is in front of ICA, this bone we remove. This is not this bone. This is the quadrilateral bone, which we remove in anterior petrosectomy, which is actually in back to behind V3, in front of arcuate eminence, and medial to GSPN. And this is essentially what I was telling, epidurally we come. And epidurally we come, identify GSPN here. And this exposing Cavaz's quadrilateral here, which is posterior to V3. And which is in front of arcuate eminence and medial to GSPN. And this is the bone we expose. After that, we drill out this bone to expose the posterior fossa dura here. You drill this bone, Cavaz's quadrilateral, this bone, you can expose the posterior fossa dura. You can drill till you see the inferior petrosal sinus. And after that, you open the middle fossa dura parallel to the superior petrosal sinus. Once you open the middle fossa dura, temporal lobe is retracted. Once temporal lobe is retracted, you see the tendorium. So you connect this superior petrosal sinus is ligated. You open into the posterior fossa dura which you have exposed. You can see the fifth nerve right there, and the tumor will be lying here. This is essentially the anterior petrosectomy approach. Just one example. This is a classic tumor which we operated some time back. This is a petrosectomy, anterior petrosectomy we did for this patient through a Cavaz approach. Let me see, this video will tell you everything. So this is, epidurally we are coming. Epidurally we are coming, we are stimulating for seventh nerve in the internal auditory canal, sharply dividing the periostea. This is the dura propria, or the middle fossa being elevated very sharply. So we can elevate this back till you can elevate the lateral till we see the lateral wall of the cavernous sinus. You can expose the Meckel's cave. We can keep on sharp dissection. This is sharply dividing the dura propria, or the middle fossa, over the epimerium, over the divisions of trigeminal nerve. More laterally we do over the mandibular nerve, more anterior laterally over the maxillary nerve. You can come into this plane, even through the superior V1 area at the superior orbital fissure. Now we are, here we are drilling the internal auditory canal, just to see the lie of the internal auditory canal, which is in front of the arcuate eminence here. And now again we are drilling more. Now we are going to look for the carotid artery there. So we are drilling over the carotid artery. This is the Cavaz's quadrilateral here, and this is carotid artery just below the GSP, and this just be lie of the carotid artery is just below the GSP and here, and this bone which down we see is the Cavaz's quadrilateral. So once we have identified carotid artery, once we have identified the lie of the internal auditory canal, then we can easily go and remove this bone, which will be, this is the carotid artery getting exposed. Cavaz's quadrilateral here. This is the internal auditory canal. Internal auditory canal, and just stimulating for just final drilling of the internal auditory canal, simulating for seventh nerve. Then we have to remove this piece of bone, which is the Cavaz's quadrilateral. And after that, we go up to right up to the fundus of the internal auditory canal from inside. Now removing the Cavaz's bone. Once we remove this Cavaz's bone, we can expose the dura of the posterior fossa, and we drill the bone. This venous oozing will come from venous plexuses there, and this is the last bit of bone being removed. Last bit of bone being removed from the, and then after that, after controlling that, what we do is we have to open the dura. We have to open the dura. Middle fossa dura is being opened parallel to the superior petrosal sinus. Now tendorium will start coming. This is white thing is the tendorium. So middle fossa dura is getting exposed, and after that retracting the middle fossa dura. Now middle tendorium is here, and middle fossa dura is retracted. You can see the superior petrosal sinus lying in the middle. That is the posterior fossa dura. And after this, we ligate the petrosal. This is a dura is being incised in the posterior fossa dura, and now we make a connection between these two, posterior fossa dura and middle fossa, by ligating the petrosal sinus. This can be done with hemoclips or with suture, and after you ligate that and open straight to see fifth nerve before us, which you can see just now. And once you remove that, the fifth nerve has appeared there. That is a fifth nerve. You can work above or below the fifth nerve. So dural sutures are put, tendorial flap is being reflected. Now removing the, dissecting the arachnoid, working below or above the fifth nerve, straight into the tumor. Now this is using CUSA. CUSA, the whole tumor, easily sectable. T2 hyperintense tumors are easily suckable. Whole tumor can be removed. This is this is a fifth nerve hanging in the middle. Tumor is coming out from the posterior fossa. Below and above, this is below, this is above, and you can see the brainstem there. One of the easiest approaches for a upper clival tumor. And now, these are this is the post-op picture of this patient, and these are some of the tumors which we have removed through Kawase approach. Can we do this for all upper clival? No, because the venous anatomy is very important. So normally, the superficial middle cerebral vein, it drains through sphenoparietal sinus into the cavernous sinus or early to the pterygoid plexus. But sometimes you have these veins draining through the middle fossa like this, the basal vein or a sphenopetrosal vein. So these are relative. This is a sphenopetrosal vein, this is a basal vein. If venous anatomy is like this, which is very rare, then you cannot do this approach through a epidural approach. That case, this was a publication from Manas side. He used to do through a intradural approach, but then the landmarks are not there. Intradural, you go in, you cannot deflect, say the Kawase triangle, because the other one, GSPN, will give us a clue where correctly which bone has to be drilled. Now, how about a large tumor? So large tumor which has high supracellular extension. So what we do, we used to come from anteriorly, remove the zygoma or the orbitozygomatic approach. We come from anterior lateral approach and then try to take out. You can see these large tumors going very high up. It is very difficult to come from middle fossa alone. We come from anterior corridor and take out the tumor. So that we do combine it with anterior lateral approach here. And how about such a big large tumor here occupying middle clivus going to the middle fossa? So what about this? Before this we use the posterior lateral corridor. So posterior lateral corridor, the important, this is called the combined posterior subtemporal pre-sigmoid, trans-sigmoid approach. So what is this approach? I will tell you. The advantage is these autological structures, we are working behind the labyrinth. Sinuses are preserved and vascularity interrupted early. And what is this tumor? This is, if you are seeing the skull base, you can see the transverse sigmoid junction here. So you have to make a craniotomy spanning the transverse sinus here. You can see 4 burr holes spanning the sigmoid sinus. You have to do a craniotomy like that, craniotomy from the middle fossa and posterior fossa, and you have to remove the bone in front of the sigmoids, and this is the craniotomy. Then we can see the sinus here, and now essentially it involves mastodectomy, exposure of sigmoid sinus, and we do a retrolabyrinthine bone removal, and we also do a retrosigmoid craniotomy. And this is open like that. This is the posterior fossa dura opened here, and this is the middle fossa dura opened here, and I will show you how we open that here. And this is the step. This is the posterior fossa dural incision is here, middle fossa dural incision is there. So we connect both together by ligating the superior petrosal sinus. Then we cut the tendorium towards the tendorial edge. We can expose the whole contents of the from second nerve right to the lower cranial nerves. We can expose like what we see in this picture. And this is the labyrinthine mass here. We work litro-labyrinthine in front of the jugular. Jugular bulb is, we work in front of the sigmoids, and in these structures we can see if you open correctly like that. So this is a very good approach. We can expose tumor from middle fossa to jugular bulb area. There is no retraction of the cerebellum. Operative distance to the clivus is reduced. And this is just one operative video. Again, we are drilling the retrolabyrinthine petrous bone. We are removing, we have exposed dura in front of the sigmoid sinus. We have done a temporal craniotomy, exposed the middle fossa dura. I will just run if I can. Oh, I cannot run it here. That is the problem. Okay. So actually, I have transferred my presentation to a computer. Now I cannot run it very fast. Okay, so this is what we do is, we expose the dura in front of sigmoid sinus, labyrinthine structures are kept intact, middle fossa dura is there, posterior fossa dura is there, and now this is what we are cutting the we are, still we are drilling the bone. Bone we are drilling in front of the sigmoid sinus. So we have the middle fossa dura, posterior fossa dura, and ultimately we open the dura in front of the sigmoid sinus. We open the dura, middle fossa dura, connect that by ligating the superior petrosal sinus, then cut the tendorium right up to the tendorial edge, and then we expose the whole tumor there. And it becomes such a, this is cutting the tendorium right up to the tendorial edge, and then the tumor is getting exposed and we can deliver the whole tumor out. The difficulty with only a fibrous tumor, the tumors which are T2 hyperintense, it is relatively easy to remove. And you can see the fifth nerve appearing there. Fifth nerve appearing there, the whole tumor is getting, this is a labyrinth which we have preserved. We are working behind the labyrinth in front of the sigmoid sinus. Jugular bulb there, temporal fossa there, the whole tumor is getting out. So it's a simple approach, but a time-consuming approach. And let me run for want of time. I have 6 minutes only. So again, some difficult problems. It all depends upon how vein of labae length. Sometimes the vein of labae will run through the tendorium. In that case, it becomes very difficult because you cannot cut the tendorium there. This the whole thing depends upon cutting the tendorium. This is the posterior fossa dura, middle fossa dura. You ligate the superior petrosal sinus, then you have to cut the tendon. But if this sigmoid, this vein of labae, if it is running through the tendorium, you cannot cut. It becomes a problem. What happened in one of a patient developed venous infarct. You can see the venous infarct which developed because vein of labae got injured. So we have a combined approach. We combine both anterior and posterior petrosectomy for very large tumors. Like we did for this case. We did it in one sitting. First we went from posterior petrosectomy, then we went from front and finished in some 12 hours, we removed the whole tumor. And now what people have learned over the years, after doing so many cases of the CP angle tumors and acoustic neuronoma, people have realized it is size and consistency, and arachnoid will decide the approach, not that various fancy approaches. So people have found that the retrosigmoid approach is okay for this tumor. The retrosigmoid approach, you work behind the retrosigmoid here. This is a pre-sigmoid approach. So this is, it's a very old-fashioned approach, but people know that working area for petrosectomy approaches and retrosigmoid approach, what we operative surgeons, what we get is essentially the same working space. And this is because of acoustic neuronoma surgery, we do all this surgery there. So we are very well versed with the retrosigmoid surgery. And another advantage of this is a pre-sigmoid surgery, you cannot see the clival pit there. Clival pit is inaccessible through a pre-sigmoid approach. While you see here, clival pit is accessible through a retrosigmoid approach. That is extra advantage. So this is an old-fashioned approach. People have found that many people, Professor Same, Briccolo, they have found that it is not the approach which matters. It is the anatomic and pathological characteristics of the tumor. It is a very familiar approach. No venous major structures there, and tumor itself will give us way using para-supracellular avenues. We can expose the tumor. This is incision, we give lacy as incision. Key is exposure of transverse sigmoid junction and sigmoid sinus, and transverse sinus has to be exposed. Once you expose and retract the dura, you get a lot of space to work through supra-paracellular approach. Like in this one patient, a large tumor there, petroclival lesion, which we have removed. We can show at least one video. So here we are working, only thing you are working between the cranial nerve. You are seeing the lower cranial nerves here. You can see spinal accessory, lower cranial nerve. 7th, 8th, you are working between the corridor between lower cranial nerves and 5th nerve. So this tumor gives you space, especially if the soft tumor, easily you can remove. As we are doing in this case, I don't know how much this video will run, I don't know, because I cannot forward it now. You can see spinal accessory, lower cranial nerve, 7th, 8th here. So all the corridors we can use. And this now we will work above the 7th, 8th. This is below the 7th, 8th, above the 7th, 8th, between 7th, 8th and 5th. All the corridors we are using, and ultimately this tumor also can be removed. I will skip this video for want of time because this tumor is removed totally, and this is at another video. And you can see the sharp dissection which we use with the sharp micro scissors only. sharp scissors or needle, he can open the arachnoid. Meningioma is extra arachnoid tumor. Acoustic neurinoma is a subarachnoid tumor. So essential difference is that, so arachnoid will help us to go ahead. And some disadvantages, extension to cavernous sinus, Meckel's cave is difficult. And sixth nerve you see only in the end of surgery. But then this is all some of the tumors removed through retrosigmoid route, but you can use the suprameatal drilling if you can remove a tumor in the Meckel's cave or in the middle fossa, just like we have done in this patient. So now what we have found is many people have done a two-stage simple approach. One is first stage do a retrosigmoid, then come from front subtemporal anterior approach to two-stage simple approach. This is what Professor Same is suggesting, and don't go for extended approaches. So also there is endoscopic approaches are coming for petroclival meningioma. Main culprit is the sixth nerve carotid artery. Tumor is in this yellow circle. Sixth nerve is in front. So it removes lot of work there. Tumors which extend laterally cannot be removed. Carotid artery has to be mobilized. So people come through transmaxillary, transpterygoid approach, go through, see the foramen, lacerum, go up, isolate the carotid artery, mobilize the carotid artery and reach this tumor. Essential step is to remove the petroclinoid ligament. And this is removing the petroclinoid ligament. Posterior clinoid meningioma arising from posterior clinoid, relatively easy to remove through endoscope because the sixth nerve is pushed down, and also tumors arising from lower clivus. Here again, it is relatively easy because sixth nerve is pushed up. This is our experience there. So we have done most of the cases we are doing through very large hectic approaches till 2003. After that, 44 of the 60 petroclival meningiomas decompressed after 2004. It was through routine retrosigmoid approach. Initially, it was all same, anterior lateral, petrocell, but after that, there is a jump in retrosigmoid approach. And so over time, we have moved away from performing complex, large transpetrosal approach to simple retrosigmoid approach, and radicality, subtotal, shunt, this is our thing, and no surgery without complications. So we had lost 10 cases. And most of the only 2 cases we have lost in the last 60 patients operated since 2000. Initially, we had high mortality. And this is all complications. This surgery, you can see new deficits. Many of the patients develop new deficits, prolonged ventilator care, tracheostomy. You see on follow-up, 98 patients severely disabled, moderately disabled. It is hard truth only. It's very difficult surgery, but we used to do this difficult surgery. However, radiotherapy, we never used to give upfront, only if they show symptomatic recurrence. And now today's patients, they don't want any complications or anything. So what we have in hand, we have just finishing. So what we have in, this is a series from Walker, Seifert. He has told mortality for surgery is very high. And is there anything other than that? So there is, even though there is no class 1 evidence to support gamma knife treatment with surgery, this paper shows that it is the radiotherapy, gamma knife surgery and surgery, they are almost same. And neurosurgeons must be careful not to turn cure into something worse than disease. And in particular, the benefits of complete resection must be weighed against the possibility of associated morbidity and even mortality. This is our series. We had 7% operative mortality. It is comparable for these large tumors. So we have moved away from early skepticism with fanaticism or over application of skull-based approaches. We have reconciled, we understood morbidity and mortality and matured by doing simple approaches. So this is what one should have. At one end of the spectrum, you should remove the tumor with gross total removal, or other end of the spectrum, quality you should maintain by doing some functional preservation. But you have to take a in-between stand. Subtotal removal with radiosurgery is being considered now. And so this is surgical mortality has reduced over years. Approaches should be tailored, and we are humbled to learn that less aggressive approach these tumors result in better. So we have some publication. At least I will tell people to, this is our meningioma publication. Most of it is from posterior fossa, and this is a cousin of that vestibular sarcoma publication. But this publication, if you can read, you can give a grasp of petroclival meningioma surgery. Thank you very much. I can go.
Thank you, sir, for that wonderful lecture.
You have to give.
So one question about this.
Yeah.
Do you think the change, the other day we heard Professor Mishra also, he was also saying how we are coming to more standard approaches. So is this all related to CSF leaks? Is it because
No, why we have
changed to a more simple?
morbidity only.
Mainly CSF leak or other morbidities? Everything.
Morbidity, weakness, hemiparesis, CSD, at least we can manage, but it is a big complication. But mainly because of severe deficits. You have seen severely disabled patient, moderately disabled. It is easy to tell severely disabled, moderately disabled, tracheostomy. So it is a big task. We used to do all aggressive surgery, but we have come down. Last 60 of my cases, I have lost only 2. But through this retrosigmoid, which I could remove.
Any other questions? Residents? Or you had enough of sir yesterday? Okay, thank you. Next, let me invite Dr. Arivargan for his talk on surgical adjuncts in glioma surgery. Okay, this wrong picture here. You've got the wrong man. Ari, it's you only. Ah, there.
Name if you put my name. So what happened? Any connection problem?
Professor Vijay.
Should we go to the next talk?
Times
Let's
works.
come.
No, it is. He's connecting, but it's going off again. I don't know why.
Problem.
No, did I? No, HDMI. I tried VG also.
Oh, okay.
No?
Yeah.
Okay. Fine. Okay?
Yeah.
Yeah, I'll do it. come, but
It's going.
but this is
Check the monitors.
oh, it is not okay. No problem. I'll do like this. Okay. Sorry for the hitch. I first thank the organizers, Dr. Hegde, Dr. Komal, and Dr. Shibu for inviting me and giving me an opportunity to talk here. After the complex talk on scale base, I'll make things simple. So I'm going to talk about the various agents we use in glioma surgery. Though the surgery for glioma is often considered simple, these patients can have significant morbidity as well as mortality. So the whole goal of surgery should be to provide as much best outcome to the patient with as minimal morbidity, not only in the form of neurological morbidity as well as in the form of cognitive and quality of life morbidity. That is the cornerstone of today's treatment of glioma. I think gone are those days when we talked about patient, whether patient is alive or not, whether patient is moving all four limbs or not, whether patient is ambulant or not. Now is a time when we need to talk whether this patient, after the composite treatment of surgeon and oncologist, is able to lead a meaningful life with his family as well as with the society. So that is not, that cannot be achieved with just one person. Like the slide shows, management of glioma involves a lot of people, neurosurgeon for surgery, as well as for diagnosis, oncologists, as well as support from psychology and counseling people. So across this, in today's date, it's not enough to talk about overall survival and disease-free survival. One has to talk about the quality of life and cognitive functions in these patients. And there are a lot of progress which happens in various treatment modalities as well as these adjuncts in form of radiation, chemo, and immunotherapies. Let us see what surgery can do to these patients. There was a long debate as to whether the extent of resection is really influencing the survival of not. There are papers for and against, and this is the latest meta-analysis of more than 40,000 patients of glioblastoma from Savaya's group who have shown clearly that most of the studies favor gross total resection of the tumor compared to subtotal resection. And what is the question asked? Whether extent of survival, extent of resection increases survival or not. And they noted from more than 37 studies involving more than 40,000 patients that use the gross total resection, in fact, reduces the mortality at 1 and 2 years of period. Therefore, highlighting the importance of extent of resection in these patients. The extent of resection can actually be limited by the eloquence of the brain in which the tumor occurs. As you can see, tumors in and around the eloquent regions have less chances of complete resections while compared to non-eloquent regions. And let's go about what helps us in increasing the extent of resection, or what helps us in improving the outcome in these patients. So our goals in this glioma surgery has to be simple and two. One is increase the extent of resection, thereby improving the outcome. And second, to increase the safety of surgery, thereby you do not give an extra morbidity to the patient in your quest for increasing the resection percentage. So how the technology has helped us to increase the extent of resection. You can use various forms of intraoperative imaging like an ultrasound or MRI. Also, you can use a new imaging or visualizing techniques like fluorescence guided surgery, whether you use 5-ala or a fluorescein. The second goal is to increase or to maintain the safety of your surgery vis-a-vis extent of resection. And what technology can help us? One is you can be guided by neuronavigation during the surgery. And the second is to make sure you monitor the patient during the surgery, either using awake or mapping the motor or language functions, and as well as the higher functions while you remove the tumor, so that the patient does not incur an avoidable neurological deficit. So these should be the two cardinal goals in management of glioma surgery. So how these technologies help us, I'll just go through one by one as an overview. And navigation, I think, has now come a part of our armamentarium in most of the centers. For surface gliomas, is it really helpful? There are a lot of discussion about the brain shift as well as the loss of accuracy and all those things. Yes, You can use navigation in case of subcortical tumors where they don't come into picture, or you can use navigation as one of the ways to identify the eloquent cortex like motor cortex before you start the surgery. In case of diffuse tumors where the tumor is not seen clearly on the surface, then navigation will help us. And also there can be challenges in navigation, like once there is a large cavity, the accuracy of the navigation may be lost. However, navigation definitely helps us in marking the flap, marking the tumor, as well as marking the eloquent region before starting the tumor decompression itself. Next is use of intraoperative imaging. I'll just touch upon the two techniques which are now used. One is intraoperative MRI. A lot of studies now which show that the extent of resection with intraoperative MRI improves as compared to non-intraoperative MRI. Similarly, you can see that it's more useful in non or minimally enhancing tumors, because these are technically tumors which are difficult to identify during surgery, whether one has resected it completely or not. And that is where the either intraoperative MRI or ultrasound helps us to show that there is actually a residue present which may not be identified under the microscope or by the neurosurgeon's expertise. So this is an example where you can see that after the partial resection, you can identify residual tumor, and then complete resection. The second resection can achieve better results. So this curve shows that the survival also improves in patients who underwent surgery with intraop MRI technique as compared to those who did not have intraop MRI. However, there are meta-analyses after this study which has pooled data and show that as of today, the data is not from the meta-analysis, that we don't have strong data to show that this IOMRI has significant improvement in outcome. Definitely it increases the extent of resection, but it may sometimes not reflect on the outcome. So these are intraop MR setup where we have an hybrid OT, where the MRI is linked to the OT just across the door, and a patient is positioned there. We need special tables and special equipments as well as head holders so that you can do an intraop MRI. It is time consuming, but over a period of time, once the workflow is maintained, the time can be reduced about 30 minutes. And this is an example where you can identify a tumor on the diffuse tumor, and after surgery there is a residue. First time surgery there is a residue, and which after intraop MRI and resurgery you can see that can be completely resected. Second is ultrasound. I think Dr. Ali is going to cover this in detail in the afternoon. So I'll just mention that because I like it so much. It gives you an opportunity to do it multiple times. And this is an case where you can see a diffuse glioma involving left frontal lobe going across the corpus callosum to the opposite side. And then DTI shows the fibers are closed posteriorly, and navigation can tell you the extent on the anterior, medial, and posterior surface. And you can do ultrasound, and if you have a 3D ultrasound which can be navigable and can be merged with the MRI, like I hope it plays. So one acquires ultrasound images in the two directions, both anterior, posterior, and medial lateral, and this can be merged with the MRI. Your preoperative MRI, and then this ultrasound can be converted into a navigable ultrasound, and so that you don't have to do multiple time MRIs, whereas you can do ultrasound multiple times and re-register them to give you better findings. So this helps you to improve your extent of resection. Like you see in this study where they have analyzed all the literature on ultrasound, you can see that the extent of resection can be improved in across various types of tumors. And extent resection ranges, GTR ranges anywhere from 70 to 90% where ultrasound is used. So between the two techniques, intraop MRI and ultrasound, the resolution is very good in MRI as compared to ultrasound. Ultrasound requires expertise and training because the images are always not axial, coronal, or sagittal. However, the presence of high cost as well as the cumbersome and time-consuming break in surgery in MRI actually is a dampener when compared to ultrasound. User dependent, of course, MRI is better because it gives you the same kind of images that you're trained with, whereas an ultrasound, one need to be using it regularly to understand the type of images that you get on the table so that you recognize which is a residue and which is not, and orient yourself to the cavity and the tumor. Going to the next, the fluorescent guided surgery, there are two types mainly, fluorescent and 5-ALA. both work on the principle of the breach in blood-brain barrier, and you give a dye which lights up the tumor because of the breach in blood-brain barrier, and as compared to the surrounding peritumoral normal brain tissue. So this is yellow fluorescence with a 560 filter. You can see the tumor is seen in yellowish green stent as color as compared to the pinkish normal brain, and can be used for identifying the tumor in the depth. The advantage is that it shows up the residual tumor. The disadvantage is it does not show the depth. It only shows the area what is exposed under your microscope. So, so you don't get the depth perception as to how far the residue is there, which can be obtained from an ultrasound. So basically all these are complementary to each other. It depends on how you club them for your surgeries to give the best outcome. The second drug which is used is 5-ALA. It's more costly compared to fluorescein, and I hope this video plays. I don't know, because I cannot use this. I need the control of the screen because otherwise I can't play the videos. Okay, yeah. Yeah. So this is this video is from Dr. Ali, which you can see that after switching over the filter, you can see the tumor, residual tumor is clearly seen pinkish compared to the normal bluish tinge of the brain, and it can be resected completely, keeping keeping the filter settings, and this can help you to resect the tumor completely. And a lot of data exists which show that extent of resection definitely increases with the use of 5-ALA. And this study shows the pattern of use of various modalities, intraop MRI or 5-ALA ultrasound across the neurosurgeons in Europe, and show that it is not uniform. It's heterogeneous depending upon the availability as well as the experience and the options of the surgeon. Next, let me go to the preserving function. What we saw are all those technologies where you can, this technology can help you to increase the resection, but also one should remember that you should maintain the functional preservation, and various techniques can help us in doing that. One is navigation, second is stimulation, and preoperatively you can use the DTN of the corticospinal tracts to identify how close the tumor is to the eloquent region. So these are divided into three time zones. One is preoperative, second is intraoperative mapping, and third is intraoperative monitoring. Preoperatively, one can use fMRI, MEG or TMS for cortical, as well as DTA for subcortical identification of the eloquent regions in relation to the tumor. And intraoperatively, direct cortical stimulation or the subcortical stimulation can be used, both for motor as well as language functions. Intraoperatively, again, you can do direct continuous stimulations, or you can do repeated direct cortical stimulations for motor, as well as language monitoring can be done using the bipolar for the surface and monopolar for the subcortical regions. A question often discussed is whether one should do awake surgery or asleep surgery in case of lesions. For language, this question does not arise. You need to do awake. For motor mapping, it again, in my opinion, it's a surgeon's preference. But if you look at the data from the meta-analysis, what they show is there is no difference in the deficits when whether you use awake surgery or the asleep surgery for lesions in and around the motor cortex. The extent of resection is slightly more when you do awake surgery, 90%, compared to those who underwent surgery with general anesthesia, which is 80%. However, the neurological deficits, whether early or late, severe, non-severe, appear to be similar whether one does the surgery under awake or asleep. Again, I think this depends on the surgeon's expertise over a period of time and how one is comfortable using this technique during the surgery. This is a paper which I think Dr. Anand alluded in his presentation by Dufo. He has shown extensive resection between of low-grade or non-malignant, low-grade gliomas, non-enhancing. And in his data, he has compared pre-96 and post-96, where use of intraoperative monitoring has definitely increased in the. He says used of this method, that is the cortical stimulation or electric stimulation, leads to extensive of indication of low-grade glioma surgery and with reduced morbidity in these patients. Again, there's a meta-analysis which shows those patients who underwent surgery with intraoperative monitoring had significantly longer survival when compared to those who did not have intraoperative monitoring. Basically, it's an increase in extent of resection, and therefore which translates to increase in outcome in these patients, thereby making a very strong reason to use these techniques whenever the patient has a tumor which is in and around the eloquent region. So I'll just show some few examples and end it. So this is a young boy with a large tumor, which is near the region of ambient system, probably pressing on the region of hypothalamus. So if you go by normal, regular understanding, one may not want to use it monitoring. In this case, if you see clearly, the motor fibers will be at this point will be related to this tumor posteriorly and inferiorly. So various approaches can be used. In my mind, I thought the safest approach for this tumor will be transtemporal, transventricular, because if you come from the top, I'm going to transgress the corticospinal tract fibers, and this is through transinsular is going to be again, it's a left side, so it's again going to be more morbid. So this patient underwent temporal craniotomy, mid-temporal gyrus, transventricular, and access was from the roof of the temporal horn. And I hope I get that. Yeah. So as expected, we got the corticospinal tract stimulation subcortically in the posterior part of the tumor, so that we could preserve the function and preserve or avoid damage to the tumor, damage to the corticospinal tract at the depth, and the tumor could be resected completely. So this is a post-op MRI where you can see that the tumor is completely resected. The access is from the middle temporal gyrus, transtemporal, and this is a patient post-op with no motor neurological deficit. This was actually a pilocytic astrocytoma. I think this is one of those optochiasmatic glioma complex arising from the optic tract region. He had homogeneous hemianopia preoperatively. So what is this all about? Is it all gadget intensive or requiring expertise? One needs this help us to give improved resection and safety. Yes, of course. At the same time, there are problems in having all of this because this is not available everywhere, and a lot of cost implications are there in many of the technologies. Expertise is not available across the spectrum. And should this restrain practice, saying that if you have a patient with eloquent cortex tumor, unless you have all of this, one should not operate? I don't think so, but one has to be pragmatic in choosing what technologies are required to manage a particular tumor. So if you look at it, if there's a tumor which is well-defined high grade, probably you may not need anything unless it is, I'll come to the other part of it. Navigation will be helpful. The 5-valve or fluorescent, if it's available, can be used to increase the external resection. IOMRI is a high order one, can be used if it's available. If it's an ill-defined lesion, definitely for increasing the extent of resection, navigation will help for initial marking, and ultrasound preferably, because you can do multiple times, or if you have MRI, will be definitely useful to help you to achieve better extent of resection than not. Regarding adult or child, if a patient is adult in an eloquent tumor, it's better to do awake surgery. I would do awake surgery both for left and right side tumors. There are a lot of discussion whether you really need awake surgery on the right side or not. That's left for interpretation. In child, obviously, we don't have a choice. We need to do under anesthesia. Again, depends on the location. In a non-eloquent, a tumor present in a non-eloquent region may not require any of these gadgets. If it is present in an eloquent region, then it is better that one uses this direct cortical stimulation and subcortical stimulation, both for motor or language, depending upon the proximity of the tumor, because this is definitely going to increase extent of resection as well as improve the safety of your surgery. And before all this, in patients with where MRI shows glioma, it is always better that you do a fMRI and DTA in tumors related to eloquent cortex and a neuropsychological assessment in all the cases to actually know what is the extent of cognitive dysfunction that this patient has. So a few representative cases. This middle-aged man with a left frontal glioma from inferior frontal gyrus who presented with seizures, and he was operated under awake surgery, and the most important was to make sure his language is preserved. Language assessment in surgery is not just asking him to tell 1, 2, 3, 4. One needs to go beyond that. We need to be able to identify the anomia, as well as to understand the interpretation, or as well as to keep his judgment intact, because subcortically you can injure the arcuate fibers and resulting anomia, even though he is able to just tell 1, 2, 3, 4. As you can see here, our neuropsychologist is the audio coming? So here the neuropsychologist is asking him to identify the drawings. It is not just telling 1, 2, 3, 4 or January, February. And here the psychologist is asking him hypothetical questions and asking him to answer to see if his judgment is intact.
ఎండాకాలంలో మనకి ఎక్కువ వేడిగా ఉంటది, తక్కువ నొప్పి ఉంటది.
So, no, but the audio is completely gone now.
Yes, it's coming. It's connected.
But are they hearing?
No, it's connected.
No, it's going there. I think audio. Yeah. So language assessment in surgery is actually complex. It's not restricted to saying 1, 2, 3, 4. One need to assess whether he is able to identify structures, shapes, or objects, and also see whether his judgment and understanding is intact. So here she's asking some hypothetical questions and asking him to answer, as also to react to situations. So he underwent a surgery without any both cognitive as well as neurological deficit. This another lady, this is another patient who was earlier operated for GS secreting adenoma. He came back with seizure and had a tumor on the right side, insular region. And he also underwent awake surgery. So what are the gadgets I would use? Because he's an adult, I would do awake. Some people may do under anesthesia. He underwent fMRI and DTI preoperatively. And during surgery, we used ultrasound as well as this scan. He underwent DTI, which shows clearly that the tumor is bordering pushing the corticospinal tracts medially. You can see the coronal as well as in axials. So he underwent surgery using ultrasound guidance, direct cortical stimulation, as well as subcortical mapping. And tumor was removed through transopercular approach. And here in this kind of tumors, the extent of resection is restricted by the eloquence, not by only the morphology. So this ultrasound helps us to do multiple times in multiple phases the imaging to tell us whether what is the residue. The 5-ala fluorescence will only show us the cavity, but it won't give us the depth, how much residual tumor is there. And of course, this is subcortical mapping where we stop once we got the.
No. Yes.
So as I keep on increasing, stimulating, once we find that there is at 5 milliamps, there is a stimulation and the response, we need to stop. So this is a post-op, this is a pre-op and post-op MRI, where you can see the tumor is resected, and this is how the fibers which were initially displaced by the tumor is coming back to the position. And I hope this was an anaplastic astrocytoma grade 3, so he underwent radiotherapy, and this is follow-up imaging at 15 months. He has no neurological or cognitive deficits post-op. He has taken radiochemotherapy, and this is a follow-up now. He is more than 2 years follow-up, doing well. This is another lady, tumor with left insular glioma, involving both frontal and temporal opercula, and MCA buried inside this, only presenting with seizures. fMRI actually showed language to be far away. However, we knew that the arcuate fascicles are going to be very closely involved in this tumor, and this DTI, which again shows displacement of the corticospinal tract medially. And she underwent awake surgery, left side, used direct cortical stimulation and subcortical mapping of ultrasound, of course. We need to map the speech area before tumor decompression, identified, as well as at the depth, when you reach subcortically posterior temporal, we need to look for it, whether we are damaging the arcuate fascicle or not. And lenticular striate branches will be the medial limitation for our surgery. So again, this is analyzing comprehension in the patient. The psychologist is asking questions for which he has to give answers. I'm not sure the audio is being heard. This is yeah. 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 So as we stimulate the left posterior inferior fontanelle gyrus, she suddenly stops talking, and that identifies the area of the speech. And as we decompress the tumor, another important landmark is to identify the lenticular striate branches in the depth. And once you reach that point, you'll have to stop because further decompression can cause hemiparesis and injury to the vessels. So this is a post-op imaging again, which shows almost near total decompression. We had left a small part here. She had again a grade 2 lesion with small residue, and therefore she underwent adjuvant therapy. She had anomia for a period of 7 to 10 days post-op, which was transient, which improved over time. So in conclusion, how do we use all these technologies? We need to use these adjuncts pragmatically. It depends on the imaging characteristics of tumor, whether it's well-defined or ill-defined, extent of the tumor, how much this tumor involves the eloquent cortex. Eloquent cortex does not mean only the motor cortex. We need to look for motor cortex, language cortex, and importance subcortical fibers, which even if you preserve the primary motor cortex, if the subcortical fibers are injured, it can cause deficits. And of course, the age of the patient will decide whether you can do awake surgery or under anesthesia. And what should be the goal for this surgery? It should be very clear. We need to make sure we can provide comprehensive improvement, not only in survival, but also in neurological function, cognition, and quality of life in these patients. Thank you.
Very wonderful, very nice talk, Dr. Hari. We can have some questions and some comments, please.
Ani, you would have listened to Charlie Dio.
Yes.
He doesn't use any of this. He just uses visual, auditory, and tactile cues to remove this glioma. You have seen, no, optimally invasive. He doesn't call minimally invasive, very small incision. His trajectory is perpendicular to the long axis of the tumor. And all gliomas he removes using tactile, visual, and auditory cues. It is a lecture I don't want to give, but he says nothing is required, and he removes in toto, and he shows all pictures, survival, I don't know. You would have listened to his talk.
Yes, sir. I will answer to this question. I think we listen to a lot of lectures in the conferences, but only we know how the patients do after the surgery. Like I said, these are the technologies available. It depends on the surgeon to decide what is good for him and what is good for the patient, how he can make the best use of it. If he, as we have listened to Dr. Dufo, he says he uses only electrophysiology. He does not even use microscope. Dr. Dufo says, I don't use microscope, only loops. He has an expert neuropsychologist and a monitoring person inside. No ultrasound, no MRI, all this fluorescent guided surgery. His strength is using the electrophysiology and neuropsychology intraoperatively, operates everything awake. If you listen to Berger, he may say he will use all those technologies and improve it. Finally, it depends on what a surgeon is comfortable with, which technology helps him to give the best outcomes. I do not believe that you can assess the function of this patient, or you can preserve the functions of this patient without keeping him awake or without using technology. How much ever your eye is clear, it is not going to show the corticospinal tract or arcuate fasciculus. You either use electrophysiological monitoring or keep awake. None of this, just microscope is not going to show us corticospinal tract, all of us know. So there is going to be a deficit if one claims that there is no neurological deficit without using any of technologies. I think we'll have to take it with a pinch of salt. At the same time, it should not be an overkill also. It should not be that only if you use intra-op MRI and intra-op ultrasound and all these techniques you can achieve good resection. I think that is also not true. I think the truth is somewhere in the middle, and I believe it depends on the surgeon as to how much he uses the technology to deliver a good outcome for the patient.
There's one more question. Is awake surgery or non-awake surgery? Where you forget about diffuse series, where you tend to leave more tumor. I think awake you tend to leave more tumor because they start developing some deficits. You leave and come. Well, other thing you don't know. I think some cities they have told awake you leave more.
No,
you told the other way around.
No, sir. Actually, that's why. Again, one is personal experience, other is data. If you go by data, because data, that's why I picked up the meta-analysis, because the authors of the meta-analysis are not passionately attached to the data. If I write my series, I'm going to show what I present. Whereas the meta-analysis is an analysis of others' data. If you go by the meta-analysis, they show the extent of resection is better with awake while compared to under anesthesia, whereas the morbidity is almost similar. Non-severe morbidity is 28% in awake surgery versus 20% in anesthesia, and severe morbidity is 4 and 2%. So it's not statistically significant. It comes again, it depends on the surgeon's preference whether he is comfortable doing surgery awake or not. In our own hospital, we have a big number of consultants. Some prefer to do under anesthesia for motor mapping because they're comfortable that way. I am comfortable doing under awake because it gives me confidence, and I personally would remove more tumor when I have a patient awake because I'm able to test and identify, and so that it gives me a better control on the surgery, and I would probably remove more tumor if the patient is awake. Of course, there are areas where there can be transient deficits. You need to identify it over experience, and that does not stop the surgery during that period. And then you proceed further, and you know that this tumor can be removed, and you proceed further. There can be a transient deficit which will improve. Yes, sir.
Yeah, just the qualifier for what Dr. Suresh Nair said. Awake surgery does not always, in common parlance, means we are using cortical mapping and deep white matter stimulation. So awake with cortical mapping and deep white matter stimulation, you can definitely achieve good extent of resection.
Correct.
But if you're doing awake only as just awake anesthesia, without mapping or deep white matter stimulation, you will leave behind a lot of people.
Yes, that I think now only awake surgery is really not going well, because that is you are waiting for an accident to happen, then trying to find out. You need to keep the patient awake to help your mapping or monitoring better. You identify prior to causing damage so that you can stop. That's where this subcortical mapping, it helps you 10 milliamp, 5 milliamp. You can go up to 3 milliamp, 2 milliamp, and then you can make sure it doesn't cause a deficit.
Yeah, a few comments on this. And actually, on the surface that we do the mapping to find the speech area, but most of the surgery is done intratumoral, the suction part. That is what Charlie too was mentioning. His argument and his way of doing is that he has more used to the suction rather than, that's where the discussion came. The tactile sensation and the hearing, what he hear when he suck the tumor and you will reach the white matter area, it's different, right? But the similar thing, but it was demonstrated also. It was demonstrated. I think he demonstrates, number one. Number two is, but the same thing, it is not possible in QSA. When you use the QSA, it goes. You don't get the tactile sensation, rather, you don't get the what we hear. So basically, in a small tumors, once you get inside the gliomas and you start sucking out, it's quite simple until we come to the edges. But there, the ALR can be useful, and also the electrophysiological, that is direct stimulation. I also prefer more of direct stimulation when you come to that, but we don't use of much of ultrasound, but more use of electrophysiology.
And what he essentially says is, you reach the normal brain, it will show some petechiae, which will not be there when you start sucking out tumor. And then the sheeting thing will come with tumor report from the normal brain. And then you violate the bubbling thing will come if it is a tumor. This is what auditory, visual, tactile, who's here. But when you use a suction, when it reaches the normal area, petechiae will come in the normal area. It will never come in the.
I think we'll stop here.
You use-
Only thing I would like to say is that I think whatever we show and teach, if it is reproducible by another surgeon, then only it will become helpful. If it is done by only one person, that information is not helpful for others.
That makes sense. I think we'll go for the next.
Thank you very much.
Thank you, Dr. Hari. That was wonderful talk. We move on to the next topic, meningioma, integrated classification and radiotherapeutic management in the molecular area. Dr. Tejpal Gupta.
Hello, good afternoon, everyone. Are my slides visible? Am I audible?
Good afternoon, Dr. Tejpal. Dr. Tejpal is in Mumbai. He's a professor of radiation oncology and secretary of Indian Society of Neuro-Oncology. So he is joining us live from Mumbai now. Professor Tejpal, please.
Thank you. First of all, I'd like to thank Dr. Komal and the Narayana team for organizing this Neuro-Oncology Symposium. I hope my slides are visible. So I will take you through the integrated classification and radiotherapeutic management of meningiomas in the molecular era. So as we all know that meningioma is the most common tumor of the CNS, comprising nearly 1/3 of all primary brain tumors. And the incidence is increasing with increasing age. Traditionally, meningioma has been considered a surgical disease, and it indeed is a surgical disease. And local recurrence rates over the last 50 years have been stratified by the extent of resection. As the Simpson grade of resection, which was given in the 1950s, still is valid as of today. And based on the Simpson grade of resection, the 5-year local recurrence rates have been seen. So Simpson grade 1 resection is associated with less than 10% recurrence at 5 years, whereas subtotal removal of tumor, which is Simpson grade 4 or a biopsy, is associated with more than 40% and 90% rates of progression at 5 years respectively. So we all know that extent of resection is an important consideration in meningiomas, but certainly not the only factor which is predictive for recurrence or progression. And there are several prognostic classifiers in meningioma. Of course, the histological classification by the WHO into benign, atypical, and malignant has been there for some time. Also, more recently, the DNA-based methylation classification into benign, intermediate, and malignant was proposed. Researchers have also used a multi-omics platform to define 4 molecular subgroups of meningioma. An integrated molecular grade now defines them or classifies them into grade 1, grade 2, and grade 3, which integrates histological grade with some molecular alterations. And finally, a hierarchical integrated morphomolecular model, which classifies meningiomas into low, intermediate, and high risk categories. So many of these have been unraveled in the last decade, and we need to use them more frequently in our therapeutic decision-making process. So the WHO histological grade has been there for more than 40 years. In 2007, there was a modification to the grading of meningioma, and subsequently in 2016 update, brain invasion was included in addition to more than or equal to 4 mitotic count as histological criteria for qualifying as grade 2 meningioma. The 5th edition of WHO does not recommend any further change. So we all know that necrosis, mitosis, and brain invasion are aggressive features in meningioma. And this histological grade has stood the test of time. It correlates very well with recurrence-free survival. Grade 1 meningioma has a 5-year relapse-free survival of close to 90%, whereas grade 3 anaplastic meningiomas have a 5-year survival of less than 30%. So histological grade, we all know, correlates well with recurrence-free survival. However, there is more to meningiomas than just the histological grade, and that was first unraveled when the DNA-based classification was done, which has quite revolutionized the classification of primary brain tumors. So this was on a data set of more than 500 meningiomas, where 6 DNA-based clusters were recognized. They were called as methylation cluster benign 1, benign 2, benign 3, methylation cluster intermediate A and intermediate B, and methylation cluster malignant. And as you can see at the bottom of the curve, the progression-free survival is very, very different between the benign cluster, the intermediate cluster, and the malignant cluster. So the benign cluster, most patients do very well, whereas in the malignant cluster, the 5-year survival is rather poor. Now, if we were to correlate the histological grade versus the methylation cluster, you would see on the cartoon on top that WHO grade 1, it segregates even into the intermediate clusters, the MC, intermediate A, intermediate B, and a very small proportion even into methylation cluster malignant. Similarly, the WHO grade 2 and 3, they are not corresponding to the intermediate and the malignant clusters respectively. A lot of WHO grade 2 tumors actually correspond to the methylation benign cluster. The 2 Kaplan-Meier curves at the bottom, on the left is by histological grade, which is grade 1, 2, and 3. And on the right is by the methylation cluster, benign, intermediate, and malignant. And as you can see, the methylation cluster, the curves are further apart and more robust in classifying meningiomas as opposed to the WHO histological grade. More importantly, using a multi-omics platform which comprises of DNA methylation, RNA-seq, and copy number alterations, 4 molecular subgroups of meningiomas were identified. And this was published a year ago in Nature. The 4 molecular subgroups of meningioma, the MG1, which is more immunogenic, the MG2, which is angiogenic, the MG3, which is hypermetabolic, and the MG4, which is proliferative. Again, if you see the third row, which shows the survival outcomes, MG1 has the best survival outcome, whereas MG4, the proliferative group, has the worst survival outcome, whereas MG2 and MG3 types are intermediate or in between in terms of prognosis. Researchers also went ahead to develop and validate a molecularly integrated grade, and this was done on a cohort of close to 400 primary meningiomas. And what essentially they used were tumor intrinsic features, histological features, and some molecular features by which they assigned a point to high-risk molecular alterations and also to histological features. And any score, a maximum score of 11 was possible. Histological, molecularly integrated grade 1 was patients having a score of 0 to 1. Molecular integrated 2 was a score of 2 to 3, and anybody with a score of 4 or more was classified as molecular integrated grade 3. And what was the impact on outcomes? The integrated molecular grade actually trumped the histological grade. So if you see again, the Kaplan-Meier curves, on the left is the histological grades 1, 2, 3, and on the right is the molecular integrated grades grade 1, 2, 3. And as you can see, the separation of the curves is more robust with the integrated grade. More importantly, within the WHO grade 1, you can see that integrated grade 3 tumors were present, and they had a much worse outcome. Similarly, within WHO grade 2 tumors, you had integrated grade 1, 2, 3 tumors with very different outcomes. Similarly, in WHO grade 2 and 3 tumors, some of those tumors had molecular integrated grade 1, and they had much better outcomes. And presence of brain invasion was not uniformly predictive of outcome. Presence of brain invasion in molecular integrated grade 1 patients had good outcomes, but presence of brain invasion in molecular integrated grades 2 and 3, the outcomes are much worse. So very clearly, integrated molecular grade trumps histological grading system. The researchers also went ahead to build a nomogram for prediction of PFS in meningioma using the molecular integrated grade, extent of resection, tumor volume, and the status, whether it is a primary tumor or a recurrent meningioma. And as you can see, the 1 year, 3 year, and 5 year probability of progression-free survival can be predicted using this nomogram. The most recent classification is an integrated molecular morphologic classification. This again is based on a data set of close to 350 patients where copy number variations were used, histological grade, copy number variations, and methylation cluster. All these three things were used to develop a risk score. So as you can see here, each of the WHO grades were assigned a value. The methylation cluster, benign, intermediate, malignant were assigned values, and copy number variations of 1p, so loss of chromosome 1p, 6q, and 14q were assigned values, and an integrated model score. So anything which was up to score 2 had low risk, 3 to 5 was intermediate risk, and 6 to 9 was high risk. And as you can see, the Kaplan-Meier curves are quite well apart based on this integrated morphological molecular model. Again, a cartoon to depict the integrated morphological molecular model wherein low-risk tumors do much better, whereas the high-risk tumors have a dismal outcome despite aggressive multimodality treatment. This paper also recommends a tier-wise algorithm for molecular risk stratification. So initially on light microscopy, if it is an angiomatous or a secretory or a psammomatous meningioma, that is generally a low-risk meningioma. If it's clear risk, then it becomes clear cell, then it becomes intermediate risk. And if it is some other histology, then you need to go in for a molecular risk stratification. For molecular risk stratification, you could choose either the methylation array, which is a robust way of doing it. If you don't have access to a methylation array, you could use a FISH to look at 1p loss or a 6q loss or 14q loss. And if that is not available, you could use TERT promoter mutations targeted gene analysis. So based on the availability of infrastructure and expertise, you could actually go ahead with molecular risk stratification for meningiomas. Now coming to the second part, which is the role of radiation therapy. In asymptomatic patients where meningiomas have been detected incidentally, it can be used to prevent new onset symptoms, reduce the risk of tumor progression, possibly improvement in overall survival. But most of the time it is used for symptomatic patients, either in the definitive, adjuvant, or salvage setting, where you can provide symptomatic relief and prevent new deficits, provide better local control and reduce the risk of further progression, and also provide an improvement in overall survival, particularly in subtotally resected grade 2 and even gross totally resected grade 3 meningiomas. The grade 1 meningiomas, in general, you need to individualize therapeutic approaches. Of course, if therapy is indicated, surgical resection is the first choice, and gross total resection should be attempted wherever feasible. However, for small imaging defined meningiomas, a lot of people do use radiation therapy, either fractionated RT or stereotactic radiosurgery, particularly if the patients are not willing or unfit for surgery and in surgically difficult or challenging locations. So this is a systematic review of stereotactic radiosurgery versus observation for patients with incidentally detected meningiomas. And what you can see from the forest plot is that the risk of progression is significantly reduced with upfront radiosurgical treatment. What are the predictors of progression? A T2 weighted hyperintensity, larger tumor size, and younger age were predictors of progression in this systematic review and meta-analysis. There is a difference of opinion, and the world is divided on whether you should do radiosurgical treatment or fractionated radiotherapy. I think it depends to a large extent on patient and physician choice and philosophy. Deciding factors are, of course, size, location, age, performance status, and patient preference. It can be used in the adjuvant setting to the residual tumor after resective surgery. And generally 14 to 16 gray as a single fraction is what the recommended SRS dose is. However, in recent times, hypofractionated radiosurgical treatment giving slightly higher doses, 21 to 27 gray in 3 to 5 fractions, have also been used. The more commonly used approach is the fractionated radiation therapy, generally used for larger inoperable tumors or recurrent disease, and a dose of 50 to 60 gray in 25 to 30 fractions is what is generally practiced. This is a summary slide of the outcomes with radiosurgery in largely imaging defined meningiomas, and you would see that the 5-year progression-free survival is generally upwards of 90-95%. Fractionated radiotherapy Again, there is excellent survival after GTR in grade 1 meningiomas, but the outcomes after subtotal resection are not so good, and there is a consistent benefit of postoperative radiation therapy after subtotal resection. What about grade 2 meningiomas? They are much less common than the grade 1, comprising 15 to 25% of all meningiomas. However, the risk of recurrence is significantly higher compared to grade 1, and only 40 to 60% are disease-free at 10 years. Once again, surgery remains the mainstay of treatment, and gross total resection should be considered whenever possible. Role of adjuvant RT has been controversial and has been evolving over the last 2 decades. This is data from the SEER database, where a large cohort of patients were analyzed who received adjuvant radiotherapy versus did not receive adjuvant radiotherapy in non-benign meningiomas. And actually what they showed was that the use of radiotherapy was associated with worse outcomes, although the p-value was just borderline significant. More recently, a systematic review on the role of adjuvant RT in grade 2 meningioma showed that it improves local control, particularly if subtotal resection has been done, but does not impact upon overall survival. The most recent data set that demonstrated for the first time the benefit of radiotherapy, adjuvant radiotherapy in WHO grade 2 meningiomas was published a few years ago in 2017. So in patients who underwent subtotal resection, there was clear benefit of adding radiotherapy, which did not exist when patients underwent gross total resection. As neurosurgeons, most people have a bias against adjuvant radiotherapy in grade 1 to meningioma, and this is the British Society of Neurosurgery survey on the use of adjuvant radiotherapy in grade 1, grade 2 meningiomas. And if you can see on the last row, incompletely resected grade 2 meningiomas, even in those meningiomas, more than 40% of neurosurgeons never refer them for radiotherapy. So despite being the commonest brain tumor, there has been lack of prospective studies evaluating the benefit of adjuvant radiotherapy in grade 1 to meningiomas, and that is largely dictated by personal and institutional biases and patient and physician preferences. And that is indeed a clarion call for the conduct of prospective trials to generate high quality evidence. The RTOG took a step in that direction a few years ago. So they decided to do a trial of radiotherapy for intermediate and high risk meningiomas. So the group 2, which was the intermediate risk meningioma, it was a single arm study where patients were treated with radiotherapy following surgery. And the PFS and local recurrence rates were extremely good. Local recurrence rate of 2% at 3 years and 96% PFS, and on overall survival of 96%. And no grade 3 or worse toxicity was noted with postoperative adjuvant radiotherapy. In parallel, the European trial was also done for non-benign meningiomas, and what they also showed was that the overall survival at 3 years was 98%, progression-free survival at 3 years was 88%. So these were very encouraging outcomes, and that led to a randomized trial in gross totally resected grade 2 meningiomas, the RTOG and RGBN 003, where patients following surgery are being randomized to observation versus radiotherapy. The radiotherapy could be delivered with either IMRT or with protons. The mitotic index is being used for a stratification. A similar trial, radiotherapy versus observation in atypical meningioma, is being run in the UK. And both these trials will give us a definitive answer whether there is a role for any adjuvant radiotherapy following gross total resection of a atypical meningioma. Grade 3 meningiomas, there is much less controversy. However, they are also much less common, less than 5% of all meningiomas. They are associated with aggressive biological clinical behavior. Again, surgery is the recommended first line therapy. However, they have a tendency to recur locally and can also metastasize rarely. High dose adjuvant RT is routinely offered. There is no proven role of upfront systemic therapy or targeted therapy. However, despite all aggressive multimodality therapy, grade 3 meningiomas have suboptimal outcomes. The RTOG 0539 looked at this group as well, and they planned a single arm prospective study wherein patients received 60 gray and 30 fractions. And as you can see, they did achieve a reasonable 3-year progression-free survival of 60%. And in patients who had high-risk meningioma, grade 3 meningiomas fared worse than recurrent grade 2 tumors. As we know, over the last 10-12 years, conformal radiotherapy techniques have become the standard of care or the norm in all across the world, including in most of the centers in India. And this is a summary slide showing the outcomes with these conformal techniques in meningioma. So as you can see, local control is generally upwards of 80-90% for most series, of course, depending on the grade and the setting, whether it is definitive or salvage. And late toxicity is very much acceptable, less than 5% typically in most series with focal conformal techniques. Now we also have the proton, which is the magic bullet, and the physical depth dose characteristics of protons make them particularly attractive for treating meningiomas. If you can see on the left is the dose wash of standard VMAT or the photon-based treatment, whereas on the right is the dose wash from proton. So normal uninvolved brain can be significantly spared from the low dose region using the proton beam therapy. We have been using IMRT for intermediate risk meningiomas for the last more than 15 years. And this is data from our own series. This is just to show the radiotherapy dose wash. And we achieved a 5-year PFS of 89.2%. The overall survival was 100% in this series. We also looked at does the timing of radiotherapy impact upon outcomes in atypical meningioma, and this was an audit of 86 patients where patients received radiotherapy either early upfront after surgery or in the salvage setting after first progression. And what we did demonstrate was that early adjuvant radiotherapy was associated with better progression-free survival as opposed to salvage radiotherapy, both in patients who had undergone GTR as well as in patients who had undergone subtotal resection. So we strongly believe that early adjuvant radiotherapy in atypical meningiomas can potentially improve outcomes. And because modern conformal radiotherapy is not associated with very significant toxicity, they can be given a reasonable quality of life as well. This is just a summary of the management algorithm for meningiomas from the recent EANO consensus on management of meningiomas, first published in Lancet Oncology in 2016 and now updated in Neuro-Oncology in 2021. Thank you for a kind attention, and I'm happy to take questions if any.
Questions?
Yeah. Yes, ma'am, please. Wonderful session. We open to questions.
Thank you, Dr. Tejpal. This is Dr. Vani.
Yes, ma'am, I can.
Thank you for that wonderful lecture, and particularly summarizing all the molecular parameters as well as the high throughput studies that you showed. I have only one question. Of course, now we don't really do DNA methylation profiling. The WHO also doesn't really put that into essential diagnostic criteria. But my question to you is that you're saying that for atypical meningiomas, upfront radiotherapy, you were showing one slide in the end, whether it is salvage or upfront radiotherapy. But when you looked at the DNA methylation profiling, that beautiful cartoon that is there from the German group, which shows that so many of the large majority of atypical meningiomas, they have all conformed into the intermediate A, which is a better group when compared to the intermediate B. So do you think that since atypical meningioma is a diverse group, some going to intermediate A, some going to intermediate B, none of them go to the MAL group at least. So what is your suggestion? On histology itself, do we give upfront radiotherapy, or do you want prognostic markers before you do that? That was my question.
Yeah, so ma'am, very good question. I don't have a very good answer for that, but the data that I showed was our retrospective audit, and I have to acknowledge that, I mean, it is associated with significant biases. Having said that, currently what we do is we use 1p loss and HTERT mutation. If 1p loss is present or HTERT mutation is present, then we would certainly recommend adjuvant radiotherapy in atypical meningioma, even if it is gross totally resected. We are also part of the NRG RTOG BN003 study. So we counsel patients, those who don't have those kind of molecular alterations, we counsel them for participation in the study. So that study is currently randomizing patients to observation versus radiotherapy. The hypothesis of the study is that even in a gross totally resected atypical grade 2 meningioma, the upfront adjuvant radiotherapy will improve progression-free survival. Overall survival, it's unlikely to improve because when they progress at that time, when you give the radiotherapy, most of the time you would be able to salvage them at progression. But you're right, atypical meningioma is a very heterogeneous group. Many of them segregate actually into the benign cluster, and a very, very small proportion actually segregate into the malignant methylation cluster. But it is a heterogeneous group, and I don't think there is one size does not fit all. And I think if you can do some of the molecular alterations which are easily doable, then you can possibly base your decision making on that.
Thank you.
So, what is your experience with recurrent meningiomas, especially something in the sphenoid meningiomas, which were partially operated and then we have given radiation? So in the recurrent setting, suppose there is a recurrence after 3 years, 4 years, what else can be done, and what is your experience with recurrent meningiomas?
So you're asking for recurrence after receiving radiotherapy, is it?
Both surgery and radiation.
Yeah. So radiation, external beam radiation has been exhausted once.
Once already exhausted. Yeah.
So I must say that despite being a radiation oncologist, I am pretty wary of re-irradiating meningiomas because they live long, and no re-irradiation is sort of so-called safe. So when we re-irradiate, we have to balance the risk and benefit, and the risk of radiation necrosis becomes pretty much high, no matter even if you irradiate after 3 years, 4 years, or 5 years. Maybe if you irradiate after 10 years, 12 years, 15 years, or maybe if you could use the proton beam re-irradiation, then possibly the risk of radiation necrosis would reduce. But otherwise, within 3, 4, 5 years of primary course of radiation, we are very reluctant to re-irradiate these patients. Fortunately, many of these tumors are avid on the DOTA scan, and currently we are not in a study setting, but PRRT using the DOTA. If they show DOTA avidity, then our nuclear medicine colleagues are happy to offer them PRRT. That does not lead to significant shrinkage, but it does provide stability and prevents the tumor from growing further. Of course, in the recurrent setting, if you can reoperate, you should go ahead and reoperate. That will give you the best chance of cure and reducing the risk of progression.
So we come to the closure of this session. We had a series of wonderful talks. We thank all the speakers for their wonderful talks, and we thank all the audience for being there. Thank you, Dr.
Thank you. Thank you, Dr. Kishore Yadav and Dr. Shailesh. Sorry for that goof up. So now we are running late in our program schedule. So we'll break quickly for a quick lunch and join back in half an hour. More interesting sessions post lunch. Please join for lunch now.
Welcome back after the lunch break. Now we will progress to the next session, and I invite Dr. Kiran and Dr. Vidya Bhushan, consultants from NH, one in neurosurgery, the other in head and neck surgery, to please take the stage as chairs for the next session.
Hope everybody had good lunch. We started today's deliberation with highly intellectual talk by Dr. Komal, then supra-intellectual by Egde sir. Then we were hovering around in the sky, glioma and all that. Then we came to meningioma. Now we will come a little bit down, skull base, and nevertheless it is very important. And this is where how we will know how multidisciplinary will help in a different way. Let us talk today. We'll start with 4 talks, followed by a panel discussion, case-based discussion. That will be very interesting. Since we'll be discussing as a case discussion, we won't be having question and answer after each talk, so that we can make up for the time. First, I invite my colleague, Dr. Vidya Bhushan. He's a senior head and neck surgeon in Narayana Health. He'll be talking on principles of endoscopic sinonasal malignancy.
Good afternoon, everyone. So today's topic will be principles of endoscopic approach to sinonasal tumors. So sinonasal tumors constitute around 3 to 5% of all the head and neck malignancies, and they're located in such a situation where surgery is most complex and technically very challenging. So there are various approaches defined for to handle the sinonasal malignancy. So ideal approach should give us adequate exposure for the target lesion. It should facilitate complete resection and repair, and we should have a backup plan so that it should be flexible in case we require a widening of any approach for any unanticipated events. So Ketchum first described craniofacial resection for skull-based malignancies, and after that we've got multiple evidences in the form of retrospective case series, where it has been time and again proven that by craniofacial resections, these skull-based malignancies can be handled with good oncological outcomes. So again, these are the evidences which have got over 20 to 30 years. And then in 2005, we've got these papers from the Kasam group, where endoscopic approaches, which were there in our ENT practice, but the horizon was expanded. We have moved on from handling regular sinusitis to handling skull-based malignancies. So we've got convincing evidence that even with endoscopic approaches, these malignancies can be handled well with equal good oncological outcome as compared to the craniofacial resections. So if you look at the endoscopic endonasal approaches, 2 modules have been told, one in a sagittal and in the coronal. In the sagittal, it will be, I'm sorry, yeah. Can I have a pointer? Yeah, thanks, yeah. In the sagittal module, we have this transfrontal, transcripiform, transtubercular, planar, cellular, clival up to the odontoid, C2. So these are the multiple modules which have been explained on the sagittal planes. Now, main principles when handling malignant cases, sinonasal malignant cases, endoscopically is we should have a multi-layered dissection, multiportal approach, transnasal, transantral, centripetal dissection. I'll explain each of them through various videos. Subperiosteal dissection and roll of Rosen section. So what are the controversies coming from the big craniofacial resections where we were used to remove the specimen en bloc, And switching over to the endoscopic resection, where most of the times we won't be able to remove the tumor en bloc. We will be doing sequential resections. Now, what were the controversies for endoscopic surgeries, whether margins will be getting adequately? And like I told, en bloc and piecemeal resection, complications, because we'll be working in a narrow space with crowded instrumentation. How do we handle and avoid complications? And of course, this endoscopic approach has a good amount of learning curve than compared to craniofacial resections. And finally, quality of life. Now, coming to the margins, we have a good amount of evidence now in an endoscopic approach for sinonasal malignancies that negative margin can be achieved equivalent to craniofacial resections while operating on sinonasal malignancies. If you look at the margins published in this one of the largest series in the European position paper, craniofacial resection had positive margins about 15.6 to 17%, whereas endoscopic resection has positive margin rate of 10 to 18%, which is acceptable. Now, how do we assess the margin intraoperatively by endoscopic approach? So if you see, this is a right nasal cavity, this is a case of adenoid cystic carcinoma. So this is a very common scenario which we encounter. This is the periorbital tissue and the tumor sitting here. Now we are, when we are working in a closed cavity, the tumor will be abutting the nasal septum, tumor will be abutting the periorbita. So that doesn't mean we need to clear out the entire periorbita or we need to remove the entire bone. So this is where frozen section comes into play. Yeah. So we can see this is a tumor attached to the periorbital tissue here. So what we do is gentle capsular dissection to remove the tumor from the periorbital. I'm sorry. Yeah. Gentle tumor dissection to separate from the periorbital fat. Here we can see the periorbital fat protruding out, and this is the final tumor which is being released from the periorbital tissue. And then once we do this, we need to send this periorbital fat for frozen section to confirm our negative margin. Okay, so whenever the main principle in endoscopic approach is we should go one layer ahead while operating these kinds of tumor. So once the tumor is removed, we remove this entire periorbital fat and send for frozen section for margin assessment to make sure we get R0 resection. Another advantage in endoscopic surgery, particularly in margins, is when we are dealing with adenoid cystic carcinoma of nasal cavity. We all know that adenoid cystic carcinoma has got propensity for perineural invasion. And here what we are seeing is when we, after removal of the tumor, we identify the foramen rotundum, Vidian canal and the foramen rotundum here, and we can drill out the bone around the Vidian nerve to trace it posteriorly to remove the entire the nerve and give the tip of the nerve for frozen section analysis so that we get a negative margin. Same example in case of dural invasion. So this is the this is a post tumor removal, dura getting separated from the brain here, and this will always be done in a two-surgeon forehand technique. So what we are doing is, once the tumor is removed, this is a case of for olfactory neuroblastoma. This was the site where the tumor was adherent to the dura. So we take margin away from the tumor. So this is called centripetal dissection. So centripetal dissection is you approach the tumor base where it is attached away from the site of attachment. So we remove this entire dura, carefully separating it from the underlying brain tissue. Sorry, and then analyze the remnant dura for any evidence of tumor by frozen section. So once we get negative margins, we stop our surgery. So this is the cut end of the dura where we send these things for frozen section analysis. So margin assessment in endoscopic surgery shouldn't be a issue as long as we utilize frozen section. Coming to the next controversy, en bloc removal and sequential resection. So en bloc resection was the standard of care by craniofacial resection, but then majority of the times, like I told, en bloc resection will not be possible unless tumor is very small in size by endoscopic resection. So we've got enough data accumulated that even by endoscopic surgery, even by doing removing the tumor sequentially, the oncological outcome is equivalent to craniofacial resection where we remove the tumor en bloc. What is important is getting margins negative. That is most important. So margin negative at the point where the tumor is attached is where our focus should be than on the removing the tumor by sequential resection and a complete in toto resection. Again, if you see this case, yeah. So this was a case of again low-grade sarcoma, as we can see, is attached to the roof of the nasopharynx and the posterior wall of the nasopharynx. So this was a tumor in the left nasal cavity. So after complete removal of the tumor, the entire mucosa is stripped of the bone. This is the roof of the sphenoid. The bone is drilled out and posterior extension up to the prevertebral muscles. Now we need to assess our margins based on the whatever bed we are seeing here. So if we get our margins negative there, that means we've got a margin negative resection. So another case of low-grade adenoid cystic carcinoma, again epicentered in the nasopharynx, going on to the pterygopalatine fossa and the lateral sphenoid recess. Yeah. So this is a tumor in the left nasal cavity. This is a tumor which epicentered in the along the lateral wall of the nasopharynx on the left side. So there is no tumor. So in the nasal cavity, because of closed constraints, it seems like tumor is adherent everywhere. So we need to ensure that tumor is free from the mucosal attachments, like what is seen here. The tumor is gently pushed away to make sure that there is no mucosal attachment. And what we did was we divided the tumor in this lateral wall of the nasopharynx to remove the tumor as two components, one with the nasopharyngeal component and one along the pterygopalatine fossa component. So tumor is divided here. Now we will be removing the nasopharyngeal component here. Nasopharyngeal component is being pushed into the oral cavity because it was quite big for us to take it out through the nose. So this is the nasopharyngeal component being removed per oral. And then next step, we drill out this pterygoid plates. We can see the pterygoid musculature attachment there. And the small component of tumor, which is extending laterally into the infratemporal fossa and the pterygopalatine fossa, can be gently accessed and removed. So this was the component which was there laterally. And then the tumor attachment site is drilled out completely. And again, margins are sent for frozen section analysis to confirm negative margins, and this is a post-op CT after resection. So in a few cases, the nasal cavity will be fully occupied by tumor where we won't have any space to put our endoscope. Like in this case, this is a case of T2 squamous cell carcinoma from the nasal cavity where we don't have any space for instrumentation. So in these cases, we approach the tumor through the contralateral side, elevating the septal flap, going onto the cartilage, making a small septal window. I'll just fast forward for the lack of time. Removing the septum, and here we can see the tumor. So what is important is for us to then remove the tumor sequentially, but keeping the base still attached to the tumor. So in this case, the tumor was attached to the inferior turbinate and the medial wall of maxilla. Yeah, this was the site of tumor attachment, and this will be removed in toto and again sent for frozen section analysis for margin assessment. And the base of the tumor, once we confirm negative mucosal margins, we drill out the base of the tumor. So it remains a wide nasal cavity here. Again, complications, one of the things blame that complications like CSF leak or any major vascular event will be difficult to handle endoscopically. Of course, if we talk about ICA injury endoscopically, definitely I would agree it is difficult to handle. But then if we talk of other complications, CNS complications in terms of CSF leak, meningitis. So if you see one of the largest series for the craniofacial resection, the overall complication rate was about 36%. And if we analyze the complications rate for the largest series for sinonasal malignancies by endoscopic approach, the complication rate reported is about 9 to 11%. So why complication rate is less in endoscopic approaches? We get to see the main vessels by endoscopic approach very early before we handle the disease. Like in this case, after partial resection of the tumor, we get to see all the vascularity, anterior ethmoidal vessels, posterior ethmoidal vessels, and yeah, the spinopalatine vessels and the internal maxillary artery in the pterygopalatine and infratemporal fossa, where we can control these blood vessels much earlier on during the dissection, so that inadvertent injury to these blood vessels can be completely avoided. So this is the vascular anatomy in the pterygopalatine fossa, the vascular component in the anteriorly, and we have the neural component posteriorly. So, yeah. Yeah, just last few slides. And approaching these hidden areas like this is a low-grade sarcoma involving the extending into the frontal sinus through the frontal recess. So again, with use of angled telescopes, these tumors also can be beautifully removed by sequential resections. Now what we are seeing is the, sorry. What we're seeing is a drilling of the frontal nasofrontal beak here. We're using the 70-degree endoscope. This is a frontal sinus here. The right frontal sinus seen. This is a frontal sinus. So this gives us, I mean, pretty much good confidence that the tumor can be removed in toto, and the right frontal and the left frontal sinus here. And this frontal beak will be removed, and both the right and left frontal sinus will be made into one single cavity like a draft 3. Again, this is the 2-year follow-up post-op MR showing complete resection and good outcome. So even if you take off very laterally located tumors into the infratemporal fossa, again there is a adenoid cystic carcinoma of the pterygopalatine fossa and the infratemporal fossa. Even these can be accessed very nicely with the endoscopic approach, even with this lateral placement into the infratemporal fossa. So once we do a wide medial maxillectomy and remove the tracheoid plates, we are right bang on the tumor. And like I told, before seeing the tumor, we would have taken control of the vasculature. All the internal maxillary artery branches will be clipped off and pushed laterally. So what we are drilling is the floor of the middle cranial fossa here from the undersurface on the right side. We can see the V2 here, foramen rotundum coming out here, and Vidian canal here. So that's the middle cranial fossa base from where the tumor was arising. All these things will be done in collaboration with the neurosurgery team. So all these procedures will be a 2-surgeon 4-hand technique. and then the entire tumor can be mobilized very easily, avoiding any transfacial approaches. I'll just fast forward for the lack of time. Reconstruction, we have various reconstruction options by endoscopic approach. Our main aim is to separate the cranial cavity from the upper aerodigestive tract and also protection of important neurovascular structures. So Haddock flap, pericranial flap, temporoparietal flap, infraturbinate flap, myomucosal flap, and the palatal flaps. Haddock flap is a very versatile flap where it can be utilized to at any extent. I'll skip this video for time. And yeah, quality of life, again, we have various questionnaires being used in anterior endoscope, anterior skull base surgeries, where the quality of life is on par with the craniofacial resections. So I'll skip this. So just a brief outline of our instance. So we have about 42 cases in the past 3 to 4 years, sinonasal malignancies we've operated. 30 patients have undergone only endoscopic excision and 12 patients have combined approach excision. And like you see here, our majority of the most common tumor which we get is olfactory neuroblastoma and the SNUC, and few of squamous cell carcinoma nasal cavity. So we have a positive margin of about 7% and mainly in the squamous cell carcinoma and adenoid cystic carcinoma. So this is the adjuvant therapy details, where 35% of them have undergone neoadjuvant chemotherapy, and adjuvant treatment, chemotherapy and radiation is utmost important in any sinonasal malignancy to achieve a good overall survival and local control. So we had about 2% for patients had CSF leak, and 2% of them have developed cerebral abscess after combined endoscopic and cranial approach. Most common complications what we have noticed in endoscopic approach is Seineke formation, nasal alar retraction, maxillary nerve hypoesthesia, and hyposmia. So there are, of course, limitations in endoscopic endonasal approach, and mainly it is anatomical limitations. If the lesion is extending along the anterior wall of the frontal sinus, involving the skin, involving the hard palate, or gross intraparenchymal extension, or lesions crossing the optic nerve laterally are clear-cut contraindications for a pure endoscopic approach. Yeah, I have videos, but I think I'm out of time. Yeah, thank you.
Yeah. Dr. Bhushan for the wonderful exposition. I think the important message is endoscope is a tool, and oncological principles should not be compromised, and with minimal morbidity, in a way that facial incision and other things have been avoided. So it's a good. We'll move on to the next talk. Dr. Shiv Prasad is an endocrinologist from Narayana Health. He'll be talking about functional pituitary tumors, endocrine management. I think we'll have in the end because final discussion will be there. Yeah.
Good afternoon, everyone. So today I'll be discussing one of the most common non-neurological tumor which the neurosurgeons operate. So pituitary adenomas are the tumors which arise from the adenohypophysis, the hormonal part of the pituitary gland. And many pituitary adenomas, almost all of them, they secrete hormones, but only few secrete intact hormones. These adenomas which secrete intact hormones, they present with hormonal conditions, and we call them functioning pituitary adenomas. And these are very common in autopsy series. Around 10% of patients have pituitary adenomas. In even on MRI, we can find incidental talomas in 10% of patients. But they are seen very less commonly in clinical practice. The prolactinoma is only 10 to 60%, 10 to 60 per lakh of population, and acromegaly, GH secreting adenomas occur in 5 to 10% of 5 to 10 per lakh patients. Even the distribution of the pituitary adenomas depend on the distribution of the cells in the pituitary. Most of the ACTH secreting tumors, they are in the center of the pituitary, and whereas prolactin and GH tumors, they affect the lateral wing of the pituitary. And in the preoperative patients, prolactinoma is the most common cause. It's around 50 to 60% of all tumors are prolactinomas. Next common is NFPA, but there is a varying prevalence. If you see post-operative patients, the most common is the NFPA. Whereas acromegaly occurs in 10% of patients, the remaining like Cushing's and TSH secreting tumors are very rare. Initial evaluation, we look at three things. One is symptoms of hyper secretion, like features of acromegaly, Cushing's disease, or for prolactinoma, we look for galactoria, amenorrhea, and infertility. Then we look for hyposecretion, features of thyroid deficiency or adrenal insufficiency. These patients present with vomiting, nausea, and weight loss, hyponatremia. And then we look for pressure effects, symptoms of diabetes insipidus, and headache and visual disturbances. Evaluation is very important. I want you to concentrate on the first three things. These are the three things we should do before sending a patient for surgery. Prolactin is the most common thing because we can avoid surgery, and medications are better compared to surgery with prolactinomas. And if there is a hypothyroidism or adrenal insufficiency prior to surgery, treating it is important. Otherwise, the patient can develop adrenal insufficiency and crisis during the surgery. The remaining things, IGF-1 and GH, we do it only if there are features of acromegaly, and testosterone only the patient has the features of hypogonadism. I'll be concentrating more on prolactinomas. The preoperative evaluation is very important. So get a prolactin test done for all the patients undergoing pituitary surgery. There are three major causes for high prolactin. The most common cause is prolactinoma. In these cases, they have a prolactin more than 200. Most macroadenomas have prolactin more than 500. There are two other conditions which can mimic prolactinomas, that is a Stark effect. A non-functioning pituitary tumor compressing on the Stark can increase the prolactin up to 100 or 150. And the second is the medications. We should be very careful about patients taking proton pump inhibitors or anti-neurotic medications like risperidone. Risperidone can increase the prolactin up to 200. And when the prolactin is very high, there is something called hook effect. This occurs due to the kind of lab or analytical condition where the analyte which is used is oversaturated. Very high prolactin levels, usually more than 4,000 or 5,000, can give you falsely low reports in the lab test. So if you're suspecting prolactinoma, if the patient has amenorrhea and galactoria, and the prolactin is coming between 100 or 200, do a prolactin test with dilution. So in those cases, you can pick up the prolactin secreting tumors. So prolactinomas, they're the most common functioning pituitary tumors. It's usually female predominant, 10 times more common in females because they present early to the clinical care because of amenorrhea, galactoria, and infertility. Around 10% to 20% are macroadenomas, usually males present with macroadenomas, and giant prolactinomas occur in 1 to 5%. The giant prolactinomas are tumors which are more than 4 centimeters in size. And treatment of choice is medical treatment. We have two agents, bromocriptine, cabergoline, available in India. Quinaglide is available in some European countries. I'm not going into much details here. Cabergoline is the most effective drug of the two. Screen is not visible. So So most of our patients ಏನಾಗ್ತದೆ? Okay, I'll continue like this. Yeah. Prolactin must be treated with cabergoline or bromocriptine. Preferred drug is cabergoline because it's the longest acting and it is more potent compared to bromocriptine. And there's the advantage of giving it only twice in a week. Bromocriptine is less effective and we use only in patients who are planning pregnancy because it is short acting and we can stop the medication as soon as the pregnancy is confirmed. There are conditions where the patients don't respond to dopamine agonists called resistant prolactinomas. This happens with 25% patients on bromocriptine and 10% with cabergoline. And we define resistant prolactinomas as failure to normalize prolactin and reduce the tumor volume by 50%. Here, this is one condition where we refer the patients for surgery. And even we try high dose of cabergoline and most patients don't respond to high dose of cabergoline. For using more than 2 milligram per week, the response, we don't get much response after that. Then there is a new drug, lapatinib, which is not available. And there are other indications for surgery like resistant prolactinoma, patients who present with apoplexy and the involvement of vision, and patients with CSF leak. This CSF leak tends to occur when we start someone on cabergoline. If we started on a higher dose of cabergoline in giant prolactinomas or macroprolactinomas, the risk of CSF leak goes up. Next is GH secreting adenomas. So most of the times the diagnosis is made by a neurologist or a ophthalmologist. They end up with either headache or visual disturbances. And these are the common features, the soft tissue thickening, prognathism, and macroglossia, and it can involve all the organs in the body. And majority of the tumors are macroprolactinomas, macroadenomas 73%, and 4.5% are giant adenomas. And diagnosis, we do IGF-1. A screening test of choice is IGF-1, you don't do a GH, and if the IGF-1 is high, for confirmation, we do a GH after giving 75 gram of glucose. And treatment of choice is transpenital surgery here. And results depend on many things like the experience of the surgeon and the tumor resectability, whether it's a microadenoma or a macroadenoma. Microadenomas have a better response compared to macroadenomas. And medical therapy is not very effective, so we don't use it as a primary line of medication. We use after surgery where the patient has a remission or has a relapse or if it doesn't improve after surgery. And we rarely use it as a primary mode of therapy when for surgical preparation, patients who have severe obstructive sleep apnea, patients who have left ventricular dysfunction or uncontrolled sugars, we treat the patient with short-acting octreotide for a few days before surgery to prepare them. And there are many medical therapies. The medical therapies can be classified as pituitary targeted and end organ targeted therapies. We have somatostatin ligands or somatostatin agonists. In India, we have only octreotide LAR. It is given as a monthly injection, 10 to 40 milligram per month. It is expensive. It costs around 20 to 40,000, and very few patients afford that. So most of them, they go for radiation. And we have pasireotide. Pasireotide is a multi-somatostatin receptor ligand. It is more efficacious compared to octreotide, but 50 to 60% of patients develop diabetes when on pasireotide, and it's not available in India. And cabergoline is less effective, and it is not commonly used for treating acromegaly. Then we have end-organ targeted therapy. This is the GH receptor antagonist pegbisomant. It improves the features of acromegaly, but it has no effect on the tumor itself. And we can't do a GH levels to follow up the patient, and it's expensive, costs around some few lakhs every month. And it's not available in India, and it has to be imported from outside. And we have combination therapy where we use both pituitary targeted and end organ targeted therapies. These are very effective. Again, cost is a problem, and so most of the times these patients go for radiation or resurgery. There are many emerging therapies. One exciting molecule here is the oral octreotide. Octreotide, which can be given orally twice a day, 20 to 40 milligram. It is FDA approved, and it's available in US. It's not available in India. There are many other molecules which target the growth hormone receptors, which are not available. The next class is the ACTH secreting adenomas. They are all present with typical features of central obesity, striae, then proximal muscle weakness and facial plethora. These constitute only 4 to 6% of all adenomas, and usually affects females more than male. And 60% of patients have microadenomas, 30% have macroadenomas, and the major problem here is that 10 to 20% of patients will not be able to detect adenoma on MRI. And we make a diagnosis depending on cortisol measurements. It can be done in 24-hour urine, or a salivary cortisol, or a cortisol after giving dexamethasone. Treatment of choice is transpenital surgery. And for persistent and recurrent therapy, again, the treatment of choice is a resurgery. Those patients who don't respond, we send for radiation. Medical management is not very effective again for Cushing's disease. We have 3 targets for medical therapy. The first is the ACTH production by the corticotropic tumor. We have ACTH production inhibiting drugs like the somatostatin receptor ligands and dopamine agonists. We have drugs against the renal steroidogenesis, ketoconazole, meteropon, mitotane, and etomidate. We use ketoconazole frequently, and we have glucocorticoid receptor blockers like mifepristone. So not go into details of this. In our practice, we use ketoconazole because the results are rapid, and but the problem is they don't have any anti-tumor effect. The tumor continues to grow, and there is a risk of liver toxicity and drug interaction with ketoconazole when you're using with other drugs. Again, there are emerging therapies against growth factor receptors and cyclin-dependent kinases. They're all in different stages of development, the phase 2 or phase 3 development. So we'll have to wait in the coming years for these molecules. The next is the thyroid TSH secreting adenomas, very rare. They present with thyrotoxicosis, and surgery is the treatment of choice. And we treat the thyrotoxicosis with antithyroid drugs, beta blockers, and somatostatin ligands to prepare the patient for surgery. We have gonadotrope adenomas. These are non-functioning tumors, but they still secrete the alpha subunit of FSH and LH. And most of these are, they present with the pressure effects, and the treatment of choice is surgery. And we don't have any medications to treat gonadotroph adenomas. And we get to see aggressive pituitary adenomas. These are the tumors which don't respond to medical, surgical, or radiation therapy. They are characterized by elevated Ki index of more than 3 to 10%, high P53 immunoreactivity, and increased number of mitosis. Again, the treatment of choice is surgery. With medical therapy, we have temozolomide with the standard therapy. If the patient has acromegaly, we give somatostatin ligands, and if the patient has prolactinoma, we continue dopamine agonists. It is administered orally 5 days every 28 days cycle, and the response rate is 20 to 50%. And the most important thing, the medical management, is the hormone replacement. Always analyze the hormone levels before surgery, the adrenal axis, the thyroid axis, and the prolactin, and supplement the hormones before surgery. With this, we can prevent the risk of adrenal crisis and hyponatremias. And we analyze the axis again 1 month after the surgery, and after that every 3 to 6 months. So to summarize, so prolactinoma is the most common functioning subtype of pituitary adenoma, and dopamine agonists are the first line therapy for prolactinomas, and surgery is indicated for only few patients, and other functioning adenomas are rare compared to prolactinomas, and surgery is the treatment of choice for other functioning pituitary adenomas where medical therapy is used as an adjunct. Thank you.
Thank you, Dr. Shiv Prasad. We can take 1 or 2 questions. Yeah. Sure.
That was really a very nice, comprehensive lecture on pituitary adenomas. I was, because as pathologists, we see a lot of pituitary adenomas that we diagnose. My question to you is that there are, apart from the factors that you showed about aggressive pituitary adenomas, there are some hormone secreting adenomas by themselves which are aggressive, yes, but they may not present as functional adenomas. Yeah. I'll give you some examples. One is sparsely granulated somatotroph adenoma, or a silent corticotroph adenoma. There are 2 silent corticotroph adenomas, type 1 and type 2. And there is plurihormonal PIT1 adenoma. They are all very aggressive tumors, but they are hormone secreting. Yeah. But they don't function, they don't present as functions. So how do you treat them? Do you have any medical line of treatment, or is it only surgery and followed by adjuvant therapy? What is the line of treatment for such? Because they're all known to recur. They progress very rapidly. They're known to recur. Their Ki67 index may be very low. Nevertheless, they're aggressive tumors. So what is your suggestion on those?
Yeah, so medical therapy, what we have is mainly hormone directed. So if there is a patient has features of acromegaly, if the patient has high growth hormone, in most of these sparsely granulated growth hormone adenomas, they have more features of acromegaly. Yeah. So we monitor the GH levels after the glucose OGTT, and we do IGF-1 levels. If the IGF-1 levels are within the range, then we're not going to start them on medical therapy, and we refer them for either repeat surgery if the residue is more, or if there is only less, then we send for radiation. And most acromegaly and these ACTH secreting tumors, they don't respond to medications.
Same answering your question. Some of it, like resistant prolactinomas, are known to be very aggressive, and by and large we go for adjuvant treatment even if there is complete excision by now, because we have seen most of them recur. So some of them have undergone radiotherapy even though after surgery these prolactins come down and it is at a borderline, but still if it is resistant and aggressive, we do radiotherapy.
So as pathologists, we generally give a comment in a comment box. For example, if it is a prolactinoma in a male, which is non-functioning, these are large giant prolactinomas. That is an aggressive tumor. A sparsely granulated somatotroph adenoma that has those fibrous bodies, very aggressive. Crook cell adenoma is very aggressive. Then we have the silent corticotroph adenomas, type 1, type 2, and a plurihormonal PIT1 adenoma. We generally write a note or a comment in our reports that these are more aggressive tumors. So I don't know whether that is helpful or not helpful, but we know that these are aggressive. There are studies that have shown that. That's the reason we write that comment.
Thank you.
Those are helpful for sending for radiation. Yeah.
I think recently we detected hook cell tumor also. I think it was referred to you. Akila must be knowing. Yes, sir. Thank you.
I would like to call upon our next speaker, Dr. Yogesh. He is a consultant head and neck oncology in Mazumdar Shah Cancer Center. He'll be speaking on treatment strategies for malignancies of temporal bone.
Good afternoon. I'll be speaking on treatment strategies for malignancies of temporal bone with main focus on how to come to diagnosis and what are the surgical options available. So talking about primary tumors of the temporal bone, these are rare and the numbers have really been elusive. The most common quoted number of 1 to 2 million cases per million population per year comes from the SEER database, and which has been substantiated by a database from population-based studies in Singapore and Denmark. So it is just comprises 0.2% of all head neck cancers. And if we look at it, the temporal bone cancers can actually have secondary involvement from the structures in the vicinity of preauricular skin, parotid, temporomandibular joint, ITF. And 75% of skin cancers we know occur in head and neck, and this is the vulnerable site. So what is important is to identify the primary site of origin and to appropriately stage it and then compare it for the survival. As I told earlier, that the sites of primary tumor can be varied, and this has been appropriately depicted by a retrospective study by MD Anderson group, wherein they found in the total population patients of 157, they found 40% tumors were actually arising from temporal bone or EAC, and rest of 60% arose from parotid gland, preauricular skin, or skull-base bone. Now, why the emphasis on site of origin? This is an important question to answer because when we look at survival and staging of these tumors, the tumor arising from the temporal bone have worse survival. And if we go in the ascending orders, followed by those in the skull base and those in the preauricular skin. So if we're talking about T4 tumors in parotid or external aortic canal or ear canal, they usually have better survival when compared to these malignancies. Talking about the pathologies, it's easier to look at these pathologies depending on the area. When external aortic canal, EAC will have squamous cell carcinoma, basal cell carcinoma, which are the two most common malignancies seen in this area. But there are malignancies arising from the serous adenocarcinoma and adenoid cystic carcinoma. Rhabdomyosarcoma is most common ear canal malignancy seen in pediatric age group. And when we look at the middle ear or the inner ear, most common is squamous cell carcinoma, or the middle ear neuroendocrine tumor, or the endolymphatic sac tumor. Now, the 5th edition of WHO has dropped the terminology of neuroendocrine adenomatoid tumor and aggressive papillary tumors. And then there are structures in the vicinity, the cartilage and bone tumors and the hematolymphoid tumors. Another most important part is the metastatic tumors, which can come to middle ear from breast, the adjacent head and neck sides, or it can also come from a lung and prostate. When we look at these tumors, the classic triad of otorrhea, otalgia, and hearing loss is seen in only 10% of the patient. But the symptom duration to presentation can really be varied. And it was looked into by Paul Gidley, wherein we found that most earlier symptoms to present is otalgia, which can present as early as within 5 months, followed by facial palsy, which can present within 6 months. And hearing loss can present with a varied variation from 8 months to 37 months. This is also important to look into the spread of the disease. The roots of the spread of the disease were actually defined by Leonetti in the radiological study, and it is very important to know the exact extent of the tumor. And why is it so? Because this is what dictates the resectability of the patient, the possibility of a negative margin, and most importantly, the final prognosis and outcome. So if we look at eardrum, I would say it is akin to what is Ongen's line for the maxillary tumors. And why do I say so? Once the tumor transgresses the tympanic membrane and it enters into the middle ear cleft, that is the point wherein the mastoid air cell system allows unimpeded growth of the tumor and extent within the inner ear structure, superiorly, inferiorly, and that is where we struggle for something which is called as resectability. Now, resectability in true sense, when we look at it, is the inability to get a negative margin. So what is so elusive about these tumors is how it just, the symptom complex, if we look at it, it overlaps with the benign counterpart in the ear. And when we look at squamous cell carcinoma, these are depicted pictures. It can easily be confused or mistaken with a granulation tissue. And if you look at adenoid cystic CA, it is subcutaneous and very easy to miss on a routine otoscopy. So when do you actually go in and biopsy? So that's the actual question. So any symptom complex which is not really responding to standard therapy for prolonged period of time, or any sudden onset of unusual symptoms. Now this can be otalgia, which is most common, as I told from previous study, or it can be sudden onset of facial palsy in otherwise benign presenting symptoms. So that time you should go in and do imaging and further evaluate the patient. So with this staging, as I told, is important. So Arega in 1990 came up with staging for the external auditory canal tumors, wherein they stage the tumor according to local destruction and infiltration and the medial involvement of the tumor. So, and also looked at nodal involvement. But this was updated in 2000 by Stephanie Moody et al. So what was the updation and what was the need for it? So this was the study. It's a landmark study wherein they looked into facial paresis, specifically into the external auditory canal tumors. So they looked at T1, T2 tumors, usually did not have any facial involvement. But what was important is the tumors which showed facial paralysis showed 3 modes of involvement of the facial nerve. Now it was either in the horizontal segment, which is the bony segment, in the vertical segment, or through the stylomastoid foramen. So when we talk about the involvement in the fallopian canal in the horizontal or vertical segment, we are essentially talking about extensive bony involvement. When we talk about extensive bony involvement, it is obviously a T4 tumor. And when we talk about a soft tissue which is extending through the stylomastoid foramen into the ITF, we're talking about a soft tissue extent which is more than 0.5, which is again a T4 tumor. So with this findings, they suggested a change and upgradation of facial palsy into T4 tumors. And this is where it stands. The facial palsy is ominous sign. Similarly, Araiga in the study, when they saw nodal positivity, the survival of these tumors dropped to 29%. So Higgins did a systematic review of about 21 studies and 348 patients. They looked at facial palsy specifically. And now when they saw these patients with Pittsburgh 1990 T3 and looked and compared the survival of 1990 T3 with the patients with facial palsy, the patient with facial palsy had poor survival. And also when they compared patient with and without facial palsy, the survival was worst in the facial palsy group. So this validated the change in the Pittsburgh system and also importance of facial palsy as an ominous sign. But then, though it is most widely accepted, it comes with some drawbacks. And now these drawbacks were highlighted mainly by two groups, by Ito, the Japanese group, and Mazzoni, the Italian group. What they looked at was two important vague terms used in the Pittsburgh classification, and one is extensive soft tissue involvement, and the other term is full thickness. Now, the problem with extensive soft tissue involvement, when big tumors were looked at by Ito group, what they saw was bone erosion actually correlated well with poor survival or poor disease-specific outcomes. But it did not happen with extensive soft tissue extension as per definition in the Pittsburgh. And for the term full thickness, it was valid for the tumor involving the anterior canal wall, and it is pretty vague for something with the inferior or the posterior external auditory canal wall. Now, why is it so? When we look at the anterior canal wall, we're looking at this tumor transgression into the parotid space and also into the TMJ. But when we look at the posterior involvement, it is essentially within the confines of the temporal bone. So with this, they suggested a modification in the Pittsburgh classification to specifically in the T3 and the T4 category. So wherein T3A, they define as a subheading with less than 5 mm into the parotid space, and T3B, wherein it should be grossly same as T3A, but the extension is beyond 5 mm. Now this I'll discuss in detail when I come to parotid involvement. What does this exactly mean? And then finally about the posterior extent, wherein disease can extend into the mastoid cavity without actual paralysis of the facial nerve, and T4B with paralysis of the facial nerve. And as I told, there are multiple sites which can secondarily involve the temporal bone, and those has to be appropriately staged. So all these sites, though they are actually T4 or T3 tumors of the specific subsite, but the behavior and the survival is better than the actual temporal bone tumors. For diagnosis, CT and MRI are complementary. So both has to be done, and the importance of CT is to have soft tissue delineation in the background of middle ear and the bony anatomy of the skull base, while we know MRI is important for the leptomeningeal disease, brain parenchyma, perineural spread, perivascular spread, and bone marrow involvement, and also the parotid, TMJ. But the limitation when it comes to CT is that it cannot actually differentiate between inflamed mucosa or the tumor. This is a landmark study which was done by Arriaga, and he looked into the correlation of the CT with the pathological findings. And it was important, they found out that 94 out of 96 comparison of the CT finding with the pathology were accurate in his study. There was only one case which was false negative, and this case wherein there was actual tumor, but there was no bone erosion. So soft tissue extent was not picked up well when the erosion was absent or when erosion is less than 2 mm in cases of CT scan. But what was more important in this landmark study is he defined a systematic way in which to analyze the imaging, of a systematic way in which to analyze the imaging. So he defined 4 quadrants of the external auditory canal: the superior, inferior, anterior, and posterior. Then middle ear cleft or middle ear cavity has to be looked in, mastoid involvement, and tegment, jugular fossa, carotid, and posterior fossa, and finally the otic capsule. This map is usually to know the extent of the disease and also plan out the surgical resection based on what the extent is. And finally, with this MRI advantage is to differentiate the tumor, the mastoiditis, cholesteatoma. The most important application of MRI would be in decision making of a critical case wherein decision has to be made for sigmoid sinus or internal jugular vein resection, and it is important to determine the adequacy of tocula and to know the contralateral drainage pathway before we embark into any resection. Now, having known how to define the extent of the tumor, and me previously calling eardrum as the entrance line for the temporal bone, here is the study which has exactly looked into the same point. So it talks about the prognostic impact of the advanced tumors. And in this study, if you look at in the multivariate various analysis, the ossicles, the posterior fossa dura, the pterygoid muscle, and the sigmoid sinus, these findings really had the hazard for the poor disease-specific survival. Now, when they further looked into the application and presence of these factors with either alone or as 2 or 3 factors, the survival further deteriorated and it was statistically significant. Now, what does this exactly depict is as and when the middle ear cleft and the further structures are involved, the possibility of resection, the tumor extension, and the possibility of negative margin reduces. And this is what depicts in poor disease-specific survival. And most of these patients in this series had a local recurrence. Now, coming to treatment selection. Now, it is very important to know with the incidence being so low, there is no level 1 evidence for the treatment selection in the temporal bone cancers. And all our recommendations are based on the retrospective studies. With this, just to outline, T1 tumors can well be managed with lateral temporal bone resection with or without superficial paroidectomy or radical radiotherapy. T2 tumors, lateral temporal bone resection with superficial parotid with adjuvant postoperative radiotherapy. T3 tumors, subtotal temporal bone resection with total parotid, neck dissection, adjuvant therapy in the form of RT or CRT. And T4 tumors, subtotal temporal bone, total temporal bone, parotid with neck dissection and adjuvant treatment. Now, here I would like to discuss few points regarding how to decide on the extent of the surgery. Now, sleeve resection has been very lucrative for surgeons in a way wherein there is preservation of the hearing, less vascular and less neural complication. But then it comes at some certain cost. When you look at data from Zhang, the margin positivity rate when sleeve resection was performed for the squamous cell carcinoma was 54%. In the same data, they found local recurrence was up to 41%. And similarly, Browning got a local recurrence rate of 46% with a sleeve resection. So, do you actually do sleeve resection or not? Sleeve resection can be done, but it should be done only for low-grade lesions or as a margin for lesion in the vicinity, wherein EAC sleeve is removed just for the final margin and not for the actual squamous cell carcinoma involving the external auditory canal. So, with the data available, for the external auditory canal squamous cell carcinoma, lateral temporal bone resection is the bare minimum surgery which should be performed. But then there's always been a question about piecemeal versus en bloc. So, what exactly is piecemeal when we talk about temporal bone resection? It's basically sequential resection. So, how do we sequence it? So, we start with the removal of the soft tissue. We'll remove all the soft tissue and then do bone work, which would be sequential drilling till the margin obtained is negative. Now, the problem really in temporal bone is inavailability of frozen section for the bone. And that's where it becomes very tricky to define the final negative margins. While the en bloc resection goes by the principles of cancer resection, wherein complete removal of organ can be done without tumor spillage and dissection is done in the anatomical planes. So this question really arises in big tumors. So what is the data available for it? So if you look at T3, T4 on tumors, en bloc versus piecemeal resection, on the left side is all en bloc resection, and on the right side there are only 2 studies which are retrospective data showing disease-free survival in patients with piecemeal resection. But if you look at the numbers, these are pretty comparable with range of 44 to 59% in the en bloc group and up to 50 to 59% in the piecemeal group. But then for big tumors, piecemeal is something which is now very well established. But what about the small tumors which are restricted in the bony canal? but have extensive soft tissue component, which can be more lateral or inferior without actual medial involvement. So this was exactly what looked into by Thomas Muhlmann. So they compared the piecemeal and en bloc resection approaches for the lateral temporal bone. And when they compared the survival for en bloc was about 38 months, and for the piecemeal resection was 37 months, and this was not statistically, the difference was not statistically significant. So it, with this, there are experience-based modification of tumor resection which are established. So this is one important anatomical study by Commune, which talked about variation of the en bloc resection for advanced auditory canal tumors. Now, the variations of LTBR, which is lateral temporal bone, has already been defined by Medina way back in 1990. But these variations, how does they come upon, and what is the exact anatomical basis for it? That is more important to know. For a conventional lateral temporal bone resection, one would keep the soft tissue attached with it and just disjunct the canal just above the fallopian canal and remove the tumor en bloc containing spilling it without a spillage. So what are the modification wherein you are seeing extended LTBR is posterior extension, inferior extension, superior and anterior. Now what do you mean by these extensions wherein the modifications are, if you look at anterior extension, the important points to consider are resection of condyle, resection of glenoid fossa. If there is involvement of the condyle alone, then this tumor can be well contained with LTBR and resection of the condyle alone. But if there is involvement of the glenoid fossa, then one has to do a craniotomy. Similarly, for superior extent, one has to decide directly on craniotomy along with the lateral temporal bone. But when you're talking about posterior extent, we have to look it into two parts. If we are talking about lateral extent or posterior extent without facial paresis, there we might have to just open up the facial canal and not actually resect the canal, which would be extension of the lateral temporal bone, but not exactly a subtotal temporal bone resection. And inferior extent through the stylomastoid foramen, to contain the disease into the ITF through the stylomastoid foramen, one might have to follow the infralabyrinthine pathway all the way to the jugular foramen, do retrosigmoid dissection, and then probably en bloc or piecemeal resection along with the styloid base. So similarly, the soft tissue from the in the subtotal temporal bone can be initially removed, and then drilling can be done in sequential manner. And further additional adjuncts, we will be talking about neck dissection, parotid, in the next slide. So talking about extent of parotidectomy. So why parotid is important in temporal bone? It is the first Achillean nodes which are seen within the parotid gland. And there is also possibility of direct extension to the natural foramen and the fissure, which is Hutchkiss and Santonelli. Now, why it is important? Because if you look at squamous cell carcinoma, the advanced stage carcinoma will have a direct spread into the parotid. But when we look at adenoid cystic CA pathology, it is unique in a way wherein even the low-grade tumor will have direct extension, but they don't show intraparotid nodal involvement. Now, this has some bearing on actual extent of parotidectomy. Why it is so? Because when we look at the parotid in embryologically, the lymphatics actually growing, and that's why we have to decide on parotidectomy extension. So we look at this study by Lee et al., wherein they have seen the extent of parotidectomy. So for squamous cell carcinoma, as told, there's direct extension only in the advanced stages, and for adenoid cystic, it is seen even in the early stages. So for minimum parotidectomy for adenoid cystic for squamous cell carcinoma is superficial parotid, and for adenoid cystic CA, they have suggested something called as partial basal resection, which is removal of only the paraglenoid lobe, which can contain the direct extension and no need of actually going in dissect complete lobe. Neck dissection level 2 is most common, and level 5 seen only and only when there's postauricular extension. So Moffat has suggested a removal of selective neck dissection level 2 to 3 for just proper staging of the tumor. But this is one important retrospective study done by Rinaldo, wherein they've looked into a total 491 patients from 18 institute and found an incidence rate of 17.1%, which is contrary to the belief of low nodal metastasis in the EAC canal. So the best option would be to do an intraop level 2 frozen and then guide neck dissection according to it. And another important is a controversial topic is mandibular condyle dissection. So Moffat in his LTBR series, he has been removing the condyle in all the cases, whether it's T1 or T2, irrespective of the extent of the disease. But this is important study by Hosokawa, who looked into the actual pathological findings of the removed specimen, and they found that the soft tissue involvement was seen only in the tumor, which showed anterior bony wall erosion of more than 2 mm. And finally, the defect can be closed with free fat and temporalis flap, and if the defect is larger, can always be closed with a free flap microvascular reconstruction. If there's a lateral temporal bone resection, one can also consider osseointegrated implant for hearing rehabilitation. If there's radiotherapy, it can be done. It is usually done in second stage, but after radiotherapy, one should wait for at least 6 months. And if auricular is resected, auricular prosthesis can be used. So what are the surgical contraindication? Actually, it's local extent with massive intracranial extension, cavernous sinus involvement, vertebral artery involvement, or the cervical vertebral erosion, and also hypoglossal canal involvement or intercarotid artery involvement, and of course distal metastatic disease and patient with poor general health. So to conclude, temporal cancer origin and extent should be appropriately identified and staged. For SCC of the ear canal, T staging is an important independent factor. For T1, surgery alone is preferred over radical RT, and T1, T2 can be completely excised with lateral temporal bone resection, and survival is 100%, 76% in a series by Morita. T3, T4, one can go with modified lateral temporal bone or a subtotal temporal bone or total temporal bone with survival 55% or 36%. So adjuvant postoperative radiotherapy should be considered from T2 to T4, and finally for unresectable disease, one should consider chemoradiotherapy. Now, there has been one study wherein possibility of a use of neoadjuvant therapy for unresectable disease with which can be further resected has been looked into. Thank you.
Thank you, Dr. Yogesh. May I call upon next speaker, Dr. Smita Matthias. She'll be speaking on speech and swallowing rehabilitation after surgery for tumors of the skull base.
Good afternoon, everyone. I thank the organizers, especially Dr. Komal Prasad and the entire team of Neurosurgery for giving me this opportunity to speak to you all on speech, language, and swallowing rehabilitation in patients with brain tumors. I will talk about the impact of the tumor type, treatments involved and their effects, speech, language, and swallowing disorders, and dynamic rehabilitation plan. So the size and location of the tumor is the most important in understanding what the functional impairments will be, whether the tumors are at the supratentorial level or the infratentorial level, and whether the pathology is either benign or malignant. The treatments and post-treatment effects will definitely impact rehabilitation, whether it may be cerebral mutism, excessive crying seen in children, hemiparesis, drowsiness, radiation side effects like mucositis, xerostomia, edema, erythema, and of course, fatigue, nausea, and vomiting caused by chemotherapy. We need to assess the patients and describe what specific speech language problems they have, whether it's dysarthria, apraxia, voice, fluency, or articulation disorders. In terms of language, whether it's aphasia with or without cognitive issues of attention, concentration, memory, problem solving, and whether they have feeding plus or minus swallowing issues. We then create a dynamic rehabilitation plan, understanding whether the symptoms are stable or fluctuating. If it is a speech disorder, the end will be to work on improving speech intelligibility and understandability. If it is a speech and language problem, first work on improving language information content, manage communication breakdowns, use augmentative communication, and then once the language is improved, work on speech intelligibility. If there are speech, language, and swallowing problems, swallowing always precedes the other two. So anti-aspiration care, depending on oral and nutritional feeding, plus or minus voice care, depending on whether the patient is tracheostomized with or without speech valves, working on language content, and then of course intelligibility and understandability. Aphasia is an acquired language impairment following brain damage, and the patient can have problems in either one or more of these parameters of language. This loss of language can cause cognitive deficits, emotional outbursts, social isolation, mood swings, depression, and overall affecting quality of life. When you assess the patient and make a tailor-made plan, you always understand the impairment, the function, the pathophysiology, and then the activities and the participations depending on their profession and on their personalities. Different approaches used for language therapy vary from conventional approaches to melodic intonation therapy, reading approaches, functional approaches, communication, cognitive linguistic approaches, group psycholinguistic approaches, social support, stimulation. ASC, telepractice was used a lot during the COVID time. Computer-mediated and constraint-restraint therapy are a few approaches. Moving on to dysarthria, unclear speech, which is difficult for listeners to understand when the face, tongue, and throat muscles are weak, slow, and uncoordinated. These patients usually do not have difficulties in thinking, remembering, or retrieving words. So their symptoms can be unclear speech, depending on rapid rate of speech or slow rate of speech, poor opening up the mouth, poor co-articulation from one sound to another, a soft voice, a monotonous speech, a raspy voice, or difficulty in rhythm, rate, stress, or intonation. Here we do a systems approach where we assess the respiratory system, phonatory system, articulatory system, resonatory system, prosody, and the naturalness of speech. Techniques in therapeutics depend on speaker-oriented approaches, which can be behavioral, prosthetic, medical, or surgical approaches. Communication-oriented strategies can be speaker strategies where we work on the patient themselves, listener strategies where we work on both the communication partners, we work on pragmatic strategies, we analyze what kind of breakdowns there are in communication, what kind of resolutions and trouble spots will help the communication be successful. We also work on interaction strategies, which is a combination of both. Moving on to dysphagia, difficulty in swallowing, where the patient can have difficulty in any of the consistencies of food or liquid. This is the latest classification, the ITSE framework, where we divide the consistencies and we try to analyze them and see what are the problems the patient has. So the patient can have difficulty in liquids, semi-solids, solids, and medicines, difficulty in taking them safely, efficiently, and adequately. And these problems can take place at all the 4 stages of swallowing: oral preparatory, oral transit or propulsion, pharyngeal or esophageal stage. Here in the stages of swallowing, you can see the contrast of the bolus moving from the lip onwards. So in the oral preparatory phase, where you have the oral musculature and the bulbar muscles, where the bolus has to be prepared. Then you have the transit phase, where the timing of transit is very important. Otherwise, you can have premature spillage and have premature aspiration. Then you have the third phase, which is the most important, pharyngeal phase, where the nasal regurgitation should be prevented, premature spillage, aspiration, and penetration, and of course the cough reflex, which will prevent airway entry. And finally, the esophageal phase, where you have entry of the bolus into the esophagus and then prevention of retrograde aspiration based on the peristaltic movement. Here you see the coordination of the respiration and swallowing during the third phase of swallowing, where you have apnea. So if you don't have all three levels of closure, where there is arytenoid closure, epiglottic closure, and vocal cord closure, the larynx tends to be open during swallowing and the patient is at high risk of aspiration. Here are some of the symptoms of dysphagia. They can be direct symptoms or they can be indirect symptoms. Direct symptoms are choking and change in voice post swallow and choke and breathing difficulty. You can have indirect symptoms as well, whereas the patient has loss of weight, the patient takes a long time while eating, the complaint of food getting stuck in the throat. All these should be assessed in detail. So the swallowing evaluation can happen before prophylactic, when the surgeon knows that the patient can land up with a swallowing problem. It can also happen indirectly, where the patient already has acquired aspiration pneumonia in the ICU and either the reference comes from neurosurgery or pulmonology or the intensivist to start the swallowing rehab in a patient who's already having symptoms of pneumonia. So we work on them step by step, do a baseline clinical swallow evaluation at the bedside, and which involves a neuromotor evaluation, cranial nerve assessment, assessment of the phonatory, resonatory, and the respiratory systems, depending if they have, different tracheostomy tubes which are required to protect the airway from aspiration. We also then use different instrumental techniques like fiber optic endoscopic evaluation of swallow and video fluoroscopic swallow study, depending on which phase of swallow has to be assessed. And we use it as both an assessment and a management technique. So these are the different parameters based on which we decide which kind of assessment is beneficial to the patient. So if it is visualization, you decide based on which phase of swallowing you want to assess. If it's sensory assessment, it's better to use FEES, whereas we can directly assess the laryngeal adductor reflex. If you want to see both sides clearly, FEES is a better assessment. If age is a factor, then of course fluoroscopy is easier for all age groups and easy to perform in difficult to test populations. Therapeutic usage, both can be used. Accessibility, of course, the C-arm cannot be moved. So depending on whether the patient can be moved to the fluoroscopy suite, endoscopy can be performed at the bedside as well. Depending on whether the patient can take the barium, other dyes are also used. We also use different type of consistencies of food for both assessments, but you have to keep an eye that when you use a dye, the normal consistency of the food changes. So what you use directly and what you use with a mixed dye can be different. The duration of exposure, you take a call based on which phase of swallowing, how many frames need to be observed, and whether the patient needs to undergo multiple assessments. You decide which test is more beneficial. Moving to the rehabilitation, there are three main approaches. The first one being rehabilitatory approach, second compensatory, and third modern swallowing therapy. The rehabilitatory approach includes oromotor exercises, airway protection maneuvers, thermal tactile stimulation, and the Shaker's exercise. The compensatory approaches include choosing which kind of feeding access is beneficial to the patient. Usually starts with a nasogastric tube if you think it's a short-term swallowing problem, and after a month we do a detailed assessment and then see what is the prognostic plan. Modification of food consistencies depending what is safe for the patient, and analyzing which kind of tracheostomy tube the patient has, and we can work with the patient and manage safety of the airway. Use postural corrections to facilitate bolus transition, reduce the rate of eating, and ensuring oral hygiene by conventional oral care. And finally, modern swallowing therapy, which includes neuromuscular electrical stimulation, biofeedback during these procedures, where the patients themselves observe the anatomy, physiology, and they understand what's happening. We use the behavioral techniques, and they're able to follow the techniques when we give them commands during the procedure, and they can see whether the technique works for them or not. Transcranial magnetic stimulation is still in the research phase. This is a video of a patient who's undergoing FEES. I'd just like to highlight that you can see if you just do a fiber optic laryngoscopy, you will see a lot of pooling of secretions. But when you do a FEES and make the patient swallow, you can see even though there's severe pooling of saliva, the patient very safely swallows the solid bolus. So always better to assess, test, and then confirm the safety of the patient. You can see this video here where the larynx is clean, no pooling of secretions, bilateral cords are mobile. But when the patient is fed a solid bolus here, you can see there is incoordination in the swallow and the patient aspirates an entire bolus of banana here, and there's no attempt to clear and protect the airway. So don't judge the book by its cover, assess and diagnose and then manage adequately. And this is the final video of a patient of ours with glomus jugulare. You can see here, the patient had unilateral bulbar weakness from the lip up to the larynx. And you can see with years of therapy, she has improved. She's able to adequately seal her lips. She's able to have adequate propulsion. The swallow reflex is triggered at the right time. But even now, earlier she had severe aspiration, but now you can see that the pharynx is holding the residue for a long duration and there's mild penetration. So the patient is at least safe, the airway is clear, and with the help of a cuffed tracheostomy tube and a peg, they're able to manage. Finally, the take-home message, a multidisciplinary team approach is the best approach in managing these long-term patients who have either stable or fluctuating problems which affect their speech and swallowing. Early identification using these diagnostic tools are helpful in planning effective management. Both subjective and objective tools should be used to get a good comprehensive idea of the functions of the patient and tailor-make a dynamic rehabilitation plan for each patient, keeping in mind the ICF framework. Thank you.
Thank you, Dr. Smita.
Any questions here? Because this is a unique talk. Okay. Thank you, Dr. Smita. Now we will have a case discussion about two cases to reinforce what we have learned, because adenic tumors involving skull base is not very commonly seen and approach is different than routine surgeries and other methods we are exposed.
May I invite the panelist, Dr. Kiran, Senior Consultant, Department of Neurosurgery, MSMC. May I call upon Dr. Vivek, Consultant, Head and Neck Oncology, Dr. Yogesh, Consultant, Head and Neck Oncology, MSMC, Dr. Saurabh Kumar, Consultant, Radiation Oncology, and Dr. Nidhi, Consultant, Medical Oncology, MSMC. So we'll move on to the first case. We have a 33-year-old male patient who comes with right-sided nose block and epistaxis since 2 months, not previously evaluated. On examination, he's got proliferative mass in the right nasal cavity in the sphenoethmoidal recess and ipsilateral 3x3 firm enlarged node. This is his MRI scan showing enhancing lesion involving the nasal cavity, sphenoethmoidal recess, anterior ethmoid, posterior ethmoid, breaching the cribriform plate and entering the anterocranial fossa involving the brain parenchyma. Then we've got a PET scan. PET scan shows the same finding in the nasal cavity along with ipsilateral nodes and no distant metastasis. We did a nasal endoscopy and biopsy. Biopsy is revealed HAMS grade 4 esthesioneuroblastoma. Now, I would like to start with Dr. Yogesh, and what would be your treatment plan in this scenario? Mike?
So this is a
Kaddish D,
esthesioneuroblastoma, HAMS, grade 4.
4, yeah.
So regarding investigation, I could see the PET scan is already done. For a high-grade tumor, I would like to do a PET scan, and we already have done it. That is the first thing. Second thing, looking at the extent, I would like to analyze the imaging critically. Now, with this analysis, I could one image where we got extensive brain parenchymal involvement, but I would like to see one SAG cut wherein I would like to see what is the status of the dura at the plenum. Now, this is very important for me as a surgeon. Why I'm looking at it is if my dura at the plenum is involved, the margin of resection beyond that, it's very difficult to reconstruct. So if I'm looking at this tumor at the first tumor board meet, my first therapy would be to go with neoadjuvant chemotherapy first, of course. But then when I look at something wherein the tumor is involving at the plenum dura, I would deem this tumor unresectable upfront. And then after neoadjuvant, I would get the patient for chemoradiotherapy.
So basic, Dr. Kiran, anything else? From surgical side, do we offer upfront surgery or what do you think?
Yeah. First, let us, before considering the biopsy result, let us consider the differential diagnosis that we need to think, especially in our settings. There are other lesions such as meningioma, or it can be a fungal granuloma. These also can mimic this. So approach to these will be entirely different, and both from neurosurgical perspective and oncological clearance. So we need, that is why especially these kind of tumors which are involving primarily head and neck and which extends into skull base, unlike where we think it is meningioma or with extension into skull base, where most of the time the imaging will be more or less suggestive of what it is, and also most of it, like for example, it is a meningioma, we can go in and operate again, and those kind of situations will be there. Whereas as we discussed previously, in a onco-surgery perspective, first surgery is the best because it involves a lot of difficult reconstruction, and to get a margin, it needs a lot of planning. And that's why it is very, very important to biopsy these lesions and stage it before we proceed with the next line. And just can you put the images? What other questions you wanted to ask? Yeah.
So very important point you've highlighted. So diagnostic dilemma in such a nasal mass cases, and utilization of immunohistochemistry markers is very crucial for us to arrive at a specific diagnosis. So this is the MRI.
Yeah. So if this is esthesioneuroblastoma, yes, and with the significant involvement of the intracranial.
Yes.
And as Dr. Yogesh has pointed out, it involves quite significant reconstruction, and also there may be problems with respect to retraction of the brain, especially frontal lobe and others. So my first would be, if there is any neoadjuvant therapy or anything to shrink the tumor, which will make the surgery easier, that will be my first approach.
Yes. So I'll move to Dr. Nidhi then. So surgeon has advised neoadjuvant chemotherapy. Ma'am, what are the options?
So there are options of cisplatin etoposide based chemotherapy and taxane, platinum and 5-FU based chemotherapy, but largely the response rates with cisplatin etoposide chemotherapy are almost in the range of 60 to 70%. So that will be my choice of treatment, but it is quite an aggressive chemotherapy and we need a good performance status to give that.
So this patient has a good performance status and he's received near 3 cycles of neoadjuvant chemotherapy, and luckily we've got a good response, but a small residue disease along the cribriform region and the brain parenchymal portion has significantly responded. This is the sagittal section of the same. Now, I'll come back to Dr. Yogesh now. So what's your plan now? Now we have seen the very good response.
Yeah. So I would like to point out at the imaging. So when we look at the dura there, it's there's no nodularity. It looks like enhancing all along.
Correct.
Now there is very important point to note because the nodularity actually points to exact involvement of the dura.
Yeah.
The response is excellent. This response is excellent and it's seldom seen actually to this extent. But what my plan after this would be certainly to go ahead with surgery. Surgical approach would be endoscopic and it would be endoscopic transcribiform. Now, as I told you, my concern previously, the approach would have probably changed if there was some finding which was with respect to dural involvement. Approach could have been cranioendoscopic, wherein endoscopic I would have dealt with the nasal part and then asked neurosurgery help for the posterior part. Now, another important point, which is that now even after I see the regression here, my approach to this tumor would still be the pre-NCT scan. I will go in and resect the structures in the nasal cavity exactly how they were in the pre-NCT scan, and I won't go by the current regression.
Very important point to be noted. Yeah. Kiran sir, anything else? So when would you agree with Dr. Yogesh to go ahead with the transnasal endoscopic approach, or would you employ on craniotomy? Looking at this response and the disease extent.
Yeah, the intracranial extension now is not significant, but of course there is a dural enhancement. So we need to, as Dr. Yogesh has pointed out, we need to resect all the parts which is enhancing. So in which case we can do endoscopic, because many of the literature's current does not favor only in block resection and things like that. But of course we need to have a resection, reconstruction. So with that in mind, I will keep a craniotomy option with a pericranial flap as a standby in case if adult or facial ATAF, everything. So our dictum would be, in case if the dura is breached or need to be removed, we need to have at least 3-layer closure. Yes. You need to have a 3-layer closure and at least one of it should be pedicled. So in that way, even if endoscopy is done from nasal perspective, I will still keep an option open. Of course, now there are different approaches like subcranial approach wherein we need not have to do a complete craniotomy. And second is that if it is only for resection, reconstruction through a bicoronal incision, we can raise the pericranial flap down and put for a pedicranial in addition to the regular ADA flap. So these options are available. Craniotomy is not a must, and of course it is in the tool whether you can use endoscopic or craniofacial resection. That is an option which each person can consider.
Yeah, very important point. Subcranial approach. If there is no gross parenchymal invasion, if there is only dural involvement, and subcranial approach is a very good option for us, where we avoid frontal lobe retraction. Yeah, Dr. Yogesh.
One additional point I would like to make: when I go in the endoscopic and resect dura, the posterior margin of the dura and the olfactory fibers, I would like to have a frozen control. So that gives me a better idea about my resection, and also to the pathologist and to the radiation oncologist, how was the resection, whether it was R+ or R0.
Agreed. So frozen section control in any endoscopic nasal surgery for handling sinonasal malignancies is compulsory to get a margin-free resection. Now, lumbar drain. What is your take on lumbar drain, sir? If you have done a pure endoscopic resection, resecting dura from the entire dura along the cribriform plate, and there is not much of high pressure leak at the time of surgery. What is your take on lumbar drain?
In this case, if as we are planning to resect the complete ACF base, that could be from other things, I would like to keep an option of lumbar drain. So if it is a small leak, just where we need to remove only a small part of the dura, in which case we don't use it. But in this case, because this is a frontal lobe, there is likely to be a pressure and even encephaloscale kind of picture. We would like to keep the option of lumbar drain in this particular case. Maybe in other case, it may not be needed.
Taken. So, Dr. Yogesh, can you what are the reconstruction options endoscopically?
So endoscopically, I would certainly like to do a 3-layer reconstruction. And this 3-layer reconstruction can be considered in 2 forms. I would like to use a tensor-fascial latta, which would be 2-layer, and I would cover the 3rd layer with the Haddad pedicle flap.
Yes. Now we have got the report as same HEMS for esthesioneuroblastoma, and one important thing about neck dissections. Patient had ipsilateral neck dissection which didn't respond well to the NSCT, so I am sure we will address the neck also. And on the final histopathology, all the neck nodes turned out to be negative. Then we need to plan an adjuvant treatment. I'll go more to Dr. Saurabh regarding the adjuvant treatment. It is esthesioneuroblastoma grade 4 N0, and all the margins are negative. What would you plan?
So we'll be planning. Yeah, so we will be planning for IMRT based conformal radiation therapy to the post-operative bed. And in this case, I would probably treat the nodes also, because on the PET scan initially there were neck nodes. So the involved neck sites will be included in the radiation field.
Would you go for only RT or CT with chemo RT?
So because the patient has had a very good response, I would consider some form of concurrent CTRT.
CTRT.
Yeah.
Ma'am, does you still continue with cisplatin with adjuvant CTRT?
So ideally, if we have given cisplatin-based chemotherapy in the neoadjuvant setting, we need to compromise to carboplatin-based concurrent chemoradiation. But a lot of our patients have had used cisplatin in both the settings, and they have tolerated it fairly well. So if as you mentioned, the patient is young and has a good performance status, I would like to give cisplatin only.
Fine. So patient will receive adjuvant chemotherapy. I will come back to Kiran sir. So what's your protocol for follow-up imaging, sir? When would you want to do after completion of chemoradiation? What do you want, a PET scan, MRI? What is it? How do you follow up?
Of course, PET CT is needed. That usually will be around 3 months. Because there may be a lot of post-op changes which may show up as a bright. And to see immediately, I would like to ask for a CT scan brain to see any changes or pneumocephalus, those kind of things for immediate complications. And later on at 1 month for MRI, and later on 3 months, and as required based on the, because they need to combine radiation, for that planning, they would need a MRI. So at that time we can time it along with them. That would be ideal instead of repeating, MRI again and again.
One quick question to Dr. Yogesh. So, how do you follow up on nasal hygiene in post-op in such cases? How frequent? When would you start nasal douching, or how often would you do a cleaning, endoscopic cleaning?
So after 3-layered closure, it's very important to give healing at least 3 weeks of time. So in those 3 weeks, I'll follow up the patient every week in OPD and do a undervision cleaning. Okay. And once the 3-week time period is over, then I would like to start nasal douching. And that douching can continue even in the post radiotherapy period, because there'll be a lot of crusting even that period. There is one additional point I actually wanted to make on follow up. First is, I would like to do a baseline MRI also along with PET scan. PET scan is must in this patient because it's a high-grade lesion with metastasis. So PET scan at first 3-month follow-up is must. But I would like to do a baseline MRI at the same time. Now, because after this, I would be just following up this patient every 6 months with an imaging, and that would be MRI. So that gives me a better idea about everything what I need to know in the area with respect to my reconstruction, so recurrence along the dura and recurrence parenchymal into the neural tissue.
Agreed. Well taken. So we'll move to this, the evidence which tells in particularly in SSC neuroblastoma, Ham's grade plays a very important role in predicting overall survival and metastasis. And the outcome in terms of local regional control and overall survival doesn't differ much. Either we approach the tumor by endoscopic route or by by craniotomy, provided the complete tumor is removed and we've got a negative margins. We'll move to anything, sir?
Before that, any other difference of opinion either amongst panelists or audience? They want to ask any question, clarification or comments, difference of opinion? Okay, yeah.
So I'd like to speak regarding lumbar drain actually. So in this case, probably we might not electively put a lumbar drain even after endoscopic reconstruction. I'd like to keep the patient immobile for about 5 days and would like to remove the packs under vision in OT and not put a lumbar drain till I actually go in and have any objective finding of CSF leak. Till that time, there's a meta-analysis recently which has come up actually and it doesn't support in elective placement of lumbar drains in these tumors. So that and in practice we had not really been putting lumbar drains electively in this endoscopic transcribiform patients.
Yeah, I agree with you, but it depends on literature and our own personal experience and the setup we are in which case, and also especially it is in an interdisciplinary situation where we may not have access to the patient after a few days and other scenarios, and there is also a chance of delayed leak after radiation and other scenarios. So we need to be prudent. So in this case, of course, in a smaller case, I won't put, and we don't like to put lumbar drain because of the complications involved. But if there is involvement and removal of the bone beyond about 2 centimeters, say cribriform and up to planum, I would like to place a lumbar drain. If it is just a small 0.5 or 1 centimeter and other things, especially if it goes anterior, then the chance of repair and to ensure efficient, that it is all CSF, there is no leak is little less. And also there will be some scenarios where we may have to use some other flap and other technique, muscle or microvascular flaps and other things, in which case it will be very difficult to know the secretions. We have many other times, there is a secretion coming and all those things will be there. And to see all that in our scenarios, I would like to put a lumbar drain, but of course it is optional and depending on our own institute experience, we can tailor it.
Definitely, yeah. So we'll move to the next case. We have a 35-year-old gentleman comes to us with a right side epiphora nasal obstruction and headache since 4 months. Again, on examination, proliferative mass in the right nasal cavity, probably arising from ethmoids. Middle turbinate is pushed medially. Overlying skin is normal, no neck nodes, and vision is normal. This is the imaging, which is showing lesion extending up to the cribriform plate with the dural involvement, involving the nasal cavity, anterior and posterior ethmoids. Orbit looks fine, orbital apex looks okay. And no neck nodes on PET-CT, no distant metastasis. Biopsies turns out to be adenoid cystic carcinoma tubular variant. So looking at the diagnosis of adenoid cystic carcinoma, I'll go back to the MRI. I'll go to Dr. Yogesh first. Anything else specifically for adenoid cystic carcinoma you are looking at MRI?
So for me, the origin of adenoid cystic CA in this region is primarily in the nasolacrimal duct region. Now, when I say it's nasolacrimal duct region, obviously I look for and assess it in 2 ways. First is imaging, of course, and DNA. My diagnostic nasal endoscopy is very important, wherein I will look into the inferior meatus. I will look also at the uncinate where it curves onto the inferior turbinate. And I would also like to look in the imaging the same area going all the way to the lacrimal sac. Now, why is it important? Because when I want to contain this tumor, I'm looking at possibility of two approaches, purely endoscopic approach or endoscopic combined with a sublabial approach, wherein I would like to contain the tumor all the way till the lacrimal sac. Now, this is very important because cystic CA can be really, really deceptive. So even if I do this resection endoscopically under frozen control, there is still a possibility of having skip lesion, which can go all the way till the lacrimal sac. And in that case, when I miss out the tumor into the lacrimal sac, which is abutting the orbital periorbita, I'm looking at a recurrence, which can be local recurrence, and eventually I'm looking at orbital excentation, which could have been allayed at this point.
Yeah. Another point is about perineural invasion in adenoid cystic carcinoma. So how do we approach this case, Kiran sir, adenoid cystic carcinoma with the dural involvement?
Two things. One is dural involvement, another is neural involvement. Both Yogesh has stressed. And if it has been involving a little bit laterally or involving maxilla, we need to consider whether it has involved V1, V2, V3, especially V2 and V3 in these scenarios. The MRI always cannot reflect the complete picture because of the nasal anatomy and probably sinusitis and other issues. So it can be operated through endoscopy. I would be in that region to do the biopsy of that, especially if it is involving the nerves, is very critical. That's what I feel. And because the intracranial involvement is not much, even I think the reconstruction can be done endoscopically.
So this patient underwent an endoscopic excision. About frozen section, I think we have discussed earlier also for margins, especially in this case along the periorbital fat margin needs to be assessed for negativity to ensure complete resection. Neck dissection. Would you address neck, Dr. Yogesh, in this case? It's a N0 T2 nasal cavity adenoid cystic carcinoma.
So there's a data by Amit Moran which shows that N0 neck in these localities really don't have a incidence of nodal metastasis. So I would not address neck in particular. I just want to add on one point regarding margins. So when I removed this tumor, when I spoke about combined approach with sublabial and this thing, my goal of the removal is set at 2 points. One was lacrimal sac, which I exactly spoke about. And the next point is about pterygopalatine fossa. Now the pterygopalatine fossa I would clear off completely. I'll take margins and send frozen at the median and rotundum. Once I get that, I'll drill out the pterygoid wedge. So that would be my final completion surgery, even if I do either of the approach. So
but then we still tend to have a skip metastasis.
Yes, yes,
even if we get a negative margin at the cut end, would you still be worried?
Sorry?
Would you still be worried if you get a negative margin on frozen section?
So
on the,
that is the best possible thing I could have done at the point of resection. And the next, then I'll look upon my radiation oncology colleagues.
Correct.
Take care.
I'll move to him now. Dr. Saurabh, what will be the adjuvant treatment? No neck nodal involvement, T2 adenoid cystic carcinoma nasal cavity. Would you give any adjuvant treatment?
Yeah, we as such, we follow to give adjuvant radiation for all the adenoid cystic carcinoma. Though there is a very small subset of population, maybe a very selective early adenoid cystic, probably there is some data to put them on observation. But then there should be no PNI or any other high risk factors. So only that subset probably we can avoid. But in total, I think majority of the adenoid cystic carcinomas should get adjuvant radiation therapy. I think we have followed up 1 or 2 cases where we have not given adjuvant RT. So I'm not sure what is the follow-up with those patients, but from my understanding, all adenoid cystic carcinomas has to get adjuvant RT.
Definitely. So what is
no role of any elective neck
elective neck? Yeah, I was about to ask. Second thing, how posterior would you now? Dr. Yogesh is drilled out up to the foramen rotundum. He's got negative margin on frozen section. Would you include that area up to the trigeminal ganglion in your radiation field to encompass this thing, the perineural invasion?
So we will include the foramina, but we would try to avoid radiation to the temporal fossa as far as possible, because we've seen a lot of toxicity because of that.
Okay.
We will trace along, but will not go up to
the ma'am, any role of chemo in a gland?
No role of chemo.
Yeah, more important, eye. We preserve the eye during surgery. I get a negative margin on the periorbita, I preserve the eye. But then how would you shield during RT? How would we prevent eye morbidity during RT?
So with the current.
And what are your concerns while radiating in the para-orbital regions?
No, when with the current technology, whatever we are having like IMRT or volumetric arc therapy, we will be restricting the doses to eye, the optic nerves, the chiasma, all these areas can be avoided, and at least we will not be irradiating to higher dose levels. In the same time, we will not be compromising on the bed dose. Lens is the only critical structure, but that in the current era, we are not that much concerned.
So it's a difficult scenario now. Like Dr. Yogesh told, we'll be resecting of the pterygopalatine fossa, so there will be dryness, and upon that patient is receiving RT. So invariably there will be some amount of functional morbidity, I believe. So any questions from the audience? Yeah. Post-op imaging and follow-up, Dr. Yogesh.
So again,
Adenoid cystic carcinoma.
Yes. So first post-op imaging, I would like to do at 3 months, and that would be in the form of MRI along with either a chest X-ray would suffice, because I'm essentially looking at distant mets as also a local recurrence. These are slow growing tumors and have delayed metastasis. So I'll be looking at a more prolonged follow-up in these patients. So I won't be very aggressive initially at the start.
Yeah. So we've got a good meta-analysis for the adenoid cystic carcinoma of nasal cavity, which shows different outcome based on the site of origin, like what Dr. Yogesh was telling, and the importance of getting negative margins, and the importance of surgery with radiation, and importance of perineural invasion. All these things predict the outcome in adenoid cystic carcinoma of nasal cavity. We'll move on to the next case. So we'll directly, yeah. I'd like to take Dr. Vivek's opinion. So a huge adenoid cystic carcinoma involving the face, and we do this big resection involving the orbit and facial skin. What are your options for reconstruction?
So the reconstructive approach is basically to fill up the cavity and make sure that there is separation. Is the maxilla involved?
Yes, yes, maxilla has been removed.
Okay, so the important thing is to separate out the nasal cavity and the maxilla from the skull base and orbit. So if any local flaps will come, then we'll do that. Otherwise, we can always do a free flap. So probably an anterolateral thigh flap. Put the skin into to line the lateral wall of to close off the sinonasal space, and then deepthelize and put the fat and the adipose, I mean the muscle, into the skull base area.
So separation of the cranial cavity from the aerodigestive tract, separation of the oral cavity from the nasal cavity for a better functional outcome is very important. So we'll move on to our next case. 50-year-old lady presented to us with a left-sided ear block and decreased hearing and tinnitus in 6 months. On examination, there's a proliferative mass involving the left external canal, adherent to the anterior wall. It is free from the roof, posterior wall, and the floor. No neck nodes. Facial nerve is normal. This is the imaging. Okay, it is involving the external canal extending into mastoid and erosion of the temporomandibular joint with dural involvement along the temporal fossa with no intraparenchymal extension. And the sigmoid sinus, the jugular fossa, everything looks free. We did a CT scan of the chest, which shows small indeterminate nodules in the left lung, and the histopathology turned out to be adenoid cystic carcinoma, cribriform variant. How would we proceed with this case? Indeterminate lung nodules and adenoid cystic carcinoma. Dr. Yogesh, you want to start off? Would you keep the patient on curative intent or palliative intent?
I would
seeking.
keep, with adenoid cystic pathology, I would still keep the patient on curative intent. And primarily when we looked at this adenoid cystic carcinomas in this region, they behave similar to what salivary gland adenoid cystic behave like. So three, four important points in this assessment of this patient in particular. So we were talking about a lesion which is into the anterior ear canal. So obviously I'm looking at direct extension into the parotid space. So even if the origin, we are not able to, with this extent of lesion, it's difficult to know whether it's parotid coming in or ceruminous adenoid cystic going out.
Outside.
It's difficult to make. But then anyways, this is a T4 lesion to look at. So my goals of surgery would be to goals would first to assess, and assessment is about the middle ear cleft incomplete and the inner ear. Now that is what defines the limits of my surgical resection, and that is important because the lateral structures are something which are expendable and easily be removed, but in the medial structures are something which to be appropriately assessed, and that can be done with CT and MR both, which I have in front. Second thing, with this extension superiorly, I'm looking at a combined approach. So there are two things I'm looking while looking at the scan. I'm looking at.
So the middle ear structures appear normal. It is restricted to external canal and mastoid involving dura. Kiran sir, how would you go about this case?
Two important considerations. One is this is a slow growing tumor, and hence functional preservation is a paramount importance. So facial nerve preservation during the surgery and approach, that would be one. And second, if condyle resection is planned, then it will be very close to ICA. So two things would be my consideration. Of course, dural reconstruction is not a major issue in this case. And third is the proximity to the sinus. And even though sinus per se is not involved, there can be a sinus or a superficial petrosal artery vein, sinus. Those can get thrombosed even with long-standing surgery. If we have to irrigate during the surgery, or if there is a pressure effect, there can be a chance of sinus thrombosis. So these are the main considerations I would like to keep in mind.
Would you go with pre-sigmoid approach, or how is it?
I think it depends on whether we need to resect. This is not like an approach kind of thing. So we need to resect if the involved skin and other tissues are involved. Based on that, we need to take out and all the suspected temporal bone, including mastoid, everything we need to remove. So it will involve a sort of pre-sigmoid. It's a classical modified temporal dissection rather than approach kind of thing. Yeah.
Agreed. So facial nerve, what we
one point I would like to
yes, ma'am.
Dr. Yogesh and Dr. Kiran just mentioned. So adenoid cystic carcinomas are maybe solid type, cribriform type, and tubular type. And cribriform and tubular are what are indolent, and in those cases we will definitely proceed with the curative surgery for the head and neck region, whereas solid are very aggressive, and in those we would try to either biopsy the lung lesion to prove or go ahead with the PET CT scan.
Okay. What would do with the facial nerve? Would we try to preserve it?
Preoperative facial
It was
nerve
normal
is
status.
normal. So when I look at the scan and whatever pictures were presented, I look at disease which is more anterior superior and similarly following more towards the TM joint. So the disease, as what you told me, the medial component is not there, right?
No, middle involvement is not.
So the possible areas wherein facial can be involved, I'm looking at horizontal and vertical segment and salomastoid foramen. These three are essentially free of tumor. So I would like to preserve the facial nerve, and I would like to do what my plan about this surgery would be to do a superficial parotid, wherein I soft tissue of the parotid I would keep attached onto the soft tissue of the external auditory canal. And why this is important, because I've spoken about the direct extension in the adenoid cystic CA. So when that is curtailed, then I go for the anterior part. And anterior part, if I know information with the scan about the glenoid fossa, very good. Wherein in the sagittal cut of the MRI, I will look for the capsule I will look for the joint space. I will look for what and compare CT for the condyle appearance and the neck appearance. Now, these are very important findings for me right now. And if I don't have information on this, when I eventually go and remove this soft tissue part of the tumor, I will do multiple frozen section at the capsule. Now, this multiple frozen section at the capsule actually will help me guide to whether I go with resection of the condyle or not. Now, the important part of knowing the glenoid fossa involvement beforehand is that you're very clear about surgical approach not being piecemeal, and you have to go with craniotomy. So because when glenoid fossa is involved, you cannot go in with this approach. So you can still get rid of soft tissue as a piecemeal, but for bone, you have to be more holistic.
Agreed.
And as sir said about carotid, you have to be careful when carotid would be right there medially when you go to glenoid fossa.
What would you do with the neck? Would you address neck?
In this case, yes.
It was clinically N0, radiologically N0.
But so there are two scenarios actually. Looking at the lesion, the incision would be just in the area where we can easily do neck dissection. But if there are any inhibitions, I would like to send level 2 frozen. And if level 2 frozen is positive, I will address the neck. If I don't have a frozen control, then I would like to go ahead with at least level 2 to 4 neck dissection.
Ipsilateral 2 to 4 neck dissection, yeah. So it was patient underwent surgery, and the final histopathology was adenoid cystic carcinoma, cribriform variant, PNA positive, margins are clear. 1 out of 25 nodes was positive in level 2B. We'll move to Dr. Saurabh. Regarding adjuvant treatment, would you consider her for adjuvant treatment?
We usually consider adjuvant RT even in a metastatic setting, just to give a local control, good local control.
Okay. Ma'am, any role of adjuvant CTRT in this setting where you have an indeterminate nodule? And how frequently would you want to follow up the nodule?
So no role of concurrent cisplatin, because that is to increase the locoregional control, and this does not suffice for that. As regards to adjuvant chemotherapy, there is no data, and we would like to follow up once in 3 months for those lung nodules.
C-kit, we need to speak about the CD1 ones. What does it mean to you for giving adjuvant chemo in a metastatic setting, or if this patient progresses or presents at a later date with distant metastasis, does this have any value?
So in metastatic or unresectable adenoid cystic carcinomas, if we are treating with the palliative intent, there are targeted therapies available. Testing for CD117 is one of them, and there are others like androgen receptors and HER2/neu receptors for which targeted therapies are available. The chemotherapy which is used in adenoid cystic carcinoma is quite toxic. So imatinib, which is an agent against the c-KIT or CD117, is an oral tablet which is very well tolerated, so that can be offered.
Yes, okay. So I'll come back to Dr. Vivek once. Any role of regional flaps or free flaps when we have a pinna resection?
Pinna resection generally, I mean, depends on whether you're giving radiation post-op immediately. If the radiation is being planned, then better to hold on, because pinna generally is reconstructed using rib grafts. So those are free bone grafts, not advisable to put it in a field of radiation. But otherwise, yeah, you can use this thing. So we have to keep the superficial temporal artery and use the temporoparietal fascia flap. So you can wrap you need to shape the ribs into the shape of the pinna and wrap it in that, and then we can use it for reconstruction. Of course, it's going to need multiple stages.
Multiple stage procedures, processes. So facial nerve, in case we decide to sacrifice facial nerve, what would be our options there?
I'd like to do an immediate reconstruction on table if we can get both the ends. The best thing is to take a sural nerve graft or a greater auricular, whichever is available, and do an immediate cable graft. If the patient presents at a later phase, then we'll need to do, depending on how late they present. If it's within 12 to 18 months, we'll get a EMG studies and look at the muscular end plates. And if the end plates are okay, then we can go ahead and still look for the nerve and just reinforce it with the macetric.
Intramacetric
Yeah,
nerve,
so use cable graft and use macetric as well as cross face. So macetric is the one that gives macetric or hypoglossal. These are the ones that give the power. But if you need reflex, like for blinking, we need the blinking reflex as well. And for smile also, we need it to be coordinated with the other facial, which is why we need to do a cross face as well. If the patient presents any later than that, then we'll need to put in some muscle. So generally gracilis or even latissimus dorsi. Those are the two options if the patient presents very late.
Okay, so at the for your first option should be interposition grafting.
Absolutely. If we are fairly sure that the nerve is gone, the earlier we do the reconstruction, the better it is, better the outcome.
Agreed. So do we have time for another case? Or okay, fine. Any questions or comments or anything different from the audience? No. Thank you. Thank you, everyone. I would like to call upon all the panelists for receiving mementos. May I call upon Dr. Yogesh? Certainly.
Good evening. Now we'll take a short recess for a tea break.
Oh, yellow.
Only the shadow.
Welcome back. We'll carry on with the fourth session now. I request Dr. Nupur Pruthi, Senior Consultant Neurosurgeon, NIMHANS, Dr. Nandakumar DN, HOD Neurochemistry, NIMHANS, and Dr. Manjula Das, Principal Investigator at MSMF, to please come and take the chairs on the stage and chair the next session. And I'll also like to remind the audience that in the next session, we will be having a quiz. So all those who are interested to take part in the quiz can give their names to Dr. Shantam sitting there. Please raise your hand, Shantam. Thank you.
Good evening, everyone. So let's start with the first talk of the session, molecular diagnostics in neuro-oncology, WHO and beyond, from our fellow chairperson, Dr. Manjula Das.
Hello. Good afternoon, everyone. So first, I would like to thank Dr. Komal Prasad and Dr. Kiran for giving this opportunity to address this audience. So this interdisciplinary audience, I would first want to introduce MSCTR or MSMF to you. So Majumdar Shah Medical Foundation is actually a translational research center situated in Narayana Health City. And the foundation, it has the departments, the research departments are as follows. So we have one section called MSCTR, which is Majumdar Shah Center for Translational Research, which again has multiple, couple of departments, starting with integrated head and neck oncology. Then we have neuro-oncology, we have molecular immunology and computational biology. Now, since it's a translational research center, so we not only we do the research, from that, the mandate is to take the whatever hypothesis or product ideas that come up, to take it to the clinic. So our work actually starts from the bedside, and we would like to deliver that to the patients to the bedside again. So that's why the hypothesis which is generated in the research center, that is taken to another research group, which is called a product research group. So, and if the product is a diagnostic product, then we take it to another closer to the market group, which is ADRC, which is Advanced Diagnostic Research Center. And if it is something, say a therapeutic, then we take it to another division of MSMF, which is the Technology Business Incubator. So, but Technology Business Incubator incubates multiple startup companies, different, it might not be only startup companies, different companies who need interaction with clinicians, who need the guidance by the clinicians. So if it is, as I mentioned, that the product ideas, product concepts are taken to the product research group. And if it's diagnostic, it is taken to the ADRC. If it is therapeutics, it can be the faculties of MSCTR, MSMF. They can either start a company, they can have startups, or they can collaborate with startups which are already there in the Technology Business Incubator and take the products to the market. Because as we understand that now translational research it cannot be confined only to the bench. it has to, as I mentioned, that it has to start from the clinicians, the problem, the clinical problem. It has to come from the clinicians, the first-hand problems we need to know from them, and we are very, very open if the clinicians themselves are involved in the research and initiate the research. And that we cannot take it to the clinic, we cannot take it back to the patients until we take it through the industry. That's the reason in MSMF, we are completing the entire pipeline of starting from bedside to taking it to the bedside through the industry. So today, I would represent Advanced Diagnostic Research Center to you, and I would present a little bit of the work that we have started in ADRC. ADRC is the division which actually started this year. So early this year, around January, we decided that we started this concept, and we started that the construction is still going on. We have started the work in a small way. And the mandate of ADRC is that we would make diagnostics, and not only we will make diagnostics, novel diagnostics, we would also do research in the area of diagnostics. So first, when we thought that we would start on this, so the diagnostics that we wanted to start on in Narayana Health City, as you all know, that Narayana Health City is one of the largest center for transplants, for different kinds of transplants, starting from heart and lung transplant to bone marrow transplant. It is one of the largest centers. So one of the major work of ADRC is to provide them with the transplant diagnostic. So we started with that, and then I actually wrote to a couple of clinicians in NH that this is what we are starting. Can we collaborate? Where do we start? The first response that I got was from Dr. Komal. Rather, I would say for a long time, that was the only response. So the next panel which we picked up was the adult brain tumor panel, because that's the time that actually just before that, 1 year before that, only the WHO guideline has come up that they need a lot of molecular tests. So we started discussing about that. And that's the second panel. That's the second panel that we are working on in ADRC. And of course, so as I mentioned, that we do research in the area of diagnostics. So the research would be to improve the efficiency or the efficacy of the available diagnostics, or to say sometimes to improve upon it. And we would also look at novel diagnostics, and novel diagnostics in the sense that if the markers are known, so we would probably look at a different method, and also we would work on the novel diagnostic markers. So already the audience has seen many times in the morning session, we have gone through the new WHO guideline, and from that we concentrated only on the adult brain tumor. And so these are the panels which you have actually seen that we started working. The first thing to pick up was the easy one, that 1P19Q. So immediately we got the fish and the fish probes and started doing the fish there, even at MSMF. Then third promoter mutation was the other one that we have picked up, and but that is, people do it by NGS or by fish. We are standardizing it to do it by ddPCR. Similarly, EGFR amplification also, we are going to do it by qPCR. Today, I would not be presenting our results on TOT or EGFR, but I would want to concentrate today on IDH, which we are not doing it by IHC. I would want to discuss the results that we are getting for IDH mutation by droplet digital PCR. So just to maybe refresh your memory on what is droplet digital PCR. So droplet digital PCR is an improvisation on what is known as qPCR, which is the, the real-time quantitative PCR, which is done by chemistry called TACPAN chemistry. So I would, like, as all of you, so far all of you went through a lot of, very details of the surgery. So I take this opportunity to refresh your memory, refresh your knowledge on little bit of molecular detail, molecular mechanistic detail. So as you might remember that, so TACPAN probes are, so these are nucleotide probes which have a fluorophore at one end and a quencher for the fluorophore on the other end. So these probes are made exactly to the, say, the region where you want to either detect the mutation or you want to find out that whether the mutation is not there. So you make the probe against the wild type. So, and the wild type probe and the probe against the mutation, these are labeled with two different fluorophores. Now, if the say the mutation is present there, then the probe will be binding to that region. And when you do the amplification, PCR amplification, the polymerase will come and it will replace the probe. It will, once it replaces the probe, then it would degrade also. When it replaces the probe and degrades the probe is, that becomes free of the quencher, that moves away from the quencher, and that is the time it fluoresces. So the machine, the PCR machine can read that. And if the mutation is not present, then the probe would not bind to the amplicon or to the template region. It wouldn't bind there. And so it would stay along with the quencher and it wouldn't fluoresce. The difference between the RT-PCR and the droplet digital PCR is that once this PCR in the droplet digital PCR, it is then the whole reaction mix is divided into multiple or distributed into multiple oil droplets. And so that means that it is not only in, say, only in one number that you are measuring the entire reaction. It is into multiple replicates, it is distributed, and each of these droplets are read separately by the machine. So at a time, you actually have multiple replicates of the same reaction. So you don't, so that's why like this number is in few 10,000s that you are going to measure. So you get the result that you get, the quantity that you measure. So that's why that's absolute. You don't need another, say, a housekeeping gene or something to compare it with. It compares it with itself. So this is the kind of readout that you see. The one, the green one here is for the mutation for the kind of fluorescence that we use, and the blue one is for the other kind of fluorophore which we use for wild type. The black one here is that when it doesn't bind to the probe, little bit of DNA which is not bound to the probe, those are, we see that as a black dot. Okay, so this is this is about the technique. Now, naturally, the most important one, as you have heard since morning, is that we wanted to measure this, or we wanted to measure the IDH, or wanted to detect the IDH mutations by droplet digital PCR. So as many times you have heard since morning that IDH, I just again wanted to tell you that what is IDH? IDH it's an enzyme, isositrate dehydrogenase, which plays a very important role in cellular metabolism, which catalyzes the oxidative decarboxylation of the isocitrate. And this is in the glycolysis pathway, and it produces alpha-ketoglutarate. This one, this enzyme, the IDH wild type component of, so this acts as a dimer. So it works as a dimer, means that two proteins, two copies of the proteins, they bind to each other and then they form the active protein, which acts as the enzyme. So this, the wild type component of the dimer that converts the isocitrate into alpha ketoglutarate, which is the final product of it, and the mutant part, when here specifically in IDH, when the mutation occurs at amino acid position 132, the arginine at the position 132, when that changes to other amino acids, which I'll come to that very soon. So that actually loses its activity, because again, I'll show you that what is called the active site of the enzyme, that changes its structure. So the substrate cannot bind to the active site, and hence it cannot act as the right wild type enzyme. So the mutant part of the dimer, so that when, as I mentioned, that it's a dimer. So two copies of the proteins have to come together to act as the enzyme. So if one copy is wild type and the other copy is a mutant, then also it acts as the enzyme, but it cannot produce alpha ketoglutarate. It leaves the substrate at a different position, and it makes this D2AG, which is called D2 hydroxyglutarate. So, and this happens in an NADPH dependent manner. So this forms a completely separate metabolite, which again, you might know the term oncometabolite, which is actually specifically only in the case of the mutants, you can see. Now, if both the copies are mutated, then this enzyme is completely inactive. So that's why this mutation, it brings in a structural change. Now, this is extremely important, because then when we discuss that how this actually affects the disease, we will come to know that why this mutation is essential to know in the case of glioma. So I just wanted to show you a few of, I would say that to remind you that the magic of those 4 nucleotides, that how that entirely changes. And so when we have to design, or when we have to make, say this kind of a DDPCR probes, whatever we have to design the probes, when we have to say that what is the amplicon. So we have to analyze a lot of this, the DNA sequence, and then we have to design that what's the primer, and then find out that which region is the right probe, and so on and so forth. So what we did in our repository in MSMF, we have around 247 samples which were actually checked by IHC. Some of them, 73 of them were not checked by IHC, but 69 of them were checked by IHC, and and the rest of them were checked by IHC. 69 of them were positive by IHC, 105 were negative. The 69 which were positive by IHC, when we checked by DDPCR, we checked 11 of them, and we saw that all 11 of them were again positive by DDPCR also. But the 105 which were negative by IHC, when we did the DDPCR, 24 of them we did DDPCR, and we saw 21 of them were wild type, but 3 of them, they showed that it has some other mutation. So one thing which I will tell you, that the IHC which we have is specifically for when arginine is converted to histidine. Only we have IHC only for that. But there are many other amino acids which the arginine can be converted to, though the frequency is very less. Now, out of that, we did actually 3 of them. We tried out for other mutations, and we saw that one of them is R132C. So now we are not trying to say that like DDPCR is much more sensitive. We still don't know. So what we are going to do is that we are going to do a sequence of this region, and that would probably finally give the verdict that whether DDPCR is more sensitive or IHC is more sensitive. So This is just to show you the ddPCR outputs that this one here, as I have already shown you earlier, that if it is 132H, if mutation is present, then we see a green blob here, whereas if it's only wild type, we don't see the green blob here. This is how the readout is. So another thing which we did is that, as I mentioned, that IHC is available only for 132H. We designed a probe for multiple other mutations, and when we started doing multiplexing with that, so we thought that but once we get the sample, we can, if we put all the other mutations also, mutation probes also along with the wild type, at the same time, if we have, say, a single one, we see a green blob, but if we start putting in the other probes, we actually see this as orange blobs. So we started multiplexing it with, say, 2 probes, 3 probes, and up to 5 probes. That means that showing all the mutations which are known, which the arginine gets converted to, we can still see this as an orange blob. One more small thing which we did was that, as you know, that the samples which are available from the patient samples which are available are very tiny in quantity. So it's not that, a little bit will go to pathology, and then we will get very little amount of DNA, or even from pathology, the blocks that we can get very little DNA. So we also titrated that how less DNA can we use, so that we don't have to take very tiny amount of patient sample can be used to do this ddPCR. So we went up to what is suggested for ddPCR is that you should be using 10 nanogram. But when we started titrating it down from the first titration itself was 5 nanogram. From that, we could go up to, we tried till 0.1 nanogram, but as you see that 0.5 nanogram also, you can see those tiny green dots, but I would say that up to 1 nanogram, we can detect it very effectively. So these two, at these 2 places, we have improvised it. So if we, at this point, if we just compare IHC and ddPCR, the advantages are of ddPCR above IHC is that IHC would take at least 24 to 48 hours. That after the dissection, when you get the samples to the pathology lab, you have to put that in paraffin blocks, then you have to make the slides, then you have to do the IHC. Minimum, like if you're working overnight, you can get it in 24 hours, but otherwise you'll get the results in 48 hours. Whereas if tiny amount of samples come to the lab, ddPCR, we can, within 6 to 8 hours, we can give you the results. And IHC, as again, I have mentioned that only R32H is available, whereas as I showed you that for all mutations at this positions, we can tell you together. Okay, we can tell you that at least it is mutated or not. And as you saw that the structure, so basically for the structural change, only the enzyme function changes. So you just need to know, probably at this moment, you need to know whether it is at that position, whether there's a mutation or not. So this is much more conclusive, ddPCR will be much more conclusive. If you know that it's wild type by that, then you know that no other mutation at 132 exists. The development time, the assay development time for IHC, it is much more, as you know, that it can take a few years. You can develop an antibody maybe in few months, but after that you can never ascertain its sensitivity, its specificity. Whereas in ddPCR, when you are working on a specific probe, within 2 to 3 months, if you have to develop a new mutation, or you have to develop a probe for a new mutation, you can do that in 2 to 3 months. But at the same time, so the other advantage of IHC is that already it's a gold standard. Acceptability of ddPCR will take some more time. We have to get back to Vani Madam many times, and then we have to show her many more results to convince her to accept this. Then IHC is a much easily accessible infrastructure. Every lab has it. ddPCR is an expensive equipment, not that every diagnostic lab will have it, and it's not yet that common. So that's why the infrastructure itself is not very available. The other scientific thing is that when you are doing it at IHC, you are seeing this at the protein level. And when you are doing ddPCR, you are seeing that at the DNA level. Now, that question always remains, that whatever you are seeing it at the DNA level, this is a somatic mutation, is all of it going to get expressed? Is it that, are you seeing that at the protein level? Because if it is not coming to the protein level, say if there is something else there, the transcription factor is different or something is different. So you are not, it is, if the mutated one is not expressed at all. If it is not expressed, then like the enzyme will still function. The wild type itself will still function. So that's another question which still remains. So with that, I just wanted to mention that, as I told you, that in ADRC, we are not only developing diagnostics or improving diagnostics, we are also, the mandate is to do research. So I just wanted to mention that in MSMF, the technical capabilities which we have, making, of course, molecular diagnostics, which I mentioned. We also do make antibodies, protein antibodies, which are monoclonal antibodies, polyclonal antibodies, and also we can make therapeutic antibodies, therapeutic proteins. The reason I'm mentioning this is that from this research, whatever product ideas will come up, we can take it to the final stage. We can take it to the clinic. So I will end my talk with a little bit of mentioning that what kind of research that we are doing. So maybe I'll do taking IDH itself as the case study. So for IDH, now IDH mutation, you don't see that only in brain tumor. You also see that in AML. But in the brain tumor, the wild type, the patients with wild type IDH, they maybe survive for 15 months. And with mutation, they survive maybe for 30 months. In AML, it is just the opposite. But at the same time, the mutations that you see in brain tumor is not exactly the same as you see in AML. I did not mention that this IDH enzyme, when it is expressed in mitochondria, it is known as the IDH2 enzyme. So the function is the same, the sequence is more or less the same, but the positions of the mutations that you see in brain and in AML are different. So that actually leaves us with the question. So the question is always there, that why do you see better prognosis with IDH mutation? One of the reason is that not the alpha-ketoglutarate, the other oncometabolite that that brings about a couple of mutations, which again a couple of methylations in different spots. And in the morning, you have heard that if these mutations are present, then in CDKN2A to 2B, that like methylation in that region, because there are 3 different genes in those regions, which are, if it is methylated, they get overexpressed. So due to the methylation, probably there is little more of, there is change of expression of those genes. The other hypothesis is that maybe these kind of mutations are seen by the immunity of the body or the immune system of the body as foreign. And is it that the tumors become hot? Do we have actually antibodies against these mutations? This is something we are also collecting a lot of AML patients, samples from AML patients here, bone marrow. So in the morning, Dr. Komal mentioned that this conference is multidisciplinary conference. We have so multidisciplinary in different senses. So it is not only that we have participants here only from the neuro-oncology divisions. We have here, we can bring in the knowledge from other cancers. So to understand IDH biology a little better, if we want to compare the IDH mutations in glioma, glioblastoma, and also in AML. We would want to see that whether we get, say, different kinds of more maybe IDH-specific, mutation-specific antibody in these two. So do we see, is there a possibility of getting neoantigen in this IDH mutation? So if we can find different neoantigens there, we can look for better T cell stimulation. So this can open up this research can open up a possibility of newer immunotherapy. So with that, I would want to thank our team in MSMF, especially I would say Kirtika and Gauri, who are also present here, who did this, whatever work which we have done, collecting the samples, doing the ddPCR assays, titrating everything. All of these things are done by these two young girls here. So I want to end my talk with Dr. Timappa Hegde's very positive note by saying a thank you and yes to whatever we suggest now. Thanks. Any questions? Okay, probably we can go to the next
Thank you,
speaker
Dr.
then.
Manjula Das, for the basics on molecular diagnostics. And,
Thank you, sir.
We next call upon Professor Siddharth Jejulala to deliver a talk on immunophenotyping of glioma patients.
Thank you. Thank you. Thank you, Dr. Komal and the other organizers for giving me this opportunity. This is a unique opportunity for me. I've usually given talks at universities, rarely in front of clinical audience. So it's a pleasure to be here, and I look forward to interacting with many of you. I don't need to give you a background of glioma and glioblastoma. Let me start with the background of myeloid immune cells and why we decided to look at them in gliomas. Myeloid immune cells have for a long time been shown to play a very important role in tumor microenvironments. And this is a recent review about 3-4 years ago, where they showed, this particular group showed that you could target these myeloid cells for treatment of various sorts of tumors. This is different from your immunosuppressive regimens that are there against T cells like CTLA4 or PD1, PD-L1 axis. This is a group of immune cells known as innate immune cells that can be targeted using many different approaches that are not yet in the clinic. When we started looking at the background of myeloid immune cells in glioblastoma, we didn't find much, but we did find a few other papers that talked about myeloid immune cells can act similar to other immune cells as pro-tumorigenic or anti-tumorigenic, and we want to convert the pro-tumorigenic to anti-tumorigenic responses. This is the background that was known about myeloid immune cells when we started the study about 5 years ago. So in 2017, we knew very little about myeloid immune cells in brain tumors and gliomas, but we knew about them in other tumors. And we also knew that standard immunotherapies that seem to work for melanoma and some other cancers did not work in gliomas. This is your anti-PD1, anti-CTLA4 immunotherapies. Why was this the case? What is happening? And so the questions we decided to ask was, is there an enrichment of suppressive myeloid immune cells? I've written only immune cells here, but myeloid immune cells in the tumor microenvironment in comparison to other tumor microenvironments where you have regulatory T cells and other T cell sort of upregulation. Further, we thought this would be a cool approach to actually ask if immune cells in the tumor microenvironment correlate with immune cells present in circulation. This has been shown as a good approach for many other tumor types, where if you know what sort of immune cells are present in circulation, you can use them as biomarkers, or potentially as a drug delivery scientist, as an engineer, use them to deliver therapeutics, so hitchhike basically a therapeutic on the immune cell itself. I'll come to both of those points towards the end of this talk. So when we started the study, this was the design. We wanted to do a pilot study. There was nothing that was done. In fact, even across the world, there was very little done about looking at myeloid immune cells in tumors, in brain tumors. So we said we'll do a pilot study. We do not have any preliminary data. So let's look at 20 to 30 individuals in the age group of 18 to 70, primarily focusing on grade 2 to grade 4 tumors. This was originally grade 2 to grade 4. Now there are some changes based on the WHO classification, but that general idea remains. And we wanted to also compare IDH mutations versus IDH wild type tumors. But what we ended up doing actually after 3 years before the pandemic began, which is when we stopped the study, was we were able to get only about 13 individuals recruited into the study. And this was primarily because we found that the tumor size for majority of the grade 2 tumors was too small for us to split into various groups. And I'll talk to you about that in the next slide. We basically couldn't get enough sample for us to do immunophenotyping. But now, after 3 years of experience, we know that we can actually look at very, very tiny tumors too. Further, we noticed that at least in this particular clinical cohort that was at your clinical center, MSMF and Narayana Health City, majority of the glioblastoma patients were wild type. They did not express the IDH mutation. And a majority of the grade 3 tumors were mutant, IDH mutant. They were not wild type, at least the ones that we got for our study. So then we decided that instead of looking at IDH mutant versus IDH wild type, we just do the comparison between glioblastoma that was mutant versus grade 3 that was glioblastoma that was wild type versus grade 3 that was mutant. And hence we stuck to about 13 individuals for this study. And this is sort of the general protocol that we followed. The tumors were resected by the surgeons, and just before the surgery itself, blood was drawn from these patients. The tumor itself was split into 3 random samples. One went to the pathologist at MSMF for grading and for IDH analysis. A small amount of it was saved for immunohistochemistry work in the laboratory of Dr. Namita Shah. By the way, this work was done primarily with Dr. Namita Shah. And a single cell suspension was prepared to be sent to IISc, which is where we are at, to do immune analysis. And the blood cells are also fixed, they're already a single cell suspension, and they were also sent for the immune analysis to IISc, where we do various sorts of assays, primarily meant to understand the phenotype of these immune cells. So we use antibodies to stain the surfaces, and then using advanced multicolor flow cytometry, which is what this bottom figure shows, this is a flow cytometer, we're able to actually analyze the type of immune cells we have in the tumor microenvironments and in circulation. And these are the sort of results we get from the flow cytometry analysis. Not to bore you with the details, but basically what I want to show you here is the top tumor here, sorry, the top flow cytometry plot is a way to indicate what are immune cells, CD45 cells, and what are live cells. So we can separate tumor cells from immune cells and do single cell analysis just in one setting. And then we're able to separate them based on the further markers. We have 18 such markers. So we're able to classify different immune cells. And then among those immune cells, look for activation markers versus suppressive markers. So CD15 is a very good marker for granulocytes. CD14 is a good marker for monocytes. And we were primarily interested in myeloid cells. So we're looking only at granulocytes and monocytes. Right? So what is the data that we got? This is the first set of data that we got, which is not even going into the various immune cell subpopulations, which is just a broad overview of the type of granulocytes and monocytes that we have in the tumor microenvironment. This, by the way, was not shown, as far as we know, not shown before we did this study. So in the brain tumors themselves, this result was correlated with other IHC results. About 25% of the total tumor cells, tumor mass, is made up of immune cells, CD45 being a representation of immune cells. which is a huge number of immune cells. As a comparison, in many lung tumors and pancreatic tumors, you don't get these many immune cells. But in melanoma and ovarian carcinoma, you get about the same, slightly higher numbers of immune cells. So immune cells are a correlate, kind of tell you whether you can use certain types of therapies or not. And so with 1/4 of the tumor mass being immune cells, it is possible then to target these immune cells for therapy. Among these, and this is now percentage of total cells on the y-axis. So 5% of total cells are actually neutrophils, which is about actually 1/4 of the immune cells themselves are neutrophils. This is a large number. This has been missed in almost all IHC-based studies and in RNA sequencing-based studies because neutrophils really don't produce too much RNA. All the other cells produce a large amount of RNA. So when you do RNA analysis, your neutrophils are just lost in the background noise. So here we're clearly showing that there are large numbers of neutrophils present in the tumor microenvironment, and this becomes important towards the end of the talk. We also see other granulocytes, some eosinophils and basophils, which is surprising. Usually you don't see them in tumor microenvironments. We do see two different types of monocytes. The non-traditional monocytes normally have been reported, this particular class, but the non-traditional monocytes have not been reported before. And so this is just a small scientifically interesting aspect. But there were no major differences between the monocytes and non-traditional monocytes. Nevertheless, as you look at this here, between the glioblastoma and the grade 3 tumors, there's no difference. That was one thing that we were really looking forward to. There's no difference. All brain tumors, at least grade 3 and higher, seem to have this type of profile of immune cells. Simultaneously, we looked at the circulation, and these patients, as all of you would know, are given steroid treatment usually before surgery, 2 to 3 days before surgery. This causes a drop in lymphocytes, and hence there's an increase in neutrophil percentages. Not numbers, but just percentages. So we did a side study to check if the neutrophils were very different because of the steroid treatment, and that was not the case. So these neutrophils are patent. They are the type of neutrophils that normally be present. They're just present in higher percentages. This is all compared to individuals that are healthy without any tumor. This is a small, again, academic exercise, but really didn't matter for the clinician itself, right? So now I'm just talking to you about these subclasses of immune cells, but I've not even gone into the phenotyping. What is the type of data you get from the phenotyping? And I'm going to show you a very, very busy slide, and I don't expect you to actually read through this slide. This is just to tell you, this is the sort of data we can get. These are the 17 different markers that we have among all the different immune cells after we've identified neutrophils, monocytes, granulocytes, and so on. And there's some variation between GBM and grade 3. So if you look at the graph here below, I've taken one marker, CD36, which is a monocyte macrophage heavy marker. Just as an example, I don't want you to read again. And there are differences based on in the blood versus there are no differences in the tumor. There's some differences in glioblastoma. There's some less differences in grade 3. So for each marker, we could do this, or for each tumor type, we could do this, or for each IDH mutation type, we could do this. Depending on what you want to ask, we can change our analysis and actually ask the right questions. But what does all of this tell us? There are two major outcomes of this particular story that may be of interest to you, that we thought was of interest to clinicians at least. There are higher numbers of suppressive monocytes and macrophages in the GBM patients compared to grade 3. This could also be looked at as in the IDH wild type versus IDH mutant. We don't have enough data to differentiate the two. But the basic idea here is 50% of your monocytes are expressing a marker known as CD163, which is known to be a M0 or M2 suppressive monocyte type marker, meaning these monocytes that are present in the tumor microenvironment are going to suppress many other cells. They're going to secrete cytokines that are actively going to suppress many other immune cells. They'll also have contact-mediated suppression. The grade 3 IDH mutant tumors did not have that many suppressive monocytes. And this was interesting because as we all know, glioblastoma patients tend to have very poor outcomes even after resections and other surgical treatments. This is mainly because even if a small number of immune cells that are suppressive survive, along with a small number of tumor cells, the tumors will grow no matter what. So removing these sort of suppressive immune cells could be very useful. More interestingly for us, what we showed was that these immune cells, that is the suppressive monocytes, were not present in circulation, right? There's no difference in the percentage of suppressive monocytes in circulation across tumor types and healthy controls. This brought us to an interesting outcome, which was always a chicken and egg problem in the immunology community. do the immunosuppressive monocytes become immunosuppressive in the tumor microenvironment, or do they come, they're already suppressive, they come to the tumor microenvironment and make the microenvironment immunosuppressive, right? So is the tumor microenvironment immunosuppressive, or is it the immune cells that make the tumor microenvironment immunosuppressive? And this study shows that majority of the monocytes that are coming in are not immunosuppressive to begin with, but once they get to the tumor microenvironment, they become more suppressive, suggesting that the tumor cells are producing some immunosuppressive agents. So finding that out and targeting those could potentially help us treat tumors better. Now we were able to show this using flow cytometry and using IHC. This was useful for us because it's at the protein level, at the RNA level, at cellular level, we're able to show at all levels that this is present. The second key finding that we found was that there's a correlation between circulating immune cells and tumor infiltrating immune cells. As I talked to you about before, in the CD163 case, there was no correlation. That is, the cells in circulation were not CD163 positive, but they were CD163 positive in the tumor microenvironment. So what are the markers that are correlating between the circulation and tumor microenvironment? For example, I've highlighted CD86 and CD63 here. These are actually statistically significant correlations, Pearson rank correlations here, suggesting that if you see a high CD86 expression among neutrophils and monocytes in circulation, that will also show up in the tumor microenvironment. Why is this important? If you look at so we did this sort of analysis, if you look at the cancer genome atlas, specifically at glioblastoma patients, and if you look at the Chinese glioma atlas, you will notice that individuals whose expression of CD86 is high in the tumor, either using RNA or immunohistochemistry, or the expression of CD63 is high, all red lines here, their progression is much poorer, right? So they're going to, their median survival time is very low. Comparatively, if it is lower, the same markers, then their progression is much better. But each time we cannot go and do this in the tumor microenvironment. For every patient, it's very difficult to do this in the tumor microenvironment. What we are suggesting is, because there's a correlation between these markers in the tumor microenvironment and in the blood, and no other cell usually expresses CD86 and CD63 apart from the monocyte, macrophage, and neutrophils, looking at the blood neutrophils and looking at the marker of CD86 and CD63 or the expression levels, we are able to then predict the progression-free survival, or not free survival, progression of that patient. This could be very useful for the clinician to try to decide the type of treatment strategy they want to employ, right? So with that, I know I don't want to take too much more of your time. I'll quickly end this talk with a quick with a summary. So what we observed was we were looking at grade 3 gliomas and grade 4 glioblastomas. Unfortunately for us, this is primarily a correlation between mutants versus wild types. We'd like to actually do the study across mutants and across wild types. But we observed that there's a higher number of CD163 expressing monocytes in the glioblastoma compared to grade 3 gliomas. And more importantly, in both of these, we see a high correlation of CD86 and CD63 among neutrophils in circulation and the tumor, which could potentially become a biomarker. A large part of the study was led by a talented PhD student in my laboratory, Jayashree, shown here. And all of it was done in collaboration with Dr. Namita Shah, who was at MSMF over the last 4 years. Quick round of acknowledgements for funding. This was funded by the Vijaya and Rajgopal Rao for Biomedical Engineering Research in IISc and the R.I. Mazumdar Young Investigator Fellowship that was awarded to me. This was also funded by MSCTR for the work that was done there. Thanks to Dr. Manjula Das for introducing us, having this sort of collaborative network established, and for helping us get the samples. There's a large number of people who are actually involved in the study. I'm not going to thank each one of them. I'm just listing them out here. Thanks to all of them, the study was possible. I'll leave you with this particular slide and we can take questions. What is the way forward? Well, we really need to do a larger cohort study to ensure that what the data we saw in this small cohort of 13 individuals holds true. Whether we could use these biomarkers in the blood as a potential way to understand progression, as well as whether there can be treatment strategies against CD163. Finally, in my lab, we're interested in using these myeloid immune cells to deliver therapeutics to tumors, and that will be something we try to pursue. Thank you very much. Happy to take questions.
Thanks, Dr. Siddharth, for a very nice talk. Any questions? If no questions, I have a couple of questions.
Yes.
Yeah, very nice talk on time, tumor immunomicroenvironment. Just I was wondering, which could you use exhaustion markers?
Yes, so we looked at 3 different immune exhaustion markers. None of them were really upregulated. The PD1, PDL1 axis. So we looked at PD1. We looked at exhaustion from a T cell perspective. That was also not upregulated, but we didn't really go in depth into the T cell markers here. So I wouldn't want to claim that they were not exhausted. We needed a different panel for that. With one marker, we were not able to confirm, but it didn't seem that it was highly expressed in this case.
Post this flow cytometry, could you culture these things effectively? How was it?
No, so we didn't try. Dr. Namita's group did try culturing. What happened in these cultures is majority of the granulocytes die very quickly. They don't survive for more than 24 hours. That's the normal lifespan of most granulocytes. So what ended up happening was you had tumor cells that would survive. Tumor infiltrating monocytes would survive. So the CD163 expressing monocytes were surviving, but all other cells were lost. So now, after about a 3 to 5 day of culture, you saw that the immune profile was shifting. Now, we don't know if this was because of culture conditions or because of actual tumor related changes. So that's very difficult to tell in culture. And we didn't pursue that further.
Last question before concluding our talk. What about the exhaustion markers compared to the periphery and times tumor-associated macrophages?
Yeah, we didn't look at that. We couldn't separate the periphery and the tumor-associated macrophages separately. This was just a chunk of tumor tissue that we got. And that's something that we hope to do in the future. We started doing it at IHC, where we're looking at periphery versus the central part of the tumor, but we didn't have enough tissue slices. So that's something that we want to actually go and look at again.
Demands one thing I can say, since you could not get IDH wild type, if you go for the secondary glioblastoma, you could get IDH mutant glioblastoma.
That's a good point. Yeah, we'll try that. We will try to establish a few other collaborations to continue this study. That's a good point. Maybe that will be a way to get those. Thank you.
Excellent talk by Dr.
Yeah. Thank you.
Excuse me, just one. Yeah, it's a very nice talk. I just want to know, you have checked the expression of CD163 and correlate with TCGA dataset.
Yes.
Yeah, so have you checked with this patient survival, this 13 patient you have taken and you got this CD163?
Yeah.
Have you checked their survival or correlation?
Yes, so CD163 expression correlates with a higher CD163
Means
expression.
whatever you are getting from TCGA, that is similar with your patient? Or?
So no, so that is a problem, right? We cannot check, we couldn't check with our own patients because the pandemic hit right when we stopped the study in March 2020. Many of our patients were still going through treatment at that point, and some of them were lost to follow up during that time frame. And using data from them, as in their survival, would really complicate our study because there can be non-tumor associated problems that affect survival. And so in a small cohort with 13 patients, even if 1 or 2 are affected by COVID or other COVID-related lockdown or other problems, and that's what affected their survival, our data really is getting skewed. So we decided not to do that. So we've not checked that for our own data, but in the TCGA data set, CD163 expression being high correlates with poorer progression.
Okay, thanks.
Thank you.
Dr. Srijan?
Good afternoon, everyone, and I thank all the organizers, particularly Dr. Komal, to give me an opportunity to speak to you about today.
Okay, so while the thing is being set up, so this is, I guess, this is the last offline talk for today, and after this will be the virtual session. And this is going to be a talk on AI, and that is artificial intelligence, and that has become like a buzzword. And I think probably all the medical conferences, there'll be at least one AI talk. So here it is. So we're going to talk about today an artificial intelligence enabled digital pathology platform, and we're just going to show you a few case studies and to show that this could be a kind of an emerging platform in neuro-oncology diagnostics. My name is Sujan, and I am part of or head the recently formed computational biology group in MSMF. Manjula has introduced MSMF in her talk, and I think you know all about that. So the computational biology group, the main idea is to work with data, various forms of data, molecular data, clinical data, as well as image data, and from there to find out patterns, find out hypotheses, and that could lead to further research and product ideas. So, of course, AI, as I told you, has become a buzzword in almost every medical field, and neuro-oncology is not an exception to it. So just last night, I did a quick search on PubMed repository, and with various terms related to AI, and then along with, terms like glioma or glioblastoma, things like that, and that shows this kind of a trend. And you can see there's an explosion of number of papers in the last 5 years, just really increasing. The last short bar is the current year, 2022, and that's only 5 months. But you can see, less than 5 months, it's probably half of the number of previous year. So it's definitely going to go up quite a lot. So this is, almost everyone is, publishing papers, and that way neuro-oncology is a little lesser. And if I insert neuro-oncology, if I check for breast cancer or prostate cancer, I'll, probably find tenfold number of papers. What are these studies talk about? What kind of data? So I did a small curation on, some of these studies, and what we find, and that is not surprising, is that more than 90% of the data in neuro-oncology, these AI papers, are essentially with radiology. So mostly MRI and a bit of CT, and of course, quite a lot of imaging data on PET scans. And these are trying to find out, and Dr. I think Shivkant in the morning has given us some glimpse about various features in MI, and these are most of the MI, the software in the MRI systems, and they have some of the basic, AI capabilities, and they throw out these kind of features. So we have most of the data which is there on AI platform for neuro-oncology is on radiomic or radiology, and a little bit on molecular data, that is either gene expression data or mutations or methylations. Very small percentage is on actual clinical data, non-molecular, non-image clinical data, and again, a very small percentage right now using the histopathology images. So that's a nascent area, but I think what working on it and looks like this is something, an area which is going to emerge, and we're going to see more and more papers coming in future where people are using histopathology images, simple. I'm not talking about IHC, I'm just talking about simple H&E stains, and from there trying to find out certain, clinical or molecular outcome. So before I get into that, just did the kind of set the platform, and this whole thing of AI started probably in the 80s when the personal computers were getting abundant, and initially it started with things like expert systems, and the first area where this kind of systems started coming up was in the area of cardiology. People are trying to put this kind of expert systems for analyzing ECG data. So just a cartoon representation. It's like saying that, if you have an expert system for detecting the different types of fruits, you hard code the rules. You say that, the apples are round and red and banana is long and yellow and so on like that. And that works fine, but this model has no learning capability. And then the moment you throw a green apple to this model and it gets completely confused, it doesn't know what to do. So then that's what led to, research on the learning models, which looks at the data and starts learning itself. Okay, so the basic, one of the most commonly used is what is called unsupervised learning, and there you just throw all the data to it, and you tell the computer, you tell the model, just you find out what are the features there, and you see whether you can find any differences in features, and you hope that it will be able to separate out the oranges, the apples, and the bananas. But the more common or more widely used kind of model in
medical field is what is called supervised learning. So there, what I do in supervised learning is that I throw a number of cases to the model where I say that, look, this is this category. So I give you a lot of apple pictures and saying that these are apples. Note down the features. So these are apples. So next time when I throw another image, so it will automatically, you will learn the features of an apple and it will say that this is the thing. So this is very quickly, this is how this kind of models work. I'm not going to take you through the details of the models. That's not really, we need to be bothered about. But just to tell you briefly that when you work with molecular data, when you work with clinical data, most of the data is numbers or maybe categories. So these are easy to kind of put them into equations. And I say that, okay, I have a machine learning model where I can, from these 356 clinical parameters or 20,000 gene expression parameters, I can find out, a reduced set. And we say that, this particular set of genes or these particular markers are sufficient to describe my clinical status. But that's not so for the images. Images, we don't have that. So images, there are other kind of models, and these are things called neural network models, where you try to kind of extract abstract features. So I can probably give you an example, a more technical example, but we had a very long day. So instead of a technical example, I thought I will just show you some paintings. So these are, the famous sunflower paintings. I mean, the left one is by Monet, who's one of the Impressionist painters. And the right one is from the great Vincent, arguably the best post-impressionist artist. So these are both sunflowers, and I can't really put any rules to say that this is Monet and this is Van Gogh. And there are many such examples. There are a lot of examples of Monet and Van Gogh. They have drawn similar kind of landscapes. But these are different. And if you have seen these paintings, you will know it's very easy for you. You never mistake a Monet with a Van Gogh, or you never mistake, say, a Van Gogh is a Monet. And this is because, but this is not because you have a rule. So this is because when you have seen the images, you have an abstract map, you have some abstracted features of these images in your brain, and that's what tells you. When you find, when you see a friend after 30 years and the appearance has changed a lot, most of the time you're able to recognize because there are some abstract features of that person you have in your mind, and that's why you're mapping to. So this is exactly how the models, work, just to tell you very in a kind of easy way. So we have certain things called filters, and we convolute the images. So images, when I look at it, images are made of pixels, and images, typically we are talking about color images. MRI is a black and white, but when you have histopathology, we have color images. So color images are 3 channels. We have red, green, and blue channels. So there are whatever, typically a histopathology image is, in terms of your computers, are typically something like 1900 by 1300 pixels. Whereas histopathology images probably will be about 80,000 by 80,000 pixels. And these pixels, and then you have 3 layers because 3 colors. So these many data points, and all these models they do, and then we have powerful computers. So this computation can be done very quickly. So all these models they do is that they put various filters on these images and convolute them and get some kind of abstract output. And these features are learned by the model, and that helps them to categorize and classify. So let's take a look at our sample workflow using H&E stains, using AI. So I have, let's say, 4 images. This is and these are, let's say, I have, always there is a ground truth. So ground truth is by the alternate method or the gold standard. You have done the categories. So I have 2 categories: category A or class A and class B, and I have thrown this to the computer. So what we do typically is that whatever initially data set that we have, we split it into 2 sets. We split it into a training set that I'm going to use as training, and I have a small percentage, maybe 20 or 30%. I keep it as validation. So I'm going to check the performance of my model. So then I just run it through this model, and every step, we call it epoch, and every epoch we check the performance of the thing on the validation. How good is it able to classify? And then we define, there are a lot of measures of, to say the performance, but most common or easy to understand measure is what is called accuracy. So if I have given 100 images of different categories, how many images it has classified correctly? Okay, so you just keep on doing this again and again. You keep on refining your model. You check the performance until you achieve. So what you want to achieve is, up to you. But typically, many of the cases we have seen the neural network models are able to achieve easily 90% or above classification accuracy to ground truth. So that's what we are looking at. So when you particularly work with H&E or histopathology images, they should know are hematoxylin and eosine stained images. So this is the typical color. There are two approaches people have taken, and the jury is yet to be out which approach is better approach. One is you work with the entire whole slide images. So you don't only look at, of course, you remove the background area where there is no tissue, and then you can put a cutoff. What is your cutoff? Like you say, my 90%, I want an area which should be at least 90% tissue and only 10% background I allow, or you could even more stringent or more relaxed one. But one is you look at the entire thing. You don't really mark out the tumor. So that's called a whole slide image approach. And there are some people say that the stromal area is equally important for many of the things, and so use that. The other approach is segmentation, or what is called the region of interest based approach, where you mark out, you curate. You can do manual curation, marking by the expert pathologist, or there are automated ways also of doing this. So you only curate out or mark out the tumor area and do the analysis on that. But both ways, both approaches, different cases work. So either way it works. But by doing all these things, what kind of classifications you try to do? These are broadly the three kinds of classifications which are kind of reported in literature. The first is the trivial one, and this is the most common, and you will see most of the computer scientists will tend to be the first one. Is just simple diagnosis of something like carcinoma versus benign from H&E. And this is anyway, why would I do that? Because this is any a pathologist can do. So that's not something which you're interested. The second approach or the second method is what is called, you are trying to make a digital pathologist. So this works for area where you don't have an expert pathologist. So many of the features of your H&E stain images, you can automatically kind of calculate if you want to see what is the necrotic percentage in your slide, and that can automatically give you that. So that's the second approach. But what we are more interested is the third method, where you are trying to correlate these features, the images, with various either clinical or molecular features. So this is where, this is really the power of AI, because this is where now you're looking at features which are not visible to the naked eye. This is not something which your pathologist can do. So you are aiding the pathologist by, making a model which can do this. So let me give you a couple of examples which are reported in literature. As I said, in neuro-oncology, this H&E based digital pathology is somewhat new. We just have started seeing papers. Most of the papers in neuro-oncology are dominated by MRI images or, recently PET images. But the few papers which we have, broadly, these two kind of things which are seen commonly. The first one is classification. So glioma classifications, where we spoke about all the different categories. Can we, from looking at, there are a lot of, the new CNS5 guidelines that talks about a lot of molecular subtypes. So looking at, by just the H&E slide, can we do the classification, train the model? Of course, we need to train the model with known classified images. And the second thing is prediction of molecular subtype. And, but no wonder that here IDH, remains to be the major molecular subtype. This is the first line in most of the cases. If you remember Dr. Vani's diagnostic algorithm in the morning, the IDH mutation status is the first line of, the diagnostic thing. But the problem is that, again, we discussed, and Manjula also discussed this in great detail, is that the IHC can detect only this canonical, mutation, which is the R132H, because the antibody which is used in IHC is only specific to that. So if you have a different mutations in even the R132 position, that it cannot detect. Or if you want an IDH2 mutation, it cannot detect that. So the question is whether we can detect all these things using H&E. So I'll just give you a couple of examples from the literature on these two, and just to tell you some bit of work which we just started doing very recently. So on the classification of glioma, this is a collection of some of the recent papers. All of these are published in 2021. These are different kind of models people did, and don't bother about the names of these models. These are just some standard model names which are used by the computer scientists. But the classification was the first paper tried to classify things like oligodendroglioma versus others. All tried to classify. You can see these are all old. We're still using Romans here because these are 2021 papers. But all try to categorize between the different grades of glioma. So the first one, you can see it was very successful. We had a accuracy of more than 80% when it could classify oligodendroglioma versus others. Similarly, there was another particular study where they had all the 6 categories: the astrocytoma, oligodendroglioma, anaplastic astrocytoma, anaplastic oligodendroglioma, glioblastoma, and of course the background glial cells. And all these things they tried, and they were able to get somewhere around almost 88% accuracy. So that was pretty good. And the last one, it again tried to do a lower grade glioma versus high grade, and again it got more than 90% kind of accuracy. So this is something which is quite encouraging. And again, the question comes whether we need to do this at all. But the point is that whenever we have a molecular test which is required, and if we do not have feasibility of molecular test, then the question is, can you use histopathology and doing these AI models as a surrogate for that? Okay, so I come to the other one, which is the IDH1 mutation. This is what we discussed about it again and again, and we know that for the standard one, the IHC can detect only the standard canonical 132H mutation, and Manjula described about her DDPCR test. But of course, if you want to do DDPCR test for many and many mutations, then you need to have multiple probes, which are all feasible, but it just adds to your development and number of probes. And of course, the final verdict comes from next-gen sequencing, and where you can NGS, you can send for sequencing, and that is not a biased experiment, that can tell you whatever the mutation it is. But any of you, if you have experience of sending data for NGS, you will know that these are only very small samples, and your service provider will say, unless you send me 20 samples or something like that, your turnaround time going to be this. You have to wait till in the queue. So this is where we thought of looking at IDH mutation by this AI, and we were encouraged by a couple of recent papers which all came out in 2020 and 21. These most of this worked on whole slide images, so they did not mark out the tumor area. And what they did was that they trained the models to detect IDH mutation from the H&E slides. And the first paper used both the kind of samples from the TCGA dataset as well as their internal samples, in-house samples. The second paper used only TCGA dataset. And some of them, the second paper also, all of them tried to add, other than the image features, they also tried to add. We know that there is a age dependency for this mutation, so they tried to add age, gender, or the ethnicity, these kind of things as the additional covariates. So these two bar graphs kind of describes the findings, and we see that at least the blue one, which is the first study, and that we could see around 90% of classification accuracy just simply using the H&E slide. Okay, and of course it had more number of patients, and not only TCGA patients, it also had patients internally. So this kind of prompted us to take up, as I said, the computational biology division started very recently. We just started with this project. This project is currently, we have started our own AI project for detecting prediction of IDH mutation from histopathology. This project has been funded very recently by ICMR. We are yet to receive the fund, but we are just started the work with the retrospective sample. This is currently being carried out with two, in collaboration with two pathologists, Dr. Akila from NH Pathology, she was here in the morning, and Dr. Megha from Pathology Department of NIMS, Hyderabad, and of course Dr. Manjula, she will be from the ADSC, and she is going to do the DDPCR. So the whole idea is that we are going to use both retrospective and prospective samples, and we are going to look at both IDH1 and 2 mutation status, and not only the canonical 132H mutations, but all the other non-canonical mutations as well, which will be verified by droplet digital PCR. And with that, we are trying to, hopefully, we will be coming up with a system
which can, do this classification at a reasonable. We did a very initial study with 40 retrospective samples, and we got somewhere around 70% classification accuracy. And then as we're going to add more and more samples, I'm sure the accuracy will go further. And then we can try to make it as a generalized method, irrespective of the specific mutation. We can try to see whether, this can act as a predictor for the IDH mutation. So going forward, I think what I tried to kind of present to you in this short session is that histopathology images, the importance of histopathology images in an AI platform. These images are generated. We don't have to spend anything extra. Most of the time, these images are generated as part of standard of care. And we have seen, and particularly, as I said, if you see breast cancer, you see a huge number of papers where they're trying to correlate the histopathology images, with things like Ki67 expression status and so on. And of course, images are much easier to handle compared to radiology. If you ask, finally, when you do all these studies, these computers where you do, there is something called a graphics processor, and graphics processors are still not as big as the CPU. So whereas most of our laptops which you have, you have 8 GB RAM, and whereas a reasonable server will always have these days about 512 GB RAM, it's quite difficult to get graphics processor with more than 12 GB to 20 GB RAM. So working with radiology sometimes become, because we have DICOMs, we have sets of images, different views. So compared to that, histopathology is much easier to kind of, and there is a homogeneity in it, so we can do it much more easily. Of course, I'm not saying that we are going to replace IHC. IHC is going to be there, but we won't have antibodies for all mutation variants. And doing sequencing always may not be feasible. So all we are trying to do is that the idea, and this is IDH mutation is just one example, and we are open to collaborations with other areas as well. But we try to do is that to build AI models where we try to build models where we can characterize, or where, with the characterized molecular subtypes, we try to see where their connection with the images, and whether from the images we can use as a surrogate to kind of say that there's a chance of this molecular subtype being there in this particular patient sample. So I will end here, and at the end I'll just invite all of you. I think some of you were there yesterday, but I invite all of you to visit MSMF, and we'll be happy to collaborate with you. So I'll be glad to take any questions. Thank you.
Thank you, sir. Is there any questions, please? Thank you.
Thank you, Dr. Sujan. That was a wonderful talk and eye-opener for us. From clinical perspective, one input what I'm compelled as I was thinking, was to let you know, dear teams, that there is no ground truth. So that's something which is there in the back of your mind, I understand. But we need to please, and we need to be that canonical, that word is there. No? So just at least in your thought experiments initially, just assume partly that there's no ground truth. The only ground truth is the actual number of days the patient survived. So we'll have to keep that only one reality, and then check, because these are all surrogate, these are all markers, these are correlations. So we may miss track in case if we hold on to that ground truth. So that's something which I wanted to. I hope you got the point.
Yeah, sure. That's a very important input, sir. And then definitely, but we have an approximate ground truth, and when we train the model, we go with that, and then we refine. And this is something which was happening in our case also, because we started with IHC as the ground truth, and then the experiment show that not some cases we have IHC negative, but it's showing positive. So then we define our ground truth.
So that's right. From when we see from previous edition and the new edition, that's what we are seeing. There are gross changes and too much of a change. And I remember those earlier studies. Now no pathologists are around, I should be talking, but the discrepancy is up to 33% using only histopathology slides. That was maybe some 10-15 years ago. Particularly the varieties of grade 2 and grade 3. So low grade and high grade, definitely not so much, but the intermediate grades, it's discrepancy between pathologists itself is up to 33% or even higher. So I would suggest Dr. Anand to add.
Very interesting talk, I should say. Again, some thoughts which came up. You took H&D stain as the basic. Probably that's the most common available and uniform and it's standardized. But for machine recognition, could that be something else which you can look at? Maybe a different form of stain or different form of recognition, which may make it easier for the machine to recognize differences. H&D is for the naked eye. The machine
Yes,
will
sir. So there
definitely
is
pick up something,
yes,
yeah.
yes.
And other data like spectrometry or Raman's spectroscopy, they can be too incorporated. Then probably
Yes, sir,
go
that's
even
absolutely,
more,
that's, so the first question is that this convolutional thing, and typically if you look at an image, we generate something like few millions of features, but these are not explainable. If you ask me what are these features, and these are not explainable. But there's another approach, and I have seen, not in neuro-oncology, but I have seen papers even in India from some of the people in head and neck oncology in some of the centers in Guwahati. And what they do is that instead of these kind of abstract features, you create much lesser number of features, but these are explainable features like ellipticity of, curvature or, correlation and things like that. So this is another approach, but the number of features are much lesser. So even for an MRI supposed to be, instead of doing this neural network, there are the standard radiomics features. And for a 3D image, we have somewhere close to about 120 to 130 features. These are explainable features. But what people have seen that with this, because things are so complex with these only 100 features, it was very difficult to explain. So that's why mostly people are moving towards going toward this neural network computing, where I cannot explain what are the features, but they actually work much better they take much more computation time, but finally it works much better. So that's one thing. And second point which you said about adding data, that's a point. And if you have additional data, we have seen papers where they have, again, not specifically for neuro-oncology, but this is a case where they were actually taking the H&E features plus there was, the lymphocytes, the infiltrating lymphocytes where CD3 kind of stains were done to check by IHC, and they took the IHC features and all these things together, and that improved the kind of accuracy. So that's very true, sir.
So thank you. Excellent inputs by researchers and clinicians here. We go on to our next talk. Upon Dr. Nandakumar for his talk, Molecular Signaling Pathways and Glioblastoma Microenvironment. Dr. Nandakumar.
Good evening, all. First of all, thank Dr. Komal for inviting. Today, I'll be discussing the molecular signaling pathways and glioblastoma environment for this clinical gathering. I think no introduction required about glioblastoma. Even the most common central nervous system tumor is glioma, and a major chunk is taken by glioblastoma. And yeah, major treatment is neurosurgical debulking, radiotherapy, chemotherapy, which finally invariably the patient's glioblastoma recur. Our lab actually working on two different aspects. One is drug discovery, which we recently discovered a novel compound, which is having anti-migratory and anti-invasive effect in glioblastoma, which we recently published. But today's talk, I will be talking more about the tumor microenvironment, because the theme is to understand the glioblastoma more from a molecular perspective, as well as molecular diagnostics, the role played in aiding or helping the clinicians to manage the patients better. One of the most significant factor playing playing role in management of the difficulty in the management of patient is the invasive nature of glioblastoma, because the tumor is ill-defined, and even in a neurological debulking, the edges cannot be completely resected. And as you know, hallmarks of glioblastoma, as defined by the Hana and Weinberg, there are many factors, and of late they came out with one of the important factors, that is tumors. Glioblastoma, including glioblastoma, creates their own tumor microenvironment. And now in this tumor microenvironment, there is another further development in tumor immunomicroenvironment, what Dr. Siddhartha also spoke recently, just now. And now tumor microenvironment, they have many factors which invariably not only creates an environment in such a way that it helps in their protection, also the surrounding area, they ensure that they don't have, they don't allow the factors to inhibit them. And finally, it leads to the growth of the tumor as well as suppressive tumor microenvironment. And also it plays a major role in the growth of the some growth factors which play a role in their overall survival. Coming to the hallmarks of the glioblastoma, in our lab we are working on proliferation of glioblastoma, invasion, then glutamate, role of glutamate in the development of glioblastoma. Here, as you know, glutamate is the predominant neurotransmitter, talking from a biochemical point of view. This plays a crucial role and critical role in the growth of glioblastoma, but the exact mechanisms are not clearly known. What happens is, usually, normally in the normal brain tissues, glutamate is present at the concentration of less than 3 micromolar. But in glioblastoma, it reaches up to the level of 500 micromolar, where it plays the role of destructing the surrounding normal brain tissues. But is it only the destruction of normal tissue, or does it play any additional role? That is what the questions we asked. So I'll not go to the details of these graphs. Even though it was known that it destroys surrounding tissue, our lab started asking questions about the role of this this glutamate in the growth of glioblastoma. For this, we used 2 different models, cell lines as well as patient-derived primary brain tumors obtained from the our Niemann SOT, where first we try to establish whether glutamate mediates its actions through 4 different receptors. One is NMDA receptor, AMPA receptor, other AMPA, kinase, and metabolite glutamate receptors. We are working on all these 4 receptors, but I will focus my discussion to the NMDA receptors only. NMDA receptor, first we established that in cell lines as well as using in patient-derived primary cultures, that they have they play a role in invasion. This was established using a in vitro invasion model, where by using NMDA, NMDA, we could show that tumors, the NMDA plays a role in the activation of invasion, as well as in the presence of the inhibitors, the effect was reversed. This indicates that NMDA plays a critical role, which is one of the key receptor of the glutamate. Later, we showed the role of NMDA in the migration also, because migration is one of the important factors before the invasion happens. Also, we try to understand what is this on activation of NMDA receptor, does it have on its effect on the subtype of the receptors, where we could show that even though there are 4 different, several NMDA receptors, especially glutamate N2B was upregulated, and it's a crosstalk on the glutamate AMPA receptors. It was very much on the GLU-A1. And this paper was published on the novel perspective of the NMDA receptors in Physiology International. And to summarize at this stage, that we could establish that NMDA receptors play a role in the growth of glioblastoma through migration and invasion. Later, we looked into the proliferation also, which we could show that by MTTSA that NMD receptor on activation of NMD receptors, it was upregulated, but it was as usual inhibited by using its inhibitor MK01. And this proliferation, migration, or invasion, one of the important factors playing role in MMPs. We looked into the and among MMPs, there are several, and the key MMPs are MMP2 and MMP9, and of which MMP2 plays a role in the invasive end, and MMP9 is established to play a role in the angiogenetic area. And sorry for the part of this one, is a technical this one, where we could show by gelatin thermography that MMP2 is upregulated, as well as in the by RT-PCR we could show that the expression of MMP2 is upregulated. And now, moving on to the next question, we asked whether in these cancer cells, as you know, they are highly metabolic, and whether there will be high oxidative stress, but how these cancer cells could survive in this high redox status, as well as overcome the oxidative stress. And again, primary question was whether NMDA receptors play a role. Through several experiments, we could show that intracellular as well as extracellular redox plays a role in the how the NMDA receptors regulate this intracellular and extracellular redox to helps in the survival of that. We could show that in different cell lines that NMDA receptor, when presence of NMDA receptors, the oxidative stress was coming down. And by using hydrogen peroxide, we could show that even from exogenous source of oxidative stress could be overcome by presence on activation of glutamate receptor, on activation of NMDA receptors. And several antioxidants we measured, and including GSH, then glutathione peroxidase and GR, and it was upregulated on activation of NMD receptors. This way, the significance of these NMD receptors is that how cancer cells secrete glutamate, and through its receptors helps in the management both in all these activities, overcoming the proliferation and means playing role in proliferation, migration, invasion, and overcoming the antioxidant redox status in the glioblastoma cells. And I'll try to skip these few slides. And this data was published in Cell Biology International. And to conclude at this stage, that how NMD receptors through different mechanisms helps in the survival of glioblastoma and overall growth of it. And now moving on to the cellular tumor microenvironment. See, now, in just a few months back, Lewis et al. Have come out with a classification of central nervous system, where they have identified the molecular, how significant the molecular markers or diagnostic factors, markers play a role in the classification. And one of them is how in 2016 they came out with the IDH classification, and of late in 2021 they came out with a MAP kinase pathway. And since we have found that cytokines are upregulated in glioblastoma, we started looking into whether this MAP kinase pathway is affected or regulated in glioblastoma. And we asked questions of a couple of cytokines, that is TNF alpha and interleukin, how it plays role. Since TNF alpha plays role in one of the top of the hierarchy, it works functions and regulating the other cytokines, we looked into the role of TNF alpha in glioblastoma and their signaling pathway. As I told you, the invasion assay, we did in vitro metrogen invasion assay, and we could see that the TNF alpha upregulated invasion assay, even in not only cell lines, even in the patient tumor derived tissues. And finally, we'll try to address what is the mechanism, the signaling pathway. And since, as I told you, MAP kinase pathway is one of the significant pathway which plays a role in the many tumor tissues. I'll skip a couple of these slides. Yeah, and also these activation of these extracellular and intracellular stimuli is regulated by the MAP kinase pathway, including cytokines. Our intention was to address the dysregulation of this MAP kinase pathway. And also, as you know, the MAP kinase pathway plays role in most of the factors of these cancer cells, with their proliferation, differentiation, and motility, and how they respond to the stress response, survival, and overall and the death of the cancer cells. And this MAP kinase pathway mediates to action through the ERK and NOS signaling, and we looked into the by using the ERK signaling factors. We looked into the how this on activation of NMDA receptors, how in activation of TNF receptors, whether the ERK signaling is affected. First of all, we used two different ERK inhibitors, that is U0126 and PD98059, and on activation of TNF-alpha, we could see that invasion was significantly upregulated, but by using U0126 as well as PD90, two different ERK inhibitors, we could find that the invasion was inhibited, which were in presence of the TNF-alpha. Also, not only at the invasion level, we looked into the by using Western blot at the protein level, we could find that on activation of TNF-alpha, the ERK2 and phospho-ERK1 and 2 were upregulated, and by using their inhibitors, the effects was reversed, which indicates that TNF-alpha mediates its action through ERK signaling and phosphorylation of them. Not only that, for the cells to move, the adhesion plays a major role. And this ERK signaling, finally, which comes to the pathway of the MAP, we could see that in presence of the ERK inhibitors, the mobility was higher. That is because of the increase in the adhesion. And same effectors are found in the interleukin beta, interleukin beta activation also. And to conclude, we also looked into the other than ERK signaling pathway, few other signaling molecules, especially NF-kappa B and STAT signaling pathway, because these are the signaling molecules which come in play role in the as a natural hub of the growth of the cancer, and which were upregulated in presence of TNF-alpha. Now we are in the process of understanding how this network is interacting with each other and also plays in the molecular marker. With this, I'll try to conclude saying that overall, this TNF-alpha mediates its action through invasion through ERK signaling, which is one of the major pathway of MAP kinase. I'd like to take this opportunity to thank the work carried out by PhD students and also my collaborators, and especially the research grant from NIMANS as well as SERB and DBT. Thank you for your patience hearing. I'd like to take any questions if you have.
Any questions? If not, may I ask a few questions, please? Just wanted to know that, do you have any in vivo studies to back this up?
Yeah, we have used all these experiments were used even the patient-derived tumor tissue samples.
So those are
but these are ex vivo. In vivo, we cannot contain now. The next line of action is introducing these tumor tissue models in the animal samples and look into the pathway, including the immune signaling pathway. In vivo means definitely not in the patient. Only the animal model is the possible way we can go ahead.
And even in your ex vivo model, do you have, did you do RNA sequencing or any kind of omic assays?
No. Those things, we are looking into only the signaling pathways, not in the omics alone.
Thank you. So maybe we can just... Yeah, I think that after this, we have these two virtual sessions. Yeah, that's Dr. Ravi Savdeshmukh. We have to start.
The next talk will be by Professor Ravi Savdeshmukh. from Center for Translational Research in our center on multi-omic analysis and clinical insights in glioblastoma. This is a recorded talk. It will be played now. Professor Sardeshmukh is in US at present. I don't know, it may be an odd hour for him, but he's gracious enough. He's there to take any questions from the audience. So first we'll broadcast the recorded video.
Good evening, all of you, and thank you very much, Dr. Komal Prasad and his team for organizing this meeting, this interdisciplinary meeting, and also for calling me to share our experience in the use of multi-omic approaches to study and understand the CNS tumors, particularly glioblastoma and low-grade granomas, and we are also going to start some work on digital tumors. The use of omics approach to study gliomas dates back to early years of this century, when the first publication on the proteomics of human gliomas came up, which was also perhaps one of the few publications from anywhere in the world. Dr. Vadi Santosh, who is a pioneer in CNS tumor and present today in this session, was also part of that study. The scenario had changed since then, and the omics space now expands from genomics to transcriptomics to proteomics, and in recent years even to metabolomics. And the new technologies and the technology improvements permit us to generate information, molecular profiles, information about thousands of molecules, and generate large experimental data sets which are used using bioinformatic approaches for biological interpretations as we go from molecules to cells, to tissues and organs. We have been using these approaches for the study of gliomas and glioblastoma. We use the multi-omics data and try to see if we can use any of that for addressing some of the clinical goals. How we generate this data? We use clinical specimens, cell lines, sometimes tumor-derived cell lines, and also 3D cell culture models. And now we are also planning to use spheroids and organoid cultures. Generate in-house experimental data. We also look into the public domain data and the information that is available, and all this integrated multi-omics information in the context of microRNAs, mRNAs, and proteins. We take it to explore for application to clinical questions which may be related to prognosis or post-treatment surveillance, sometimes to develop some mechanistic and exploratory work, and also look for therapeutic possibilities. And if we get some useful leads, we can even try to develop some of the products or assays using this information. I'm going to take two examples from our work to sort of illustrate how we use this approach in our studies. One is the interaction of one of the receptor molecules, GPCR56, and its interactor transglutaminase 2, TG2, and how this interaction and the expression of these molecules, it has effects which are relevant to tumor development. I will also talk to you about some of the approaches that are emerging and also we are using to identify protein variants and novel protein expressions which may specifically occur in the tumors. GPCR56 is GPCRs, in fact, GPCRs in general are a large family of substrate receptors, and they are known to be drug targets in many diseases. 56 is a member involved in cell adhesion function, and we found from our earlier work that it exhibits alternate expression in GBM and low-grade glioma. TG2, on the other hand, is a multifunctional protein. It's a very interesting protein, present both intracellularly and extracellularly, and extracellular TG2 is also contributed by not only by the tumor cells, but also by the endothelial cells in the tumor microenvironment. TG2 functions as a scaffolding protein to bring together ECM proteins and the cell surface integrins which are involved in cell migratory behavior. Recently, TG2 has also been found to be a ligand of GPR56, particularly in cancer, although GPR56 is known to be involved in some other neurological disorders. We have published this work recently in Frontiers in Oncology, and without getting into the technical details, I will try to tell you some of the major aspects of this work and the information that we get from it and how we think we may be able to use it. We have studied expression of these two proteins in multiple tumor samples. We have, using public domain data, we have also looked at their spatial expression intratumorally. We also mapped it to single cell expression data, and by modulating expression of GPR56 in GBM cell lines, actually we knock down GPR56, we look for the effects, molecular effects of this particular modulation by doing multi-omics analysis, RNA, protein, phosphoprotein, and so on. Some of the main observations are that the expression of GPR56 is heterogeneous, both among the tumors as well as within the tumor. And within the tumor, it is low in mesenchymal types of cells compared to other cells. TG2 expression, interestingly, is reciprocal to GPR56. Wherever GPR56 is either higher or lower expressed, TG2 shows exactly opposite trend. The molecular profile that we get, multi-omic molecular profile from the modulated cells, shows that there is enrichment of mesenchymal profile, molecular profile on silencing GPR56, and that includes even release of some of the cytokines. On the cell behavior, we find that silencing of GPR56 leads to increased cell invasion and migration, and it also contributes to macrophage infiltration in co-cultural conditions. All this is perhaps related to the hypoxic niche and the areas of the tumor which are more hypoxic in nature, and also the mesenchymal status of the tumor. We have put forth a model to explain how all these events may be interlinked and how they really contribute to mesenchymal phenotype. Now, what information do we get from this as far as the clinical application is concerned? One is, there is a possibility that some of these molecules can be viewed as therapeutic targets, and we have not yet gone deep into this. But one thing is very clear, that the molecular profile that you get, particularly when we combine it with the public domain information about MES signatures, the spatial MES signatures, plus signatures which are corresponding to the EMT in general, we are getting what we can call as the molecular profile which can be aligned to mesenchymal status of the cells. And we have something like 140 molecules which show up in this. One can extract molecules which are secretory in nature from this particular set of molecules, as well as using bioinformatic approaches, you can connect them to microRNA regulators and also identify some of the microRNA regulators which may be signaling. Both secretory proteins as well as microRNA regulators are potentially present and can be detected in the circulation, and they can be pursued as circulatory biomarkers to address some of the clinical questions. Now, what is the kind of clinical question that one can really think of? GBM has we all know that GBM exhibits, low survival. The median survival of GBM patients is low, but even then we have a lot of variance. Some patients survive for 2 or 3 months, but then some can really, carry on for longer time, like 15 to 20 months. So there is variation. So because of these variations, perhaps post-treatment surveillance is important to really to see how the patient status is. At present, it is MRI scan and the image features as well as clinical evaluation is used for this purpose. But there are possibilities where one can think about alternative methods. We all know that when GBM recurs, it recurs invariably as MES, as mesenchymal subtype, which is resistant to treatment. And we know from our GPR56 and TG2 interaction studies, we know that we are also getting some information about mesenchymal transition that can occur in these cells, and then we are getting molecular signatures which are perhaps representative of the mesenchymal subtype, and the secretory members of this molecular signature can really be used for developing some post-treatment surveillance methods. And while we are doing this, if we find some correlation between MRI features and these molecular signatures, I think we are heading for developing alternative method for the purpose of post-treatment surveillance. I will also now tell you something about the splice variants and the other kinds of variants of known proteins, as well as novel expressions that may be specific for tumors. Generally, when we look at molecular profiles, we all confine ourselves to 5,000 or 6,000 very well-known, well-studied proteins. We map them for pathways and networks and identify targets and security molecules and things like that. But it's now believed that there are many uncharacterized and unknown proteins. And that is also reflected in one of the recent papers in the journal Nature, that these uncharacterized or unstudied proteins offer a lot of opportunities for doing some functional proteomics in the context of tumors. Presently, we know that there are about 20,000 genes, human genome, and about 18,000 proteins arising out of the genes are known for their existence and function. But there are still several thousand proteins which do not have evidence for physical existence or physical evidence for their existence, and many of them, about 1,500 or so, still do not have characterized. They are not characterized for any function. So there is a lot of gray area here. In addition to that, there are already more than 40,000 entries for splice variants and other kinds of variant proteins in the databases. And then also there is emerging information about proteins which are coming from either to considered to be non-coding sequences of the human genome, and here the number again goes to anywhere from 3,000 to 4,000. So there is a lot of unexplored proteome and functional proteome, potentially functional proteome of the cells. And there are now methods emerging. We also use these methods, and in either either as used by others, or also incorporating some modification using deep RNA and deep RNA-seq data as well as deep proteomics data. We look for identification of known proteins, as well as from the remaining data, we also look for identification of splice variants. The actual the pipeline that is used for this is very complex, involving multiple steps, and I will not go into the details. We have published recently some work on this in the context of breast cancer, and now we are analyzing the data for in-house generated data for GBM, and the analysis are underway. And both these studies, they give us information that there are thousands of peptides that are expressed in these tumors, and the peptides that map to the known genes, they actually correspond to some of the oncogenes, kinases, receptor molecules, and other hallmark proteins. And some of these novel peptides are also associated with patient survival. Some of them may be present on the cell surface and can be considered as neoantigens for immunotherapy. Thus, overall, if you take it, omics approaches, there are many potential uses, and with the large data that we can generate, it can be used on one side for stratification of patients. On the we can use it for developing prognostic biomarkers or therapeutic targets. We can use it for understanding intratumoral heterogeneity by using single cell expression data, as well as we can use now methods for identifying novel proteins and novel peptides, including neoantigens. AI and ML approaches are emerging for analysis of histological and radiological images and identifying microanatomic regions or physiological features that may show up in the images. And if one can succeed in integrating molecular information with this kind of image data, one can hope for getting a better 3D view of the tumor, which will be useful for better management. I will stop here by drawing your attention to one of the interesting papers that has been published in recent years, which talks about all hidden things and the clinical and the translational aspects of omics technology. And it appears that there is a lot more to explore in the future and use it for developing what we can call as precision medicine of the future. I stop by thanking all my colleagues which have been associated over the years in all these different studies and the funding agencies, ICMR and DBT. Thank you very much for your attention.
Is there any question for him? Dr. Ravisar Deshmukh is available online. Yeah. If there are no questions, then we can thank him and finish the session. Thanks.
Thank you, sir. Thank you for a wonderful talk. In a brief period, you have summarized the extensive work what has been done in the omics field. Thank you very much. Yeah.
Sure. Thank you.
Thank you for joining from that far, sir. I don't know what time it is there. What time is it there, sir?
Well, it's now it is 9 o'clock, 9:30.
Okay.
But I usually
start
my day. Okay. I usually start my day at 6 in the morning for many of the.
It's midday for you. Okay.
Yeah. Thank you.
Nice interacting. Thank you. So the next talk we can announce.
There'll be a break now.
No, Dr. Namita's talk will be there. After the talk.
Okay, we'll have one more online
Dr.
session.
Namita's talk. We'll finish this session. You can.
Sure.
You can announce that one. So
Okay, so now the.
Thank you, sir.
There'll be a talk by Dr. Namita Shah, map of tumor microenvironment interplay in glioblastoma. This is also recorded.
Hello everyone, I'm Namita Shah, currently a visiting scientist at Samsung Medical Center. Today I will talk about the project. Hello everyone, I'm Namita Shah, currently a visiting scientist at Samsung Medical Center. Today I will talk about the project I've been working on at Samsung Genome Institute and Seoul National University Hospital in Seoul, South Korea. As we all know, glioblastoma is one of the most heterogeneous cancer with a very complex microenvironment. When we talk about the microenvironment, we mean the cellular components which include immune and stromal cells besides the tumor cells. The biomechanical component, which is properties like stiffness and porosity, and also the biochemical component like the lipids and metabolites. Now, why do we need to study the cancer microenvironment? In order to develop effective therapeutics, we need to understand how different cells interact and result in treatment resistance. Traditional 2D cell culture models for drug development has a very low success rate in general, but even lower when it comes to glioblastoma. There's a lot of work ongoing in the field of developing newer models that are 3D and dynamic in nature and more biomimetic. In order to precisely engineer these models, it is important to study the inpatient tumor in detail to understand cell-to-cell interactions. To shed more light on this aspect, we have used single cell and spatial transcriptome data from glioblastoma samples. I'll briefly describe how single cell data is generated. You take a piece of tissue and through mechanical and enzymatic process, prepare a single cell solution. This solution goes through microfluidic device which captures one cell at a time, that is then barcoded and sequenced. Now, single cell data is resulted in many insights, but it has the limitation that the spatial context is lost. Also, the process of single cell dissociation results in loss of certain cell types like neurons and vascular cells. Spatial transcriptome data, on the other hand, works by putting a tissue sections on a slide, and then areas of the slides are captured, barcoded, and sequenced. The barcodes can then be used to overlay the gene expression data back in spatial context. Spatial data has the benefit of maintaining context, but the current resolution, which is from 55 to 200 micron, can have as many as 100 cells in one spot. Now, if we can combine the two modalities, we can get information about which cell types co-localize and their histological context. Now, before I talk about the current project, a brief introduction to my previous work on studying glioblastoma microenvironment. This work was done in Seattle, a collaboration between Swedish Neuroscience Institute and Allen Institute for Brain Sciences, and was funded by that foundation. We used key anatomic features of glioblastoma for this study. So, leading edge or LE is defined as the relatively normal portion of the brain without visible tumor cells. IT infiltrating tumor, where we have a mixture of tumor and normal cells. Cellular tumor, which is mostly just tumor cells. NE, which is necrosis. PAN is pseudopalisading cells around necrosis. These are the cells which cluster around necrosis and form pseudopalisades. MVB, which is microvascular proliferation. HBV is hyperplastic blood vessels. Again, these are features of glioblastoma. And the perinecrotic zone, which is area around the necrosis without any visible pseudopalisades. For this project, we had used laser capture microdissection to capture each of the anatomic features and then did gene expression analysis to identify markers for each anatomic feature. This atlas has been extensively used by researchers to understand GBM microenvironment. We build upon this with newer single cell and spatial transcriptome technologies. So for this study, we recruited patients at Seoul National University Hospital. Samples from 17 patients undergoing craniotomies were used, out of which 13 were glioblastoma patients, 3 patients had IDH mutant grade 3 or 4 glioma, and 1 patient had a neurosarcoma. Out of the 17 patients, we have matching single cell data for 14 patients. These GBM patients cover the common genetic features like EGFR amplification, PDGFR amplification, CDKN2A2B deletion, NF1 mutations, P10, P53 TERT, and ATREX mutations. For GBM patients, we prepared samples from the core as well as the periphery of the tumor. This was determined using during surgery using the 5-ALA fluorescence. Now, these are the H&E images for the 31 sections that were used. The first one is the control sample. The next 3 are from IDH mutant cases. The first being grade 3 and the next one being grade 4. And the rest of the sections are from GBM patients. These are FFP sections, and then we also have 5 sections which are from frozen blobs. These were done before it was possible to do spatial transcriptome on the FFPE samples. Now we determined the anatomic features on the slides using gene expressions signatures from the IVCAP study. So based on that, you can see that green is the leading edge, which is gray matter. Golden color is the leading edge, but white matter. Blue is hypoxic regions, which is pseudoparasitic cells around the process and perinephrotic zone. We also have pink colors, which are represent hypoxic areas, which represent vascular areas, and you can see microvascular proliferation in this dark magenta, and then you have cellular tumor as cyan color. In total, we have 122,000 spots covering different anatomic features, and we have good coverage of all the features as you can see here. The clustering result on the right shows how certain clusters are a mix of all patients, like the LE and MVP, whereas certain clusters are very patient-specific, like CT. Next, we wanted to do the cell type deconvolution. That is, identify which different cell types are present in a given spatial spot. Now, in order to do that, we built a comprehensive single cell reference database using public domain data sets as well as in-house generated data. The reason for doing that is that no single cell data set covers all the cell types present in glioblastoma due to technical issues. So the data sets that we included are one is the equilibrium data set from Allen Institute. The next two are the adult brain vasculature data sets, which were just recently published. These were using a newer technology for doing single cell sequencing of just vasculature. We also included data which is from GBM patients to specifically study myeloid cells and T cells. Also included are the microglia from adult brain with different neurological conditions, and glioblastoma data sets which had samples from both primary and recurrent tumors. We also had another data set which was generated by CD31 sorting of cells from GBM to enrich for GBM vascular cells. And then, of course, our own data sets, which is from the GBM core and periphery. Now, this shows the UMAP layout of our single cell data from 14 patients. Using a combination of published cell type annotations, clustering, and marker gene expression, we assign cell types to this data. So you can see largely there's oligodendrocytes, lots of myeloid cells. So you have the microglia, macrophages, monocytes. We also have granulocytes, then tumor cells, and lymphocytes. Now, some of the cell types that did not show good correlation to published data sets were labeled with SNM cluster numbers. And an example of that is some of the oligodendrocyte clusters did not match oligodendrocytes from other brain, and also some of the microglia which seem very specific in case of GBM. Now, we can also see that there are certain cell types that are present more in the core of the tumor than in the periphery. So the red dots here indicate the cells that were from the core of the tumor, and green dots indicate the cells which were from the periphery of the tumor. So you can see some expected results where the tumor cells are mostly from the core of the tumor. Hypoxic tumor associated macrophages are mostly from the core of the tumor. And we see some novel interesting things where these are the oligodendrocytes which are very specific to the core of the tumor. Now, once we had the single cell reference ready, we performed cell type deconvolution on our spatial transcriptome data. So we used TestVI, which is a tool for performing deconvolution of spatial transcriptomic data. What it does is it takes the spatial matrix, which is spots by genes with the 2D coordinates, and it takes a single cell matrix, which is cells by genes, where each cell is annotated, and you can know which cell type that is. So we then applied TestVI to our data set, and we were able to see the spots where specific cell types are present. So as an example, you can see the spots with neurons. It is a rainbow scale where red shows highest proportions of neurons, and as expected, we see them in the gray matter. So you can see these nice patterns showing up. And this shows the oligodendrocytes, and as expected, we see them in the white matter. Now, looking at the correlation of proportions of higher level cell types, we can see that we have two major clusters. One is where we have neurons, endothelial cells, pericytes, oligodendrocytes, microglia. There is another cluster is tumor cells, T cells, fibroblasts, monocytes, tumor-associated macrophages, granulocytes. They all form that cluster. So basically, it's the core and the periphery. So you see that nice correlation. Now, we wanted to understand the anatomic locations where each of the glioblastoma cell types reside. I already described the IV gap histology features, but we had another component to the IV gap study where we had cancer stem cell at risk. So this was done using the community curated glioma associated stem cell markers, and we used ISH to stain for those markers and then laser captured those areas to study them further. Now these samples were grouped into three categories: CT area with expression of one or more of the CCGFC markers, perinecrotic zone with expression of one or more markers, and areas around hyperplastic blood vessels with expression of one or more CCGFC markers. And the CT control samples are CT regions with the absence of one or more CCGFC markers. Now, these regions are very relevant as they strongly correlated to patient prognosis, and cells in these regions have been shown to be treatment resistant. So the plot here shows how different cell types are enriched in three distinct spatial locations. And you can see that perinecrotic zone is highly enriched for certain immune cell types, and perivascular niche is slightly different compared to the control, where you do not see certain cells. And mostly it is just astrocyte, oligodendrocytes, and OPC-like tumor cells, whereas in the hypoxic niche we have more of the mesenchymal-like tumor cells. So we get a really nice detailed view of these different niches. There are a lot more interesting findings as we start looking at cellular subtypes. I'm just showing one example with astrocytes. You have three different types of astrocytes. One mostly present in the white matter region, and second one is largely present in the border of white matter and gray matter, as you can see here. And then the third one is mostly in the tumor region. So you can see this is a very nice section where we have the gray matter, white matter, then the cell tumor. Another example is of the hypoxic monocyte-derived tumor-associated macrophages. These are found mainly in the pseudoparasitic area and to a lesser extent in the perinecrotic zones. We have additional insights into subtypes of T cells, microglia, and oligodendrocytes too. But to summarize, through this work, we have been able to catalog anatomic feature-specific cellular subtypes and identify cellular subtypes that co-localize. This is an ongoing project and the data is just 2 weeks old. So we are still in the process of validating some of these findings. We plan to use this information to design 3D cell culture models that will mimic what happens in the patient better. It will result in a more pertinent drug screening model. I would really like to acknowledge our team, Dr. William Park, Dr. Ranjang and Kim Yon at Samsung Genome Institute, our neurosurgeons, Dr. Chalki Park and his team, Daniel Chaudhary and Yunjong, who are students at Seoul National University Hospital, Pranali, who did part of the data analysis, Darshan Abhishek from medical analytics, Pershing Square Foundation for its funding and other philanthropy donors, and of course patients and their families. Thank you so much for your time. Since I'm not present there in person to answer questions, please feel free to reach out via email. Wish everyone a wonderful evening. Bye.
If there are any questions, you can reach out Namita through the email address which was given. So do we end the session with this? Thank you, everyone. Thank you, everyone, for attending today's entire day conference. And we look forward to, we have one more session after this, right? Okay. So we have a break now, and after that, we have another online virtual session. Thank you. Thank you.
Interesting sessions. Check. ಇದು ಲೈವ್ ಇದೆ ಅಲ್ಲ ಲೈವ್ Welcome again. So the last session for today is a virtual session. The first talk is from Dr. Pradipta Ranjan Rauta on nanotherapeutics, an insight into multidimensional applications in neuro-oncology. This talk will be followed by another talk by Professor Ali Asgar Moyadi, is a professor of neurosurgery at Tata Memorial Center, Mumbai. He will be talking on intraoperative ultrasound and its applications in neurosurgery. Now, the first talk will be from Dr. Pradipta.
Hello everyone, myself Dr. Pradipta Ranjan Rao, working as the assistant professor in the School of Biological Science at AIPH University, Odisha. It's the first public health university in the Eastern India focused on the public health strategy. And my area of work is developing the nano biomolecular approaches for disease therapeutics that includes both the diagnostic as well as the therapy. So today I will say some insight into the multi-dimensional applications of the nanotherapeutics in the neuro-oncology. Before going through that, we need to understand the nanomedicine and the important medical sciences. So nanomedicine seems to be very fascinating word which is used in the diagnostics, medical imaging, nanotherapeutics, vaccines, as well as the regenerative medicine. It has the wide application because of lot of favorable properties that can address existing issues with the drug delivery or therapeutic agent or life tracking. So in all ways, due to lot of favorable properties, this nanomedicine can be used. The first point is that nanomedicine means the medicine in the nanomolecular form, which is very small in size, and it has high surface to volume ratio. And it has the different functionalization characteristics. So a lot of favorable properties can make it used in wide applications in the medical science. So basically in the cancer, coming to the cancer, mostly it is used in the both the diagnosis as well as the therapy, where it can be together, you can call that cancer diagnostics, where it can track the progress of the disease after the treatment. So there are different forms of the nanoparticles can be used. I will incite some of my research where I have a small contribution to the nanotherapeutic in the cancer, in both diagnostics as well as the therapy. So if you compare the medicine with the nanomedicine, so what are the advantages here? So in the nanomedicine, it's a very specific, it has applications in the all area like nano-oncology, diagnosis, nanotherapy. So in all area, this nanomedicine has the advantages over the medicine, simple medicine in all area. Like you can reduce the systemic toxicity, you can have the targeted delivery, you can have the effective treatment at a lower concentration of the drug, so that drug effectivity and drug sensitivities can be enhanced. And also in the diagnosis, it can effectively diagnose in a very small number of cells that's been. So it has the bottom line is that nanomedicine has wider applications and lot of advantages over the simple medicine that can address existing issues with the drug delivery as well as the diagnostics and therapy. So these are the some examples I just want to cite how these nanoparticles have the application. Nanoparticles can be variety of types, polymer, metal, so it's a nanocomposite. So it has like the lipid polymer, it can be used as a drug delivery. In marketed, already clinically approved, few drugs are available where the liposomal drug delivery become the successful after the clinical trial. Like the metal nanoparticles, which has a lot of challenges to work with, but mostly these metal nanoparticles used in the diagnosis as well as now in the therapeutics also, but still a lot of issues like the systemic toxicity and the excretion issues in the body needs to be addressed with the metal nanoparticles. We have to use that as suboptimal concentration, but active with higher degree of effectiveness and as well as sensitivity. Like similarly, the carbon nanotube, the diamond nanoparticles used as the implants used in the drug delivery, and the last, the DNA origami. You know that how a large piece of DNA is arranged inside a small nucleus inside the cell because of this folding pattern of the DNA. So exactly this DNA origami can be encapsulated in a nanoparticle and can act as a molecular robot. So these are the wide applications. We'll little narrow down our area to the neuro-oncology. So if you'll see the history, this nanoparticle progressed in the nanomedicine, so it's very new. If you'll please see, this is the last 50 years data I just cited here, where the first up to the 1994-95, we are only conceptualizing the use of nanotechnology in the medicine, because the nanotechnology was restricted only to the physical and chemical science. And but in the biology, only we are thinking to use in the biology, but we are not able to use because of lot of issues that I will cite during when I discuss mine. But after that 20 to 30 year research, there are a lot of progresses with the nanomedicine, where in both diagnostics and the therapeutics, and now also we have clinically approved few drugs with nanotechnology approaches of the application as well as diagnostics as well as the therapy. So in the neuro-oncology, there are a lot of interest, a lot of scope, a lot of hope in incorporating this rapid advances in the field of nanotechnology, in the therapeutic strategy, as well as the diagnostic strategy in the neurological diseases like neoplasm. Some of the points I will discuss what I did in my research. However, the initial phase of this hope is tempered with a practical difficulty. What happens? This nanotechnology is not a single step process. It involves the preparation, formulation, functionalization. It has to be studied in the in vitro, and the translation of the exact positive results from in vitro to in vivo is a real challenge, because everything what the nanoparticles will behave very differently in the in vivo conditions. Even if it will pass the in vivo conditions, in the clinical trial also it's another big challenge. So translations from the clinics, from the lab to the clinics is very, very challenging in case of nanotechnology. And those points we need to discuss and address so that in next 20 years we will have a better position to use the nanotechnology in the neuro-oncology. So nanoparticles, there are various types, like I discussed, the polymers, metals, and it can be a composite and of various size, and various size of nanoparticles have also different type of applications. So it may be liposomes, it may be metals, it may be a polymer, and most important part is that it's surface. Its surface has a lot of functional groups, or you can add a functional group to which you can conjugate a drug, or you can conjugate a ligand, or you can conjugate an antibody to make it target specific. So functionalization, the surface properties of this nanoparticles plays a very important role in the nanomedicine. And when you want to target specific drugs, that you can conjugate a ligand receptor chemistry, you can use the ligand receptor chemistry, you can conjugate an antibody, it will bind to the specific site, or you can call the tumor site in a body. And due to very small in size, and it has larger surface volume ratios, and it may be the more nanoparticles to be used inside your body, it must be biocompatible, as well as it will be better if it is biodegradable also. It will not react with any components in your body, or it will reduce the systemic toxicity. So these are the characters. So this is the multi-step process, starting from the formulation, then the functionalization, then study in the in vitro, then in the in vivo. And particularly, there are a lot of scope to use this nanotechnology in the drug delivery. So what will happen is the particle size, which can be very easily manipulated, and there will be control and systemic delivery, sustainable delivery or sustainable release of the drugs to make the drugs very effective at a lower concentration. So that will reduce the systemic toxicity. And site-specific targeting can also amplify the nanoparticle-based approach, and better utilization and the less side effects. Various routes of administration, it can be administered by various routes. So there are lots of applications of this nanotechnology in the drug. Coming to my area of research, where I use some of these techniques, some of this nanoparticle-based approach in the nanotherapy. So nanoparticle-based drug delivery system to target a cancer cell. So we have we have made a pH responsive nanoparticle. So we have used two nanoparticles like a chitosan. Chitosan is a natural polymer. It can be, it is a biodegradable and biocompatible material, to which we have conjugated a drug like doxorubicin, and we have again conjugated with a ligand called the hyaluronic acid, and hyaluronic acid will bind to specific surface receptors like the CD44. This was one approach. We wanted to make a pH responsive drug delivery system which can act, which can effectively release at a particular pH. So if you will go to the cellular level, when a drug will enter, this nanoparticle-based drug will enter, it will be from the endosomes, and then from late endosomes it will go to lysosome. And the lysosomes, there are presence of the hydrolytic enzyme. So there is a chance that your drug will be degraded, or your drug will lose its activity when it will reach to the lysosomes. It will come across the hydrolytic enzymes present in the lysosome. So it will be better if you will design a drug delivery system that will cause the drug release at the late endosomal stage, or just beginning of the lysosomal end stage, then drug effectiveness will be higher, and we can achieve higher efficacy even at a lower concentration of drug. So in this concept, we have taken one model where we have taken chitosan as a key-sensitive polymer, where we have conjugated a drug doxorubicin by using the EDS NHS reaction, that is a chemist, that is a basic chemist work, where we conjugated one compound with another compound, and then we have conjugated again, coated with hyaluronic acids. And when you have injected this drug in intravenous, it will reach, it can cross the barrier, even it can cross the blood-brain barrier, and it will reach to the tumor site, and where it will release, when it will bind to the tumor site where the CD44 receptor is highly expressed, and HA will make this drug target specific, and when it will bind and it will release the drug at late endosomal stage, and drug effectiveness will be higher. And we have proved that using this concept, we have proved that in vitro and as well as in vivo, where the higher cellular uptake occurs in case of cancer cells, where in the normal cells there is no cellular uptake or minimal cellular uptake. So it is specific, the target specific we have achieved, and that will reduce a lot of side effects that we are having a foreign chemotherapy, where we are injecting a drug and it is affecting more to the normal cells rather than the tumors. So here, using this concept, using this nanoparticle-based approach, can make it target specific, and we can send our drug to the tumor cells. So another most important work where I was involved was the magnetic nanoparticles for cancer hypertension. Here we have iron oxide nanoparticles, and these iron oxide nanoparticles can be used as a imaging agent, and also when you will give a magnetic field, and this due to the oscillation of electrons from the lower to higher orbit, when the excitation of electrons from the lower to higher orbit, there will be generation of heat. Even if there will be increase of the heat 2 to 3 degrees, from 37 degrees to when it will achieve like 42 degrees, then all the cellular metabolism will be ceased and cell will be die. So the target is that you have to uniformly distribute these magnetic nanoparticles in the tumor area, and then you will give an external magnetic field, and in the external magnetic field, these iron oxide nanoparticles will be excited and will generate heat. And also you can track the progress of the disease after the hypothesis. So this is the combined applications, you can call this the theranostics. We have proved both in vitro and in vivo. We have synthesized the iron oxide nanoparticles and functionalized with OLH. The reason behind using the OLH is to make it biocompatible. Itself, magnetic nanoparticles may be not biocompatible inside of it. Basically, we are giving a folic acid coating, and as well as another advantages of folic acid coating is that we can functionalize it. So after functionalization with the OLH acids, we have done all the in vitro and in vivo experiments. First part is that we have done all the physicochemical characteristics like size, charge, its crystallinity, its functional group present on the surface. So all those parameters are very important while studying a suitable nanoparticles for the use in the nanotherapy. And in vitro also we have done the cellular internalization studies, where we have treated the folic acid coated magnetic nanoparticles and treated with the cells like the glioma cells. And we have then the stain with the Persian blue, and Persian blue will stain the iron oxides, where the iron oxide, we have detected the presence of iron oxides in the inside the cell. That means cellular internalization was able to achieve in our prepared nanoparticles. Similarly, magnetic properties we have studied, and also it is the MTT cytotoxicity studies, where we have found that the folic acid coated iron oxide nanoparticles are not toxic to the normal, to the NE cells. Only when it will be toxic when you will give external magnetic field that will cause the heat and that will kill the cell. And then we have also proved that in the in vivo study also. This is the 3 picture where the scanning electron microscope of the iron oxide nanoparticles that we have synthesized, and this is to study the surface morphology of the iron oxide nanoparticles coated with the OLAs. And second picture is that it says the successful internalization of the nanoparticles in the U87 glioma cells that confirm by the Persian blue staining. Persian blue stain will stain the iron oxide inside the cell. And we have done the in vitro test, and where we have seen that at the 50 microgram per ml solutions, and this is the 10 kilowatt for the 20 minutes treatment, the cell viability was reduced to 41% after 24 hours, then after 35% after 48 hours. So that means magnetic hyperthermia was working due to the successful internalization of the oleic acid coated iron oxide nanoparticles. So another approach I just wanted to study, that I was involved in the study of nanobiosensor. So we know that we need a good nanobiosensor where we can use for the diagnostic and we can use for the live tracking of the progress of the disease. So in that way, we have started with the concept that we use the gold nanoparticles because of their favorable spectral property. If you see the gold nanoparticles in the molecular form, it will be look like pink in color. When it will be aggregated, ONA 20 or 100 nanoparticles will be joined together and it will make the size to the micrometer, then the color of the solution will simply change to violet or blue or violet. And very similarly, there will be specific absorption maxima peak for the gold nanoparticles will also be shifted from red to or pink to blue or violet. Using that simple principle, we try to detect a specific cancer cells in a heterogeneous population. What we have taken here, we have also taken gold nanoparticles and we have functionalized these gold nanoparticles with a ligand called the hyaluronic acid, and we have taken the two cells where the CD44 positive cells and CD44 negative cells. So we have proved that these nanoparticles only bind to the CD44 positive cells, and when it will bind, it will change the color, as well as you will see there is a change in the absorption state. So this was a very nice results that were published in the Nature scientific report. And it's very simple technique you can use, or you can observe the presence of your interest cells in a solutions in a naked eye also, or by using a simple instrument like the spectrophotometer. You don't need to do the molecular genetic identification test or like that. So this is a very simple technique where these gold nanoparticles can be used as a nanobiosensor. And these are the series of experiments we have proved, where we have proved that in the successful identification of the interest cells in a heterogeneous population. Again, another one advantage is that when a nanoparticles, gold nanoparticles will bind to the interest cells and its size will be increased, its density will be increased, and if you give a centrifugal force using a centrifuge, and you will have different cellular fraction. So those are the positive cells bound to the nanoparticles. Due to their higher density, they will be present at the bottom of the tube, where those cells are not bound to the nanoparticles. Due to the lighter density, they will be at the top of the tube. In that way, we can also separate our cell of interest, and you can use or you can further culture in the lab also. And we did that test also. We have seen that survival of the after recovery also we study the survival and we are able to prove. So this was a very nice approach, a simple nanoparticle based approach you can use to detect a cell of interest, as well as you can separate with the viable, with a similar viability. So it is a very useful technique, can be used in the lab to study or to diagnose and to study the progress of the disease. And then another very simple is the passive targeting approach I worked, where only the difference of the pH will make a nanoparticles to deliver a drug. So what we have done, we have synthesized one peptide consisting of 2 amino acids, glutamic acid and lysine, and one is negatively charged, one other is positively charged. We tune like that when this peptide, glutamic acid, lysine peptide will change its charge when a pH will change from 7.2 to 6.8. So we know that the cancer cell extracellular pH is lesser than the normal cell. Using that simple concept, we designed our peptide so that when it will reach to the cancer cell extracellular pH, this peptide will change the charge from negative to positive, and we know that all cells are negatively charged. One positively charged has higher internalization capability or cellular uptake will be significantly increased. And we have tested, these are the characters, these are the characteristics of the peptides we have synthesized, and that comes from the successful of the conjugation of the glutamic acid on the lysine, and we have done the molecular weight characterization for the peptides, and we have also did the in vitro surface charge changes at different pH, and we have studied the absorption maxima change on the peak in case of conjugated and non-conjugated. And in vitro, we have studied the successful and cellular uptake of our prepared nanoparticles inside the cells, and also we have done the biodistribution studies, and we did study the systemic toxicity where we found that nanoparticles can be safely used. And another important thing we have proved that it can be a hypoxia targeted therapy. Hypoxia means all the cancer cells where the oxygen level is less, and which area is mostly the acidic in nature. So pH is reduced in this area, as I mentioned. So as the pH is reduced in that area, our peptide will be enriched in that area, and due to the change in the charge from negative to positive, so there's significant higher cellular uptake. Possible that we prove in the tumor also. In the picture you can see, those are the red in color of the nanoparticles. The fluorescent, we have tagged the fluorescent type, that the yellow color region are the hypoxia region, where the red points are the nanoparticles. So our nanoparticles are mainly localized in the hypoxia region due to the due to the acidity in the hypoxia area. So these are the few concepts that can be applied and can be taught, and we are doing more in vivo studies in case of glioma cells. So it can be do more number of tests and more vigorous tests in the in vivo, and it has to be translated to the clinic test. And few remarks and the conclusions. So we know that this nanotechnology we know, and we prove that it has the considerable capacity to develop a new and original approaches in the clinical approach. But however, while designing a nanocarrier, we must have to take into consideration a lot of factors. Like it has to be well characterized, it must be biocompatible and biodegradable, and must be soluble. Its solubility is also very important in the aqueous conditions and its circulating life period, and it is target specific, because when you are functionalizing a nanoparticle, there is a chance that you will get a functionalized nanoparticles and some impurities in there. So you have to take care of all those points while formulating the nanoparticles and latter part in the in vivo conditions. And most important is that potential toxicity. Systemic toxicity needs to be addressed, what we are observing in case of metal nanoparticles. Although metal nanoparticles have very wider applications in the therapeutics as well as the diagnostics, but it has the issue with the systemic toxicity. The potential toxicity issues needs to be addressed if you want to use this nanoparticle technology in the clinical level. And these nanomaterials offer a wide range of different combinations of the nanoparticles. Then due to these combinations, we can make the combination, but we need to keep in mind that in the end, it can vary from batch to batch. It can from simple to assemble. It have a lot of side effects or a lot of characters may be changed, and it has to withstand the rigorous clinical test. And we need to develop the protocols where we can maintain the similarity between the batch to batch while in the formulation study. And finally, its impact on the environment needs to be addressed, which is very much important to study, to use broadly the nanomaterials. So its impact on the air environment needs to be carefully determined and thoroughly assessed. Thank you.
Good day. Talk that I'm going to present in the next 15 minutes is going to encapsulate good day. Talk that I'm going to present in the next 15 minutes is going to encapsulate the benefits of using intraoperative ultrasound, its rationale for use and its practical utility and benefits, especially in glioma cell. These are my disclosures. Now, gliomas, we all know and understand, they come in different shapes and sizes. They have high-grade, low-grade gliomas. What is common to all these gliomas is that the outcomes depend on certain prognostic factors. And these, what I have enlisted here, are common prognostic factors: age, performance status, Karnofsky performance score, molecular profile, which is becoming increasingly important these days. However, if you realize these three factors are innate or inherent and can't be changed, what can be changed is the treatment that is offered to gliomas. And this includes adjuvant therapy, but more importantly for us neurosurgeons is the resection that we are offered to these patients. And that's the extent of resection, which we always try to maximize. And I think there is no controversy now about the role of radical surgery in gliomas, be it high grade or low grade. However, this is easier said than done. What happens actually during surgery? You see these nice gliomas easily delineated on MRI, but when we open up the brain, this is what you're encountered with. Everything looks normal. And it is a dilemma where to enter the brain in order to start your resection. And this is compounded by the fact that the brain is a highly eloquent structure. There are eloquent substrates, cortical and subcortical, in the region of exposure, and you don't want to jeopardize any of them because often any mistake leads to irreversible neurological deficits. And therefore, it's no surprise that surgeons usually do not estimate the extent of resection correctly. Now, this is an important point that we all need to understand and accept. Generally, surgeons tend to be overconfident and assume that their impression is usually correct. And considering the fact that extent of resection is an important prognostic factor, our ability to measure that extent of resection intraoperatively is also very, very important in order to optimize the surgery for gliomas. However, studies, and this is one study that I've quoted, showed that even when surgeons estimated a gross total resection, MRI demonstrable tumor was seen in almost 70% of cases which were operated. Not only that, but what was also seen was that actually gross total resection was achievable in just 1/4 of the patients which were potentially resectable. What this means is that what is the planned extent of resection and the actual extent of resection usually is discordant. And why does this happen? Because we know that gliomas are infiltrative, are not easily visible, boundaries are not delineated, and therefore in order to aid and augment human capabilities, you need some kind of adjuncts to help you maximize that. And when we talk of adjuncts, you have two sets of adjuncts, those which help you maximize the resection. And we'll talk briefly about all of these. And at the same time, those which help preserve function. And we will not be dealing with these right now. The adjuncts which help you maximize resection, and we will be restricting our discussions to gliomas. First of all is navigation or image-guided surgery or frameless stereotaxy, whatever you call it. And this all of us know has been used in neurosurgery from a long time. It's like a GPS system. I don't think I need to explain that to neurosurgeons. However, what we know is that navigation based on preoperative MR imaging for glioma surgeries is useless except for planning the craniotomy, because once there is deformation of the brain and a shift, all the accuracy of the preoperatively acquired images is reduced to almost zero. And you need some kind of intraoperative updates by using intraoperative imaging. The gold standard, of course, is intraoperative MRI. That's what gives you the best resolution. That's what all of us image brain tumors with preoperatively, and therefore why not have that intraoperatively? And it has been shown in studies to be very useful in improving rates of resection. However, what is important to note is that there are logistical challenges in actually implementing intraoperative MRI. Long acquisition times, which means surgeries get delayed, extremely costly to install, logistic challenges in getting the scans, having trained manpower to do it and interpret the scans. And this makes the availability of intraoperative MRI very, very limited. We don't have intraoperative MRI and we don't have the luxury yet. And this brings me to the topic of our discussion is intraoperative ultrasound, which has been actually one of the oldest modalities of intraoperative imaging, which have been used in surgery in general and neurosurgery in particular since the 1950s and 60s. This is readily available, easy to use, it's highly underutilized in neurosurgery. And we need to understand, and I hope at the end of this talk you understand what are the benefits of intraoperative ultrasound. Now, taking you back in time, in the 1980s and 70s, these were the kind of ultrasound machines which were available. They were cumbersome, heavy machines. The probes, as you can see them here, were also very, very big. And the image resolution of these machines was poor. Nevertheless, early workers in this field of intraoperative ultrasound painstakingly documented techniques, parameters of acquiring a good ultrasound, and even documenting ultrasound anatomy and pathology in brain tumors. And mind you, this is all work done by neurosurgeons, because radiologists themselves hardly have the chance to peek into the brain with respect to ultrasound, because they never do ultrasound. Since then, over the last decade especially, there have been an exponential advances in the technology of ultrasound. You have much, much sleeker machines which have the latest technology specifically tuned for cranial and spinal insonation. You have wonderful probes which are well suited for cranial applications with smaller footprints, either for burr hole or for craniotomy. And certain very unique probe designs like this hockey stick probe, and these are all BK probes, which is the machine I think you'll have. This probe, though it's not CE marked, can be used for intracavitary applications, and it's a high resolution linear probe. Not only are the probes much more customized and suitable, but the interface with the machine has become much, much more user-friendly over the years. And this is the controls, or what we call as knobology, which is something which an ultrasound user has to be acquainted and familiarized with, because it is important to understand the functions that you're going to use, because you are the one who are going to set it. And depending on how well you set it, you will get a good image or a bad image. With this latest ultrasound advances, this has actually thrown open the field of intraoperative imaging and has made the ultrasound foray into different applications in neurosurgery. Most importantly is tumor surgery, where it's useful for localizing tumors and biopsying them, or even for resection control, which I will talk about a little in detail. In vascular surgery, by virtue of being able to do angiograms, endoscopic surgery for guided placement of catheters in the ventricle or tapping of cysts, and even in skull base and spinal surgery. The list is endless, and it just depends on the inclination of the neurosurgeon in applying this technique. With respect to tumor control, tumor resection control, if I were to compare the ultrasound with the intraoperative MRI, and this is actually a very relevant comparison to make because the intraoperative MRI is the gold standard. There is no doubt that the intraoperative MRI scores higher in terms of image resolution and orientation because it provides a full head view. However, intraoperative ultrasound can be as good as the MRI in terms of image resolution. And if combined with navigated ultrasound, it also actually eliminates a lot of problems with the orientation that ultrasound traditionally tends to have. Coupled with that, the logistical ease of doing quick scans multiple times during surgery without affecting the workflow of a surgical procedure and without too much strain on the resources, both financial manpower of the hospital or the operating room, it makes it a very attractive intraoperative imaging adjunct. The caveat is that it remains operator dependent, both the acquisition of the scan as well as the interpretation of the anatomy, and therefore it needs a little bit of training to shorten the learning. What is the evidence to support the use of intraoperative ultrasound in tumor surgery? And there is a lot of literature, but I will talk of a couple of relevant papers here just to show you the proof of principle. So this is a paper from the group in Trondheim in Norway, who have been pioneers in the field of intraoperative ultrasound, and specifically navigated intraoperative ultrasound. What they've done is that they have, and this is an old study 15 years back, where they used 3D ultrasound in order to correlate the ultrasound finding with pathology in different types of intraxial tumors, high-grade, low-grade gliomas, and metastasis. And this was what they did. They compared the intraoperative ultrasound finding with the MR and MRT1 and T2 findings. Mind you, these MRs were preoperatively acquired and they were imported into the navigation system. So keep that in mind. And what they did was they compared biopsies from each of the sites where they took snapshots and they recorded the ultrasound finding and the MR finding. Now these bars show the correlation between each imaging modality and histology for different tumors. Black bars show the concordance between the imaging finding and the pathology, which means in ultrasound, there was 70% concordance with the ultrasound showing tumor and the pathology confirming tumor for low-grade gliomas, compared to just 60% with MRT2 and much lower for MRT1. And across tumor types, you will note that the ultrasound actually showed better concordance with pathology than the preoperative MRI. Now, you might turn around and say that this was preoperative MRI, so there must be brain shift. Yes, of course, that was an issue. And then there is this study which has been published more recently, 5 years back, which actually compared ultrasound with intraoperative MRI. They also compared it with ALA fluorescence, and this was in glioblastomas. And again, here, if you just look at this first row, the accuracy of ultrasound is much higher to predict solid tumor intraoperatively than both intraoperative MR and ALA. And negative predictive value is as good as ALA, with intraoperative MRI surprisingly not showing the same results. This is one study, but there are a few others. And of course, I'm not trying to say that it's better than intraoperative MRI, but it is at least as good and practically useful. In our own experience, we found this extremely useful, not only in detecting the residue, but at different stages during the surgery. It's extremely helpful, makes it more comfortable, gives you confidence, whether it be localizing the lesion, delineating its extent, reconfirming it, reassuring the surgeon, and identifying important anatomy close by so that you don't get lost or disoriented. And we've used this extensively in gliomas, We found it very useful in improving resection rates in malignant gliomas, especially in non-enhancing gliomas. And what we've seen in enhancing gliomas is that it helps us improve resections beyond the contrast enhancing margins. And in GBMs, we've even noted improved survival when we've used this. And this is probably a function of the extent of resection. Now, but the ultrasound lends itself very well to be integrated into multimodal glioma surgery, whether it be with ALA, whether it be with awake surgery, which unlike intraoperative MRI may be a little more cumbersome and challenging, especially awake surgeries. The cornerstone or the bottom line for getting good results with intraoperative ultrasound is to be able to get a good ultrasound image, because that is what you're going to be interpreting. And it's no surprise, the study showed that whenever the quality of ultrasound images was good, then the survival was better. And this is probably because of the better action that the surgeon could take based on these images. However, we agree and we all admit that there are challenges in getting a good ultrasound image, and a lot of us get dissuaded and feel dissuaded from using this because of the poor quality scans that we get. And there are certain important hurdles that we need to overcome in order to optimize these. A lot of the limitations are operator dependent. It's related to the neurosurgeon not being able to optimize these resection, the ultrasound acquisitions. And a lot of it is because of the unfamiliarity with the machine. Both these are correctable and can be corrected by adequate training. And this is what we do during courses. And this was one of the courses we had done in the pre-COVID era. That the training is important in order to be able to optimize an ultrasound scan, and the 2D ultrasound scan is the bulwark or the basic ultrasound technique on which all other applications of ultrasound are based. There are certain, however, limitations of 2D ultrasound related to the unconventional planes of imaging and the limited field of view, which cause a lot of disorientation. That makes it difficult sometimes to interpret serial scans. This is where navigated ultrasound helps. And navigated ultrasound is basically nothing but ultrasound combined with navigation, such that 3D volumes are actually tracked by the navigation system, allowing you to get the best of both worlds. It helps you prove orientation because of image co-registration, and multiplanar image display allows serial display of ultrasound scans done over a period of time and helps you orient each to the other. It can also help functional information because you can get it from the MR which is fused with it, and can help you compensate for brain shift. But remember that even the navigation which when added to the ultrasound, though it improves orientation, it cannot improve the resolution of the image per se, because that is the basic ultrasound image that you've acquired, and therefore optimizing the ultrasound image is the key. If I were to give you a matrix, image guidance intraoperatively has many components. Navigation has its own use, and the 2D ultrasound by itself is very useful. But when combined with navigation, it actually extracts the benefits of both these modalities and makes it a very useful tool for intraoperative guidance. The utility of the ultrasound is in minimizing errors, inadvertent errors during surgery. Sometimes you cannot see tumor, either the boundary is not delineated or there are hidden important structures, all can be picked up. Missed residues in blind corners can be picked up, and you can evaluate the post-op status on table. Of course, it does not help you in planning the craniotomy, but when you combine it with navigation, that also can be done, and navigated ultrasound takes all. So remember, it's a very useful, easy, quick, and safe, inexpensive method of doing intraoperative imaging. And it's ideal actually for surgical setups. But remember, it's just one of the tools at your disposal. Use it completely and complementarily with other tools that we described, because using them judiciously will give you the maximum benefit in glioma surgeries. Thank you very much.
That was the last talk of the day. With that, we conclude the last virtual session, and we'll break for today. Please join us for fellowship and dinner.